still need to manage the patient. We still continue to manage the patient. When the blood pressure, when the patient continues to bleed in the brain, there can be increase in intracranial pressure. So therefore, we have to avoid anything that increases the intracranial pressure. Do not use 5% dextrose, use only normal saline. Don't overhydrate them, give them the minimum requirement for hydration. Keep the head end elevated. Avoid putting ligatures around their neck and blocking their venous flow. If they are febrile or temperature is more than 38, which could be because of the bleed itself, start paracetamol. If monitor the sodium and do it equally every 6 hours kind of, and if it is less than 132, inform your seniors. We might have to give them 3% saline. Continue to monitor this man who has had a bleed in the brain, ideally every hour until he's stable. You can use the Glasgow Coma Scale, or you can check them clinically, looking at the pupil size, light reflex, and look at the cranial nerves. See whether the patient is becoming progressively drowsy. Look at the Cushing's triad, bradycardia, hypertension, respiratory depression. Look whether the person is having new focal symptoms, because this might be related like ptosis, gaze palsy, hemiparesis, decelebrating posture, because when the intracranial pressure rises, they will decelerate and they will have a respiratory arrest or a cardiac arrest. If the patient is deteriorating, repeat the CT scan, rediscuss with the neurosurgical team to see whether they need to intervene now. For both categories of patients, they have a higher risk of aspiration pneumonia. So therefore, we need to make sure the swallow is assessed. There are trained nurses who can do that, but it's not bad idea for you to know how to assess the swallowing as well. To do this, the patient should be conscious and not drowsy. You have to get the patient seated upright, positioned very well, and give clear instructions. Give them a water, a teaspoon of water, and talk to them. If their voice has changed, sounding like wet, if they're coughing away, spattering and pooling, drooling, and if there is water inside the mouth, especially within the buccal mucosa, that patient has evidence of aspiration or not safe to take anything orally. If that is successful, try with a little bit more, and then try with a little bit more, maybe through a glass of water. If swallow is safe, continue to take give oral feeds and medication. If unsafe, for 24 hours, we can manage with IV fluids. After that, we need to put an NG tube for nutrition and to continue medication. Refer to the speech and language therapists, get the help of the dietitian, and make their nutrition well. In your next day ward round, evaluate the patient, see whether there is a neurological improvement, worsening, or it's the same. Check the blood pressure, check the blood sugar, look for evidence of aspiration pneumonia. Has they been positioned well, or they are developing orthostatic pneumonia? Has they required a hospital-acquired infection? Look at their carbs, are they developing deep vein thrombosis? Look at the medication, see whether you have stopped all the necessary medication and started the ones that you have to do. Are there any additional investigations you have to do? You might have to do a carotid Doppler in this patient, might need a Holter monitor. In a younger patient, you might have to do the Young Stroke Street. Check whether they are eating and drinking well. Are they continent in bowel and bladder? Is the skin intact, or they are developing pressure sores? Carotid Dopplers are done for people when the affected area is in the carotid circulation or anterior circulation. So, and this is also not done for all patients. We do it for patients who have non-disabling strokes or a TIA. If it is a dense disabling stroke, we have nothing to gain by doing a carotid Doppler and sending them for carotid endarterectomy, because it's now too late. If the ECG was in sinus rhythm, we have to do a Holter monitor. Longer you do, the better, to detect paroxysmal atrial fibrillation. This is a list of post-stroke complications: aspiration pneumonia, recurrent stroke, malignant MCA, seizures, pressure damage, deep vein thrombosis, pulmonary embolism, post-stroke headaches or joint subluxation, post-stroke depression, and infections, especially hospital-acquired ones, cannula sites or catheter associated. When you're walking about in the ward round, especially if your patient is unconscious, see whether they are positioned well so that they don't get any pressure damages in their weak side or don't have joint subluxations. We use the principle neuroplasticity in stroke rehabilitation. The brain can form and recognize synaptic connections, especially in response to injury, to learn and to improve. So that is done in a team: physiotherapists, occupational therapists, speech and language therapists, clinical psychologists. We have continent nurses, orthopedics, and dietitians in a good MDT team, but we might not have all of them. It's when the patient completes their rehab and they plateau and that's time for them to go home, it's your duty to write a good diagnosis card. Do a diagnosis card that you will be one day proud of when you are a registrar or a consultant and you see the diagnosis card you did. Put all the details of the stroke. When did they have the stroke? Which side of the brain was affected? What disability was there on admission and what was there on discharge? What was his risk factors? What treatment was given? Whether they was thrombolized, loading aspirin was given, or whether the oral anticoagulant was reversed. Discharge medication, document them very clearly. And this man is a cyclist. I did tell you that there is a risk of them having recurrent stroke. This risk is higher during the first month. Therefore, we advise, and it's a requirement to tell them not to drive, even if they completely recover in the first 1 month. Afterwards, if there is ongoing disability, they will have to face another driving test or a cycling test before they start mobilizing. Do the follow-up, tell them when to be seen by the medics, rehab, if they are having pressure damage, the pressure care, catheter care, and the NG tube. If you're sending them with the NG tube care. Thank you. If you have any questions, I think I have about 5 minutes. I can try to answer.
Right. Thank you very much, madam. If you all have any questions, please can take this time to ask. There are about 5 minutes more.
Shall I stop sharing, Roshan? Yeah.
Yes, madam. Yep.
I suppose it's probably too early for you all. Something that, okay. Yeah, you can get your presentation. How do I give it to you? Roshan can send it.
Yes, madam. Most of these recordings will be shared with them in the latter part of the sessions. So they will have to answer MCQ and they need to get a certificate for the internship. So we will share this recordings with them. In the meantime, also this is being broadcast in the YouTube, so they can go visit the link and they can recap.
Okay, Charita, I hope you got the answer for that. Madam, if TIA, we continue clopidogrel and aspirin 21 days. Yes, that is because of a trial that we have come. So actually, when we examine patients, we do the neurological traditional way, but we also have another scoring system that we call National Institute of Health Stroke Scale. So if the weakness is less than 3, what we are told is to the trials, I can't remember the name of the trial, has said we have to continue dual antiplatelets for 21 days, that is aspirin 75 and clopidogrel 75 for 3 weeks. And thereafter, we can continue it, the clopidogrel will be long term. So initially we are told not to give aspirin monotherapy is now discouraged. But if the weakness is more than NIHS 3, we think the lesion is too big and there can be hemorrhagic transformation. Therefore, we do not introduce dual antiplatelets. We just tend to go on one. Danuka Darshana, hope I answered your question. So that kind of things, it's always better for the seniors to make that decision, because at the end of the day, they are the ones who are taking risk. As for you, if it is ischemic, give the aspirin as soon as possible. If they are thrombolized, we give it after 24 hours and wait for the seniors to advise you. No, there is no time period to do a non-contrast CT scan. CT scans are done to exclude a hemorrhage in the brain. Blood appears very soon in the brain, and actually non-contrast CT scans are better recognizing new blood than even an MRI scan. So there is no time period. We do it as soon as possible because if it is ischemic, we have to give aspirin. Aspirin is the only thing that will prevent the thrombus propagating. So we give aspirin as soon as possible, or if it is mild, we can give aspirin and clopidogrel loading. But there is, as soon as possible, we have to do. And if the patient is on oral anticoagulant coming after a fall or something, then we are expected to do the CT scan within an hour is the ideal, nice guidelines, because they can have a subdural and they can be bleeding. And then again, we have to do that's beyond the scope of this thing. But if anybody, when you are doing internship, comes on oral warfarin and has had a fall, and there are not only warfarin, there are newer ones called apixaban, rivaroxaban, edoxaban, any of those things, you should be asking for a CT scan to exclude a brain. It could be a subdural, it could be ICH, so we need to do a CT scan. So is there a time period? No, there is no. As soon as possible, we need to do the CT scan because we are looking for blood and we are not trying to diagnose a ischemic stroke on the CT scan, because if the lesion, especially if it is in the internal capsule area, they can be very small and we can miss it in the with the cuts we are doing. We do 0.5 millimeter cuts, we can miss them. MRI, so if your CT scan is completely normal, we don't know, we need to, so we don't know whether it's a stroke or a TIA. If you have the facilities, it's always better to do an MRI scan. There are other things that what I will, a consultant will, or a trained person in stroke will be looking in an MRI. There's a new thing that has come as amyloid spells. That might be actually a bleed. So MRI has a place, but it's expensive and it's not freely available. But if you do a good CT scan and look for bleeding, superficial or deep, that is very good as well. So, madam, what is the place of MRI? That is actually when you go to tissue-based diagnosis, they recommend, especially for TIAs, to do the MRI. But for us, its availability is a problem. I hope that explains, Darshana, your question. It's 8:30. Anybody else has any burning questions? In hemorrhagic stroke, what about the hydration? Can you explain again that part? So if there is a hemorrhagic stroke, we don't want their ICP going, intracranial pressure rising. So we do not use 5% dextrose because the edema will worsen and the ICP will go up. We use normal saline or maybe 3%, but 3% wait for your seniors to tell you. Hydration also, if you overhydrate them, there can be cerebral. So what you give is a little bit under hydration or the adequate amount, because sometimes we have to do contrast CT. So you have to look after the kidneys as well. And the blood pressure, if it is very high, we have given IV antihypertensives and brought down the blood pressure. That will have a knockout effect on the kidney as well. So we have to hydrate. We can't dehydrate them, but don't overhydrate them. That is what I said. So sodium, we need to make sure that the sodium is normal. So initial sodium can be normal, but then you can have a SIADH setting in. So there you should always repeat sodium. And if it is less than 135, inform your seniors. They might want to start on 3% saline.
Right. Thank you very much, madam. That is Dr. Anuja Rajapaksha, consultant physician. Apparently, madam is also in the core group that is preparing stroke guidelines with the Ministry of Health. So, as a best person to get advice from stroke. So, thank you once again, madam. So, if you have any questions,
thank you.
We can chat on the chat box. So we go to the next lecture by Dr. Ravi Disanai, consultant physician on the initial management of seizures. Thank you.
Good morning, Roshan.
Yes.
Can you hear me?
Yes, we can.
I'm trying to share my screen.
It's okay, sir. You just have to make it full screen. That's all.
Right. Okay. Is it all right now?
Yes, sir. Yeah, good to go.
Right. Good morning, everyone. I'm Ravi Disanayaka from New Delhi. I'm going to talk to you about acute management of seizures. Before going to the acute management, I'll be just touching on a little bit of definition and description of seizure, classification, etiology, just to recap, and then a bit on the differential diagnosis, just to get you, because you are the first person or as an intern medical officer to see the patient. So it's important to diagnose the seizure correctly before you go on to the acute management, and then the process of diagnostic evaluation and initial steps in acute management. All right, what's the definition of a seizure? A seizure is considered or defined as a paroxysmal uncontrolled discharge of neurons in the brain, which interrupts the normal function, because, you know, as neurons always discharge, so they have electrical activity, but when it goes uncontrolled and paroxysmal, and then it interrupts the normal function. That's where a seizure occurs. Usually this is a symptom, not an illness as such, but it's a symptom of an underlying condition. So then what is epilepsy? So epilepsy is defined as a recurrent seizure disorder when it occurs repeatedly, or the seizures occur recurrently and characterized by this abnormal discharge from the brain, particularly in the cortex, which is considered epilepsy. So the other definition is a chronic seizure disorder with recurrent unprovoked seizures is epilepsy. So when you consider a seizure, there are 4 phases described. Those are the prodromal phase, oral phase, ictal phase, and the post-ictal phase. I'll come one by one. The prodromal phase is where you don't get any sign or any evidence of any activity, but this precedes all the other 3 phases. And then comes the aura, which of course the patient will experience as sensory warnings, certain sensory warnings, not in every case of seizures, but certain seizures will be having a clear oral phase where the patient gets these abnormal sensations, which I will be touching on later. Then comes the ictal phase, what we call the full seizure activity phase, where the patients can get muscle twitching and all the abnormal movements of the body, which again I will describe in the next few minutes. And then followed by the post-ictal phase, where the patient kind of goes through a rest and a recovery phase. Okay, so going on the stages of seizure, the prodromal phase is not a stage of seizure. However, the aura to the post-ictal phase is considered the stages of seizure. So it starts with the, you can see on your left, the aura, where the patients can get this hallucination, confusion, and feeling dizzy or lightheaded, and certain distorted emotions. Sometimes patient might not be able to put it into the words, but they will explain they were feeling unwell in certain undescribable way. So they can have certain sensory symptoms such as numbness. This, of course, might last for minutes. And then followed by a tonic stage, where you get this muscle stiffness mainly causing stiff body, and they can get some incontinence, particularly urinary and fecal incontinence. And sometimes they make a noise, what we call an epileptic cry. And because of the spasm, patients, the posture can, like back arch posture can occur, not in every case, but in most patients with generalized tonic-clonic seizures. Well, the tonic phase is followed by a chronic stage. Again, the tonic stage can last up to minutes, and then the chronic stage where the patient's muscle clonus or jerky movements occur, and there can be blinking of eyes, frothing of saliva from the mouth. So that is chronic stage, and that can last again usually to minutes to sometimes even up to hours. And the post-ictal phase, which is what I described, the recovery kind of phase, patients could be very drowsy or sleepy because of the muscle chronic stage. They prolong, if there is a prolonged chronic stage, patients feel weak for long period and then exhausted. So those are the stages of seizure. Little bit on the classification or the types of seizures. This is the classification by the International League Against Epilepsy in 2017. So they describe seizures mainly. You can see the blue blocks in the middle, which describe the seizure types, basically focal and generalized. Focal means the seizure or the tonic-clonic phase or movements occur in certain part of the body only, whereas if it occurs in the whole body, it's called generalized. There are certain other categories which are classified as unknown. You don't have to touch on that. And then when it comes to epilepsy, the same thing again applies, the focal epilepsy, generalized epilepsy, and there can be instances that you can see the purple box in the epilepsy box, which is combined generalized and focal epilepsy. So there can be patients who get kind of focal epilepsy for focal seizure going into generalization. So those are the different category, and then the other unknown category. And you also can see a green box down there, and it is called epilepsy syndrome. The certain patients will have a certain type of epilepsy, which is classified in epilepsy syndromes, which is beyond today's talk anyway. A little bit on the etiology, you can see on the right side, there are a few listed, about 6 causes of seizure or etiology, mainly the structural lesions in the brain. There can be genetic causes or genetic conditions, and CNS infections, metabolic causes, and then immune-mediated causes, and certain seizures. We probably will not be able to find a cause where we call it unknown. So moving on a little bit more on the etiology. So the commonest is what we call idiopathic epilepsy, where you see particularly this occurs early in life. So the epilepsy starts before the age of 20 years. And between that period up to the 20 years, you can see like basically 2 peaks of occurrence, the first year of life and then towards the onset of puberty. So you see most people getting this idiopathic epilepsy before the onset of, or before the age of 20 years. And more out of those lot, mostly first year of life or during their pubertal age. So other etiology factors I mentioned earlier, also the genetic factors, which are inherited conditions, and then the certain structural illnesses which occur in the brain. Just now you had a talk on the stroke. So the CVS and strokes is a known cause of or seizures, and then the brain injury due to hypoxia, certain structural lesions, particularly the tumors, intracranial infections, and then the damage to brain due to trauma or head injury. Those can be implicated in seizure. And then certain environmental conditions, particularly pollution or carbon monoxide, lead poisoning, and that has been listed as a etiology. And then intrauterine infections or infections which occur during the pregnancy or the intrauterine life. And then certain emotional disturbances and environmental stresses can predispose to seizures. And also one of the other common things you will come across during your internship and even after is drugs and alcohol, particularly with intoxication as well as withdrawal. So going into the differential diagnosis, because when you're assessing a patient with suspected seizure, you got to know what are the mimics of seizures. So because the patient won't come with a label of saying, I'm having a seizure. So you got to assess the patient. You are the first man or woman to see the patient as a medic. So the first thing you have to differentiate is whether it's a pseudo seizure or a true seizure. Pseudo seizures, also known as psychogenic non-epileptic seizures or PNES. So that is the most common differential diagnosis. And the second common would be the Syncopy. And certain other listed also can occur or come as seizures. See certain sleep disorders and then hyperperfusion in the brain, cardiac arrhythmias, and then emotional outbursts, drop attacks, migraines, and then hypoglycemia can produce seizures or seizure activity. So those are the main list. And when it comes to the pseudo seizures, you got to know how to differentiate. So this is the comparison between the psychogenic non-epileptic seizures or pseudo seizures with true epileptic seizures. So you can see the listed 10 parameters. I have listed about 8 clinical signs and 2 laboratory tests. So the mid column says the pseudo seizures, and the right column is which is the true seizures. I'm sorry, this slide appears a bit crowded, but I will just go through one by one. So if you see the eyes, behavior of the eyes, pseudo seizures, usually the patients will have open eyes, whereas true epilepsy, their eyes are closed. And then the weeping, so the pseudo seizure patients commonly get weeping, but whereas true epilepsy, you won't get patients weeping. And the ictal movements or the jerky movements which occur, those are stereotyped with a clear start and a stop in the true seizures, whereas the pseudo seizures, they are not really coordinated, they are not multiform, they can come and go like waxing, waning. So it's not very stereotyped, and there's no clear onset or a clear stop as a true seizure. Then the ictal stuttering and post-ictal whispering, again, which is seen in the pseudo seizures, but in true seizures, you won't see that. And again, with the ictal hyperventilation, with this jerky movements and ictal phase, the patients will be hyperventilating in the case of pseudo seizures, whereas true seizures, you won't see hyperventilation. When it comes to post-ictal phase, there are a few things which, again, compared to pseudo seizures, epileptic seizures will have, like post-ictal cough, nose wiping, and this noisy stertorous breathing, which is a noisy breathing which comes from the nose because of the congestion after a seizure, is common with the true seizures. You won't see that cough and then stertorous breathing in the case of pseudo seizures. This is, mind you, after the ictal phase, post-ictal. However, there is post-ictal superficial breathing or rapid breathing occurs or seen with the pseudo seizures, whereas epileptic people, post-ictal phase, you won't see that kind of rapid, shallow superficial breathing. So those are the features you can use to differentiate whether the patient's got a true seizure or a pseudo seizure. And then the laboratory testing, usually which of course will not be really available for most people at the moment. However, it can be used with lactate levels and the prolactin levels. Prolactin levels, of course, not commonly available immediately, but lactates, if you have access to blood gas, you can get that. In a case of true seizures, you can get lactate and prolactin going up, whereas pseudo seizures, you won't see a rise in lactate or prolactin. Little bit on comparison of seizure with syncope, which is the next common kind of presentation or differential diagnosis. In a patient with a seizure, you will get this classic tongue bite, particularly on a lateral side or sides of the tongue or laterally. And this sensation of déjà vu sensation, that is, you have the patient would describe that felt the same thing before, experienced the same thing before, whereas it has not happened. Then they will have this head turning to a particular side during the spell or head turning, which is uncommon with syncope. And then seizures sometimes can be precipitated with this emotional stress. And they will have this unresponsiveness or unusual posturing with jerks, and then the postictal confusion. In the case of syncope, they will have this common feeling of lightheadedness before this event, and then associated sweating during the episode. And also there will be history of either prolonged sitting or standing. So these parameters can be used to differentiate. And there is this scoring system, which of course is more study oriented or research oriented calculation to see whether this is true seizure or a syncope. So there are points given to each and every item, and then finally score is considered, use the score to assess whether it's a syncope or a true seizure. So if the patient has had a lateral tongue bite, the patient would get 2 points with déjà vu sensation, that again plus 1 point, and emotional stress associated 1 point, head turning again 1 point, and this unusual posturing and jerks 1 point, and the postictal confusion 1 point. Whereas lightheadedness, sweating, and prolonged sitting get -2 points each. So finally, if you sum up all that, and if the score is one or more points positive, then of course it's more towards a seizure, epileptic seizure or true seizure. Or if it is less than 1 or 0 or minus, then of course it is considered a syncope. So moving on to diagnostic evaluation, again, the basics in medicine, you have to take history and examination, and then going into investigations. In the case of seizures, it's the history takes a majority or the major part of it, a complete seizure profile, what happened during the event. Ideally, if you witness the event in front of you, it would be the best explanation. However, the most patients will not come that way. They will come with a history of seizure or what looks like a seizure. Then, of course, best would be to get somebody eyewitnessed. Or nowadays, you can even ask people to get a video recorded if they have carried their mobile phones with the video facility. So that would be a best explanation. And so you do have to take a complete history with his background and how it occurred and what time and duration and everything. And then moving on to physical examination, you have to do a full neurological examination and also document the description of seizure activity. Going into the diagnostic investigations, the EEG is the kind of initial or major test which we do. This is interesting to see the location of the abnormal electrical activity in the brain. So the electroencephalogram will tell us whether there is abnormal electrical discharges. So that is important to establish the abnormal electrical activity during. Ideally, you should do we usually do an interictal EEG, what we call not during the phase of seizure, but then normal stage. So that sometimes will show us electrical abnormalities, but ideally would be to get the ictal EEG, which is of course not easy unless the patient gets, and then you have facility to do video recording together with EEG. That would be the best way to get the diagnosis. So it is useful again in identifying the specific type of seizures, because this electrical activity would give us clue to diagnosis. Excuse. Hello, online. Online. I'm online. Sorry about it. Then moving on to imaging, mainstay would be to do CT and MRI, which is fairly available in the country, and then the next level would be to do the positron emitting tomography, or SPECT, single photon emitting computed tomography, which are not really easily available for us. So the CT and MRI, again, to rule out brain structural lesions, including tumors and bleeding. Then the laboratory studies are to rule out other causes. As I mentioned, the hypoglycemia, so you have to do the random blood sugar. And also the full complete blood count, renal and liver profiles. And you might have to do a lumbar puncture in the case if you suspect any CNS infections or CNS infiltrations. And then any patients who were previously known to have epilepsy and also on medications, you might have to do the anti-epileptic drug levels, ideally, to see whether they have had enough levels or they were like underdosed. And then one key element is to do this toxicology screening, particularly alcohol and certain illicit drugs, whether they have used all those drugs. Moving on to the acute management, the core of this thing. So I'll be touching a stepwise approach. So the first step is to stabilize the patient. So you have up to 5 minutes from the onset of seizure, if you know the onset clearly. And then moving on to from 5 minutes onwards, moving on to the therapy phase, where we can talk about basically 3 phases: initial therapy and second line and the third line. The first 5 minutes, you stabilize the patient. As always, the airway, breathing, circulation, and assess the disability with the neurology examination. So to keep the patient on position or recovery position if the patient is ictal or ongoing seizure. And then you have to start timing from the onset and monitor the vital signs. And one key thing is assess oxygenation. If you assess the airway, breathing, and then assess oxygenation, give oxygen via a mask. And if the patient's oxygenation is not really great, then of course you might have to consider intubation. And as an intern house officer, you are expected to seek senior help in case you think the patient needs intubation or advanced airway management. So a little bit more on the stabilization phase. You need to start regular monitoring of ECG, respiratory rates, oxygenation. Ideally, if you have access to continuous monitoring, then connect the patient to a monitor. And then within the first 5 minutes, you can get IV access and collect the blood for investigations, basically the electrolytes, hematology, toxicology, and drug levels. So the random blood glucose test ideally should be done a stick. And if the capillary blood sugar is less than 60, that means it is hypoglycemia. So you have to correct with the intravenous dextrose. You can give 10% dextrose with 5 ml per kg bolus, followed by infusion of 5 ml per kg per hour. And if you are treating hypoglycemia, then of course you have to recheck every 5 minutes to make sure that patient's sugar is corrected to normal levels. And also there is a place for intravenous thiamine injection, like 1 to 2 milligram per kg in case of alcohol excess or alcohol withdrawal. And same time, within the first 5 minutes, you are expected to prepare the acute management drugs, that is anti-epileptic medication, basically the benzodiazepines, which will doses and the drugs I will come to in the next few slides. So if the patient moves from first 5 minutes to next level, that's where you have to initiate the medications or treatment. So if seizure goes off before seizures before 5 minutes, then you don't have to consider pharmacotherapy. If patient seizure goes beyond 5 minutes, then of course you have to start treating. The first line would be to start benzodiazepines. Drug of choice is either diazepam, midazolam, or lorazepam, which is whatever is available. So that has level A evidence. So diazepam intravenous 0.1 to 0.2 milligram per kilogram per dose. You can give once and once more, like a second dose, if the seizure does not settle. Midazolam, if you are giving, just considered once only for 10 milligram for somebody who over 40 kilos, and if somebody less than 40 kilos, or 13 to 40 kilos, you give like 5 milligrams IM or intramuscular. If you have lorazepam, you can try lorazepam intravenous, again 0.5 milligram per kg per dose. You can go up to maximum of 4 milligrams per dose, and then you can again repeat once. So that is the initial therapy. Wise continuous monitoring, you give benzodiazepines, and initial therapy, of course, you allow 5 to 10 minutes. If does not settle, then of course, this is of course the second line drugs, not second line drugs, the alternate drugs for the first line. If you don't have diazepam or benzodiazepines, you can try IV phenobarbital. That is again level A evidence, 15 milligram per kg per dose, or rectal diazepam if it is available, again single dose. If available, intranasal or buccal midazolam can be tried alternate to the first line benzodiazepines, that is intravenous ones. Second therapy phase is usually considered after 20 minutes. If the first line or you give benzodiazepines, repeat it 5 to 10 minutes later if it's not respond. And if the patient's fitting beyond like 20 minutes, you consider it as a status epilepticus or continuous seizures. Then of course the second line is considered basically with intravenous or intraosseous phenytoin loading. Of course, second therapy phase, I would advise you to seek definite medical supervision from a senior, either SHO or registrar or your consultant, because by this time you should get their assistance because the patient going into status epilepticus. So IV phenytoin, of course, 20 milligram per kg or should be given over 20 minutes. But this, if you're giving intravenous phenytoin, patient should be continuously monitored for cardiac arrhythmias and should be on a continuous ECG monitoring. If not available phenytoin, you can try phenobarbital as a second line, again intravenous or intraosseous. But if the patient has been on either of these drugs as a regular dose, then of course you can't give these doses and you have to use half dose. So you try the second line loading with phenytoin, and if still no response, then of course you have to consider refractory status, but usually this is considered after like say 1 hour, if this goes beyond 1 hour. So that is considered a refractory status epilepticus. There is no specific clear guidance for this stage, but however, this you can use whatever you have not used as a second line therapy, but ideally this stage patient needs anesthetic medications to control seizures under intensivist or anesthetic guidance with the intensive care setting. So patient should be ideally managed at an intensive care with mechanical ventilation and intubation. So patient needs anesthetic support to manage at the refractory status level, which of course I think is beyond your stage as an intern house officer. So once that you have controlled the seizures, then of course you have to revisit the patient, reassess the airway, breathing, circulation, everything, and then keep the patient on the recovery position because patient will be drowsy and the recovery stage. And then if you have not had enough time, revisit the history examination for diagnosis and look for any complications. If there had been a previous diagnosis of epilepsy, then of course you can use their regular medications back again, or the habitual medications. And if there are any other concomitant illnesses such as diabetes, you have to look into those. And particularly if the patient is pregnant, then of course you have to treat, consider this as eclampsia, and there is a place for magnesium sulfate, and then you need to get involvement of obstetricians and the neonatal team regarding the further management. What are the medical complications you have to look following status or following prolonged seizures? So the patient can be hypoxic, hypoglycemic, there can be lactic acidosis and rhabdomyolysis, and you have to look for electrolyte disturbances and hyper and hypotension. Patients may develop raised intracranial pressure following seizures, so you need to look for all that evidence, and then patient can get fever. So follow secondary to seizures. So you need to be these need to be treated accordingly. I'm not going to touch it because it's not acute management. So, and then also you have to initiate a long-term anti-epileptic therapy when appropriate, not in every case. So for instance, if somebody coming with a seizures following hypoglycemia, there's no indication for long-term acute anti-epileptic therapy. However, if somebody comes with recurrent seizures, say with the multi-infarct dementia, then definitely the patient would benefit from a long-term anti-epileptic therapy. So those are my references, and thank you for your listening. Any questions? Hope I was clear to everyone.
Yeah, if anyone's having question, please chat on the chat box. Thank you very much.
I'm already 4 minutes late, isn't it?
Yeah, it's okay, sir. That was Dr. Abhi Disanayak, consultant physician at DGH Nuwara on management of seizures. So next up is by lecture on initial management of hematomesis by Dr. Chamil Marasinghe, consultant physician at CSTH Kalubowila. Can you hear, sir?
Yeah, I can hear, Roshan. Thank you.
Okay, sir.
I'll stop sharing.
Okay, can you see the screen?
Yes, I can see you.
Can I start, Roshan?
Yes, sir, please.
Yeah. So good morning, everyone. So it's a different medical emergency. Chamil Marasinghe attached to Kalubowila Prof Unit. So it's a big transition from status epilepticus to GI bleeding. Like status epilepticus, hematomesis is also obvious. There's no diagnostic challenge here. So the patients will come to you and say that they have vomited blood, either fresh blood or altered blood as coffee ground vomiters. Sometimes they complain melena initially. When they come to the hospital, they vomit blood, hematomesis. It's not a sort of pleasant experience for the patient as well as for you, because in front of you, sometimes they vomit a lot of blood. They panic and you panic, everyone panic. So it's important to know how to do the initial management of hematomesis. So what I'm trying to do is, like, I'll give you a sort of essential information, what is required for the intern house officer to stabilize and start the initial management. I'm not going to go into detail of any of these aspects. So this is what you see here is an algorithm. Don't worry, the font is small, but we are going to take one by one. And it is important any medical emergency that you're going to manage during your internship, you need to have three things. One is knowledge, the other one is skill. The last most important thing is confidence. When you start, your confidence level is very low because you have not managed medical emergencies. However, this lecture series will help you to improve your knowledge. And as you work as intern house officer, you will be able to sort of gain your skill and confidence. Although you don't see this when the patient comes with hematemesis, what is inside of the patient is a massive bleed, ongoing massive bleed. Onto your left-hand screen is a bleeding esophageal varix. Right-hand screen is a gastric ulcer that is actively bleeding. Gastric varix is a venous bleeding. However, it's high-pressure bleeding. They bleed a lot very quickly. Gastric ulcer, on the other hand, is arterial bleeding. Again, they can profusely bleed. So you don't have a lot of time when they start bleeding a lot. Therefore, you need to act quickly. Okay, as any other medical emergency, I'll start with airway breathing because it's important. Hematemesis patient can cough or vomit. Blood clots can be lodged in the upper airway. So you need to make sure that the airway is patent. If you think there is a blood clot blocking the upper airway, needs to suck it out. Circulation is extremely important here. So you need to understand this little information about the circulation. What you first find in a patient who's having upper GI bleeding would be resting tachycardia. Any significant upper GI bleeding, if the patient is having pulse rate more than 100, you are dead sure that the patient has bled more than 500 milliliters. That's 10% of the blood. The next come the blood pressure parameters, postural blood pressure and hypotension. It's not practical for us to sort of check the postural hypotension, to stand the patient up and check the blood pressure because the patients mostly are unstable and they are sort of vomiting blood. However, for your information, if the patient is having postural hypotension, then it will be about 15% of blood loss. Important to know, don't wait until hypotension develops to sort of start the aggressive treatment, because when the hypotension sets in, the patient has already lost about 2 liters of their blood. Intern house officer should rush into the patient and get 2 secure IV lines, large bore IV cannula, ideally at the sort of cubital fossa or even at the central, if the skill is available, but the cubital fossa, large bore cannula would do. And as soon as you put the blood cannula, you take blood for grouping and cross-matching, inform the blood bank over the phone that there is a patient with hematemesis, will need blood very quickly, and keep them ready as soon as possible. Send blood for coagulation profile and full blood count, because often these patients have underlying liver disease, they have coagulation derangement. Full blood count is useful to assess the hemoglobin and white cell count as well as platelets. So once you have done that, then you need to start the resuscitation as soon as possible. Resuscitation means cardiovascular resuscitation. Patient is bleeding, patient is losing fluid from the bloodstream, so you need to give fluid to the bloodstream. So you have 2 IV cannulas, you start crystalloid, normal saline, Hartmann, plasmolite, various crystalloid solutions are available. Your task is to correct the resting tachycardia. If the patient is hypotensive, obviously yes, needs to improve the blood pressure, but that may be a bit late. However, so you try to achieve hemodynamic stability. There's no fixed amount of fluid how you give, so it's individualized. However, I would recommend to start at least 1 liter of fluid as soon as possible as a bolus. If the patient is not having any illnesses that will cause fluid overload, like congestive cardiac failure, then take it from there and give more and more fluid till the patient is better. However, if the patient is bleeding inside, most of these patients will not really improve, but it's important to give crystalloids. But then if the patient is having active ongoing bleeding, you need to get the blood and start blood transfusions. However, if the patient has stopped bleeding, no hematemesis, patient is stable with crystalloids, you don't need to panic and give blood transfusions. Then you can wait for the full hemoglobin level. If it's less than 7, advise to give hemoglobin, red blood cells, to get the hemoglobin up to 8. But importantly, I'm mentioning it again, if the patient is actively bleeding, don't wait for hemoglobin, give blood transfusions. FFP, not for all the patients. Ongoing bleeding with INR more than 1.5 or APTT more than 1.5 times, that's the time to give fresh frozen plasma. Platelets, again, not for all the patients. Ongoing bleeding, when the platelet count is less than 50, you give platelets. However, the important message is start crystalloids as soon as possible and give adequate volume of crystalloids. Then organize blood. So back of your mind, you need to sort of consider the etiologies. Okay, you're working, you're giving fluids, you're getting blood, and everything is organized, and it's a sort of a rush situation. But back of your mind, you need to know why this patient is bleeding. It's a guess until you do the endoscopy, and therefore we manage all the possible etiologies. First 3 highlighted or bold are the sort of most important ones, because those are life-threatening, can cause life-threatening bleeding. Peptic ulcer disease, gastric duodenal, esophageal varices, gastric varices, they can bleed a lot. Malarial-wise, gastritis, esophagitis, or gastric malignancy rarely will cause life-threatening upper GI bleeding. Therefore, what you need to do is to manage the first 3 conditions simultaneously. To do that, you have medications. Okay. If it is peptic ulcer disease, suspected peptic ulcer disease, or if you are not sure, you start a proton pump inhibitor. Sometimes omeprazole is available, sometimes pantoprazole is available in our hospitals. Either would be okay. You give 80 milligram stat and then 8 milligram per hour infusion. Then could be variceal bleeding. So omeprazole, pantoprazole will not do anything for that. Then you need to start either octreotide or terlipressin. The octreotide is available most of the places. I hope it's available in the peripheral hospitals as well. But terlipressin would be the drug of choice. Some centers will have terlipressin. So you need to know the doses of these medications, how much to give, 50 mics per hour octreotide, terlipressin 2 grams every 4 hours, because you don't have any time to refer. You need to write it, and the BHD asks the nurse to organize the drip. Then you're managing the 3 conditions medically at the moment. There is a place of IV antibiotics, third generation cephalosporin, ceftriaxone, or ceftaxime, that needs to be given only for chronic liver cell disease patients, because it improves the mortality. One of the medications that you often use is IV tranexamic acid, the 1 gram 6 hourly. In a panic situation, when we don't have any other options, then of course it may have a place, but it's not scientifically proven. What is important is after fluid resuscitation, you need to start proton pump inhibitor and octreotide or terlipressin to reduce ulcer or variceal bleeding. As intern house officers, if you have done up to this point, you have done a great job. You don't have to do anything else. Okay, by that time, you'll get more help. A registrar or a senior house officer or a consultant or senior registrar who will come and assist you. However, what I have mentioned so far needs to be done by the intern house officer as soon as possible. It maybe within 15 minutes, maybe within 30 minutes, but you need to be conscious about all these steps in managing upper GI. Most of the patients, luckily, will stabilize or will stop bleeding, and you have more time then to organize the upper GI endoscopy. The upper GI endoscopy would be the next step of this tree algorithm. I will go through very briefly what would happen next. And endoscopy needs to be organized. The patient needs to be sent to the endoscopy when the patient is hemodynamically stable. If the patient is not hemodynamically stable, then the chances of patient arresting at the endoscopy table would be very high. Therefore, the first steps that have been mentioned needs to be started and stabilize the patient and then organize the endoscopy. It's good to inform the endoscopy unit and the person who's in charge of endoscopy that there is an acute upper GI bleed, acute hematemesis patient that we are managing in the medical ward. This patient will need an urgent upper GI endoscopy. Okay, then they know that, okay, the next available slot will be allocated for this patient. Do you have any questions so far? Anyone would like to ask? Or is it clear? Roshan, I hope that you can hear me well. Anyone?
Yes, sir.
Yeah, you can hear. Okay, so we can ask. I mean, you can ask questions at the end. So it's the one more slide to go. So endoscopy, you have seen endoscopies, how it's been done and all those things. So it's important to get the upper GI endoscopy. 2 reasons. One is to identify the cause of bleeding. Next, to treat endoscopically. The variceal bleeding is common, especially in chronic liver cell disease patients. So when the upper GI endoscopy done, so the endoscopists will see large varices, and one or many will be actively bleeding. Okay, despite of bleeding, an experienced endoscopist can put a band ligation to the esophageal varices. As soon as it's been done, the bleeding stops. It's a magic treatment. Gastric varices, of course, a bit more complicated because it's difficult to put a sort of a band. Therefore, a glue needs to be injected. It's difficult to inject glue when there is active bleeding, and it needs expert skills to inject glue. Not all the endoscopy units will perform that. So once it's done, then it's fine. So they improve. Their bleeding stops, and then you need to stabilize them a little bit more, and the patient will go home safely. If it's peptic ulcer disease, of course, 2 things can be done endoscopically. Either you can inject adrenaline, there's a small spelling mistake here, or clip the feeding artery, and that will stop or improve or reduce the bleeding. Once endoscopically treated the peptic ulcer disease, IV proton pump inhibitor, omeprazole or pantoprazole infusion needs to be continued for 72 hours. Then it needs to be converted to oral for the next 2 to 4 weeks. Some of these ulcers are related to H. pylori. After the sort of a flow test or the biopsy results, H. pylori treatment can be started later, but it's not an urgent thing. So if you want to I don't want to bombard with a lot of information. If anyone is interested in reading about upper gastrointestinal bleeding, there's a nice article in British Medical Journal 2019. So if you can Google, you can get the PDF and slowly read and get more information about upper GI bleeding or hematemesis. That's all I need to tell. I can answer any of the questions that you have. There's a chat box there, so something. Okay. So one person has asked, so hematemesis is a medical emergency or surgical emergency. After initial management still deteriorated, do we have to inform the surgical team? It's an interesting question. Hematemesis, the patient's hematemesis goes to both medical and surgical wards. So both medical and surgical team will be managing hematemesis. However, the surgical treatment are not performed these days because the endoscopy is available. So if the bleeding is from varices or chronic liver cell disease related portal hypertension, then of course there's no real surgical treatment. Then it needs to be endoscopic treatment. Both the medical team as well as the surgical team, with the help of the gastroenterologist, can do the full treatment. However, the intern house officer, either in the surgical or medical ward, will be starting the initial management steps that I have told. if it is a gastric ulcer bleeding, of course, if the endoscopy has failed, then of course, yes, you will need the sort of surgical team to sort of open and ligate the feeding blood vessel. Any more questions that you want to ask? There's another question. Apigee endoscopy only done by the trained consultant gastroenterologist. What specific procedure are done exclusively by the gastroenterologist? The thing is, like, it's not necessary to have sort of gastroenterologists to do the Apigee endoscopy. Even the medical officers, senior medical officers who are trained for this, registrars, senior registrars, to perform the full Apigee endoscopy, including banding. Therefore, yes, under supervision of a gastroenterologist or the gastric surgeon or a consultant physician. What specific procedures are done exclusively by the gastroenterologist? It depends. What I can say is, like, band ligation for Apigee endoscopy varices can be done any trained personnel who can perform endoscopy. However, according to my knowledge, the glue injection to gastric varices will be done by the gastroenterologist or trained person. And in relation to the ulcer bleeding, again, the adrenal injection can be performed if the endoscopist had been trained to do that, or clipping as well. So yeah, so if you have a gastroenterologist, you're lucky. If you don't have a gastroenterologist, I don't think that will stop the full treatment of the patient. So if portal hypertension, there after initial management, propranolol or carvedilol should continue. Okay. And what is the place of IV vitamin K? Okay, so two questions are there. So yeah, if it is portal hypertension, variceal or gastric bleeding, once the initial management is done, as a secondary prophylaxis, carvedilol would be the best. If not available, propranolol needs to be continued lifelong. What is the place of IV vitamin K? Yes, IV vitamin K can be given or needs to be given if the INR is prolonged more than 1.5 in a chronic liver cell disease patient. However, vitamin K does not act immediately like a fresh frozen plasma to correct the coagulation. You can give it. It will start working within, say, after 12 hours or within a day or two. Yeah, there is a place if the INR is prolonged. So dalteplestin is given initially as a bolus 2 gram followed by, there are two protocols that can be used, but what is widely practiced is you can give 2 milligram boluses, that's dalteplestin boluses, that's 2 milligram every 4 hours. But infusion preparation is also available. I'm not entirely sure it is 1 milligram 6-hourly infusion, but you can read about that. But the standard practice is you can give dalteplestin boluses 2 grams, actually not milligrams, every 4 hours. Any more questions you want to ask? Important questions, interesting. Yeah, as I told you before, when you start managing these patients, you will get to know about the effectiveness of this treatment. And sometimes, even before the endoscopy, you have you're pretty confident this is variceal bleeding and this is ulcer bleeding. Irrespective of that, if you're not sure, you need to manage simultaneously all the etiologies until the endoscopy is done. All right. I think we have answered all the questions, and in the absence of other questions, I will stop my, okay. Sorry, okay, there's one more question. I think we have 5 minutes, 9:25, so that's okay. What is the place of Sangstegan Blackmore tube? Yeah, before endoscopy, interesting. It was there. It was sort of one of the standard practice about 20 years ago. Sangstegan Blackmore tube is having 2 balloons. One is a gastric balloon. The other balloon needs to sort of inflate at the bed of the esophageal varices to apply pressure internally to stop bleeding temporarily until the endoscopy is done. Okay. However, it's not an easy tube to pass through, and it has been associated with complications, including aspiration pneumonia. So, if available, if the endoscopy is getting delayed, if the patient is actively bleeding despite of medical treatment, if an expert person who can put the Senstagen plaquemore tube, yes, you can place it, but we hardly practice it now because of this difficult procedure, as well as blinded procedure, difficult procedure, as well as associated complications. Yeah, however, the place of that tube is to keep the patient reduce bleeding with the application of pressure to the ulcer or the variceal bed before endoscopy. So it gives you time and stabilize the patient before endoscopy. Okay, 9:27. I'll stop there. I wish you all the best.
Right. Thank you very much, sir, for that interesting lecture. That was Dr. Shamil Marasinghe, consultant physician at CSTH Kalaboya. So next up is another very important lecture by Professor Chandani Tunga, Professor in Pharmacology, prescribing and getting the best out of medicines. Over to you, madam.
Thank you. Let me share the screen and then. Okay, good morning. And so I'm going to talk to you about prescribing and how we can get the best from medicines, because irrespective of the specialty you select to do your internship and later on, whatever you do, you will be prescribing. So over the next 20 minutes or so, I'd like to take you through how we can improve on our prescribing, how can we get the best to our patients, and also look at how we can avoid medication errors, because errors, as the word suggests, is a preventable thing. And especially with paying some attention to detail, we can do that. So prescribing basically means that we advise, and by we, I mean the medical officers, advise and authorize the use of a medicine or treatment for someone, and that's especially given in writing. Prescribing can be done verbally, but that has no legal benefit, because sometimes in a rush you can say, look, give this in an emergency, you can say give some adrenaline, but at the end of the day, unless it is written in the BHD, there is no legal validity. That is why after the emergency, once that is over, we sit down and write whatever we gave in that emergency situation, because we need that as a document. So it has to be in writing. And when you look at prescribing, all what we have to do is to prescribe appropriately, and we look at it a little bit in detail. But in addition to that, there are two other factors that come into prescribing, especially if once you go into the community and you start prescribing on your own. So in essence, the first issue is that you need to spend less. And that is from the government side or from the patient's side if they have to spend out of their pocket. Or sometimes even when it comes to insurance payments, because there is a limit to what they can afford. This spending less is becoming more and more important now. As you know, we don't have a lot of medicine, so we need to rationalize what we give, and as much as possible, make sure that these are cost effective when we prescribe. Then, of course, when you go into the community, you have the which come and talk to you and say, prescribe my drug. And by my, I mean their firm or what they are marketing. So all these factors come into play when you have to prescribe appropriately. You have to decide what is best to your patient. You will also increasingly have to think of the cost, and also sometimes about what the industry is also saying, because they are also a very important stakeholder in this program. So when it comes to prescribing, we have 5 rights. It means that we have to select the right drug, the right dose, the right route. That's very important, because if you give it in the wrong route, it will not get to the site of action the way that you want. The time, it has to be the right time. Sometimes we do say take it before a meal or after a meal or at a particular time interval. That's important if you want to get the best benefit. And of course, you need to prescribe to the right patient. So when you select the patient, you have to make sure that that is the patient that you are prescribing this particular medicine. So when you look at prescribing appropriately, what should we really do? So we need to give the best medicine to the individual patient. That is what appropriate prescribing is all about. So when you look at what we need to give to the individual patient, that is something that has to be effective for the conditions. So when you look at a patient, say the patient has ischemic heart disease, there is a standard set of drugs that we generally give. So that is the best or the most effective for that particular condition. But then we go one step further and select what is best for the individual patient's condition. Now, the individual patient's condition will depend on the other comorbid factors that the patient will have. Say, for example, you have to give a beta blocker to this patient because he has got ischemic heart disease. But if he has bronchial asthma, there is a little bit of a problem when you give beta blockers. So now you need to weigh the pros and cons. Similarly, if you have a patient with diabetes, yes, we know that metformin is one of the most effective drugs, but you also need to look at the renal function and the other problems that the patient might have. So you have to look at the individual patient and decide what medicines you have to give to that particular patient based on the patient's condition. So you have firstly the set of drugs that you have to give for a particular medical condition, and then you fine tune it based on the individual patient's conditions, which takes into account the other comorbid factors. Then, as I said, at the lowest cost to the country, lowest cost to the individual, all that comes in. So now you will have to also decide when you go to the wards, whether you are going to give prescriptions to be purchased from outside. Right now, outside means that the person will have to incur a cost and he will have to pay out of his pocket. Now, you might be told that, okay, this is the best possible medicine for this condition, but the hospital might have something else which can be given instead. So now you have to decide, are you going to get this patient to buy it from outside? What are the pros and what are the cons? Or are you going to go with what is available in the hospital? So every time you write an outside prescription, think about the cost to the patient, especially if it's a long-term medicine, whether the cost is justifiable if you have an alternative that can be given to the patients. Then, of course, when we prescribe appropriately, we also need to ensure that there are no medication errors. Now, medication errors can happen at any point. So you start from prescribing, there can be an error. So what we prescribe, what we write gets transcribed. It's now, if you look at the ward BHDs, you know that the medical officers write on the notes, and then sometimes the nursing officers transcribe it to the front where you have the drug chart. In some hospitals, most of the Western countries anyway, it's a medical officer who actually writes it on the drug chart as well. So the transcribing errors then become minimal. Then, of course, what we prescribe is dispensed by somebody else. So that in the wards, that would be the nurses. In the outpatient clinics, those would be the pharmacists. So there can be errors at that point as well. Then, when we administer the medicines, so if the medicine is not given in the proper way, the administration errors can happen, and that can happen in the wards by the nurses, by the caregivers in the community, or by the patients as well when they take their medicines. So there's also errors that can happen with monitoring. If we don't monitor the progress of a disease, we might not detect certain medication errors. So as you can see, everybody is involved in this process. Medical officers, nurses, pharmacists, patients and caregivers, they are all involved in taking medicine. So errors can occur at any point in this medication process. Now, medication errors are common in the most vulnerable, like the children or elderly or those in multiple comorbidities, children and elderly, because their systems are different from the normal adult people. With multiple comorbidities, obviously you're getting more medicines, they can interact more, and they can cause problems. So the problem with medication errors is that they can result in additional hospitalization, which means that the patient will stay for a longer time. There would be a greater risk of hospital-acquired infections, and obviously the healthcare cost is going to go up. So in addition to that, because they are in the hospitals, they can lose their income. There can be disabilities. You would have seen reports about wrong injections into some of the arteries, which can result in the loss of a limb. So the patients can get disabled. And of course, there can be litigations because now people are asking more questions and you're open to litigations when there is a medication error. Medication errors happen in Sri Lanka. In case you thought it was something that is not seen, it is seen. It's just that we don't look at it consciously. This is a very small study that we did in only one single medical unit in a peripheral hospital. And we found a lot of errors which happen with prescribers, errors which happen with dispensing, errors that happen with administration and so on. So it's not a problem that is rare. It's actually quite common. So it's important that we look at our patients and minimize their medication errors. So when you look at, I told you about the 5 rights, then we also have 5 wrongs, which look at prescribing errors. That could be the wrong drug. Now, the wrong drug could be either that it is wrong for that particular condition, or it could be wrong for that particular patient. So that could be the wrong drug. Then it can be the wrong dose. And this is very common when we don't check the BNF sometimes. We can prescribe medicine twice a day when it has to be given 8-hourly, or we can give it a wrong dose. The amount might be wrong. So it's important that we give the right dose because those doses are what gives the benefit that we want. Then it could be the wrong route. If a patient is acutely ill, there is no purpose in giving oral medicines in that acute stage because you're not going to get the desired blood levels. But on the other hand, if the patient can take orally and he is not acutely ill, then you could try oral route rather than using a parenteral route. Remember, every time you put a cannula, you're introducing a portal of infection to these patients. So the route is very, very important. And you need to select the appropriate route. The wrong time. Right? What time should they take the medicines? So if they have to take it early in the morning, that's important that we give it early in the morning. It becomes a problem sometimes in the hospital because they distribute or dispense drugs at a particular time in the ward. So we might not get the best timing there. But as much as possible, you have to make sure that the time that the patient gets the medicine is the best for that patient. Then, of course, the wrong patient. So all of these will come into the picture if the patient is not the real one that you should give in these particular things. Especially important if you're giving antibiotics, there are certain checks and balances in place which the nurses do follow. Sometimes when you give parenteral, you have to check whether that's the right patient and give because there are instances where the wrong patient has been given the wrong medicine. So when you look at prescribing errors, because that is where we as medical officers are involved, it's a failure of the prescribing or the decision-making process. Because it's a decision. What you decide to give your patient is a decision that you make as the prescriber. So there are of 2 types. There are errors of omissions because those are the ones where we don't act correctly or we don't give the drug that has to be given in the way it has to be given. Or it is an error of commission where we have acted incorrectly. We have given the wrong dose, or we have given it to the in the wrong route, or whatever. And the good thing is that all errors are preventable. So, which is why we need to be conscious about the errors that we can make. They are preventable, and therefore we can avoid all these problems. So when you look at the factors associated with prescribing errors, obviously it could be because we lack the knowledge or we do not know how to apply that knowledge. It's most of the time, it's a mixture of both. So that could be the lack of knowledge or not knowing how to apply this knowledge regards to drug therapy, on patient factors that affect drug therapy like hepatic or renal function, or we have forgotten to ask about a history of allergy. And these are common, and renal function is a very important thing that we need to think of in our patients, especially as we see a lot of older people now. And you need to actually calculate the renal function, get the GFR, and that can be easily done with many apps that are in the phones. So it's important that we check it so that if there are dose adjustments to be made based on the renal function, those dose adjustments are done. Then prescribing errors are also associated with incomplete medical records. It could be that the patient doesn't have his old prescription, so you can't reconcile whatever he or she has been taking. You might duplicate the medicines without knowing. Sometimes the conditions are not properly documented in the clinic records. So all these will contribute to prescribing errors. So how can we improve? You can improve by improving the knowledge, which is what we are doing now. And it's a continuous process because we keep on, going in for various CME programs. It's very much easier now because things are online. But more importantly, at the ground level, you need to take a very relevant medical history, which includes a detailed drug history. So the patients might know, if you ask them, at least they will be able to describe the medicines that they are taking, which is not a very good thing. But at least they have some idea. You can look at the medicines that they have. Sometimes they carry them in bags. So it's important to look at them. And of course, look at the clinic records. One of the ways in which we can prevent these prescribing errors is to ensure that we have very good medical records. So everybody who keeps a medical record writes a very detailed, a comprehensive medical record, which has all the relevant details, not the unnecessary things, but the important ones, which basically, gets transmitted to the other person who's looking at the patient. Then, of course, if you are in doubt, always check. There's nothing lost in checking with the BNF or getting online and checking. But if you are not sure, without prescribing, it is always best to check and confirm what you already know or you don't know. Then when you look at prescribing errors, there can be errors because we calculate wrong. Now, this happens usually in children because their doses are based on their weight. And if you don't weigh the patient and assume what the weight is, you can make mistakes in the dose. That's obvious. But there are certain drugs in adults as well, which you have to give according to the body weight. So you need to then weigh your patients and have an idea as to what the body weight is. A very common problem is this use of decimal points. Now, if you look at this decimal point here, this is how you write. If you write it, you have, the decimal point comes after this full number. So if this could be 1.25. The decimal point here is important because it has a meaning. But the decimal point here has no meaning because there is 0, unless of course there is a 2.5. The danger is that if this decimal dot is not seen, or if it has got merged with the next figure, you have to be very careful when you do that. This could be read as 20, and that can be a major error in dosing. So when you write the decimal points, use it correctly and make sure that the decimal dot is very clearly seen, because it can lead to problems. Similarly, when you write micrograms and milligrams, you have to be very careful, because if it is written in the wrong way, you can give a wrong dose. Then, of course, there can be nomenclature factors where you use the incorrect drug name, the dosage forms, the brand names. When you use, you can run into problems. It's a big problem with brands because there are so many brands available for the same medicine, and the patients come with prescriptions with brand names. So know what the brand is. That can cause problems. So it's good to check when they come with brand names. Using tablet numbers instead of the dose or amount, because half a tablet would be different if the tablet is 250 as opposed to a tablet that is 500 milligrams. So it's always good to give the dose strength in milligrams rather than saying half a tablet or 1 tablet or quarter tablet. Using abbreviations, you have to be very careful. The abbreviations should be what is accepted universally and not what we write just for our convenience. I've given you 2 examples. MTX is written for methotrexate very commonly. It's not an accepted abbreviation. Nebsal plus Cipra, that is again not an accepted abbreviation, that is written very widely in the words. But if there is a legal issue, this can be a problem because there's nothing called Sal or Ipra in medicine. So we need to use the appropriate terminology, do the correct dose calculation, know the strength of the formulation that you're using, and if you are not sure, check. And of course, if you want to go one step further, there is what is called error reporting, which we will look at a little bit later. I'm also looking at prescription errors because as much as we prescribe, we also write a prescription. Now, you know the normal features that should be there in a prescription. The identity of the recipient, the identity of the drug, the formulation, the dose, the route, timing and frequency, and the duration of administration. I have put a prescription. This is a real prescription that we got from the board. And you can see that, you can't basically find any of these things, perhaps the patient's name, which I have blocked out. Would any one of you be able to read what is written here? Interestingly, the pharmacist has read it, and the pharmacist has dispensed the medicines also. I don't know how he or she did it, but this is a problem because if you can't read what is given, then the dispensing can be erroneous because the pharmacist is assuming that this is coming from this particular clinic and this is this doctor's prescription. So he or she is giving these medicines and it might not be the same. The problem for us is that if this prescription comes with these patients later on into the wards, we won't know what they have taken and we will not be able to avoid any of the problems that I mentioned earlier. So writing a proper prescription is very important, irrespective of whether it is in the ward or outside to a pharmacy. Legible writing, cannot stress it enough, but it's important. Right. So when you look at prescribing errors, remember, deviation from policies or guidelines are not prescribing errors. Now, these are just policies and guidelines and not necessarily errors, because you can, if you move away from that, it is not a prescribing error. They are just there to guide us. The ward policy would be or the hospital policy would be, use these antibiotics first. But if you have a very valid reason, you can deviate from that policy. Same goes with the guideline, provided you know that why you are doing it and you can justify that deviation. And adverse reactions or adverse events are not necessarily medication errors. We know that anaphylaxis can occur with any drug, and that's not a medication error. It is something that is going to happen. Of course, it's a rare thing, but it can cause problems, but that is not considered a medication error. However, if we have missed that there was a past history of allergy and prescribed this medicine, then it becomes a medication error because that could have been prevented if we had taken a proper history. So as you can see, lots of people are involved with giving medicines. And at any level, the most important things to prevent medication errors is updating our knowledge. If you are not sure, and of course, asking another patient, ask for help. You can ask your registrars, ask your consultants, ask your senior registrars, anything if you are not sure, but always check that. It's okay to use a computer if that facility is available, which is not in a public sector hospital, but you always have your phones and you can download whatever the information that you need and use it on the go. Or you can carry a small book, whatever the little textbooks that you carry to the wards, and check when you're not sure. Right, now this is my prescription, so I can share with you any errors that you can see in this. Yep. Any errors? Okay, you can unmute and somebody can answer. The duration has been cut off when I had taken the picture. Sorry about that, but here it says 1 month. Yes, any error in this prescription? I do recognize some of the names I can call out, but would one of you volunteer? Because we have just 10 minutes more. Yep, would somebody like to volunteer? Uh, 1021, Dr. BKJS Rodrigo, would you like to take a go at this prescription? Yes, Dr. Rodrigo? Can you all hear me?
Madam, one query regarding
Yes,
the
Timira, what are the problems you see?
does prescribing like glycomet and all, do they come as deviations of the prescription, or don't we necessarily say metformin or like the generic name rather than brand name?
Okay, good. Anything else? Anything else?
If the lower down, although this is a prescription, you have mentioned about several investigations in the same prescription.
You can do that. In the private sector, we generally use only one page, so we can write one. That's okay.
Okay.
All right. Yes. So somebody in the chat has said 1 tab, that's a ferroglobin. I'll come to that. So there are 3 errors. Okay. One is what Timira said. Technically, I can't write this. This is an illegal thing. You should write metformin and within brackets glycomet. So this is wrong. This is because a patient wanted it that way, but that is illegal. Legal provision is that we write the generic name and within bracket, we can write the trade name if that's what you want, or the brand name. The second one is what I wanted to point is actually the enalapril dose was 2.5 milligrams. The dot here has got merged with the line in the 2. So what happened was the patient was given 25 milligrams, but because the patient knew that she was on 2.5 milligrams, I told her, she knows the doses because I generally go through the doses. She called me and asked, did you increase my enalapril dose? So, and then WhatsApp this to me. I said, no, I wouldn't generally not give 25, although it is possible to go up to 25. So no, what I wanted was 2.5. So lesson learned here was that, you have to be very careful when you put that decimal dot and make sure that it is clearly seen. So that was where the problem was. In the chat, you said, yes, 1 tablet. Now, ferroglobin is a combination product. So you can't really give the milligram doses because there are other things that come in. So you can usually say 1 tablet when you're using combination products. You can use the trade names when you're giving certain combination products because each combination will have a specific composition. So you can't say so many milligrams of this and so many milligrams of that. But yes, so ferroglobin 1 tab is possible simply because I'm giving a particular brand which has a particular composition. Otherwise, no tablet. You are very right. You can't say 1 tablet. So as you can see, at any level, each one of us can make mistakes in a prescription. Enalapril 25 was a preventable error. Glycomet 850 is a legal issue, but enalapril 2.5 is a medication error. 25 is not what I wanted. It is just that that dot had got merged especially because I was using an ink pen. So it's important to remember those things and make sure that we don't make those mistakes. Good. Right. So as I said, we have transcription errors when we transcribe. And it is more likely when it is handwritten and the documentation is a paper-based system, but we can't go away from that. So it's important that we check. So if you write on the BHT, next time when you do the ward down, just check the drug chart to see whether what you had prescribed is what has been given to the nurses. So legible handwriting is important because then it's easy for the nurses to transcribe it. And I'm coming back again to what is called error reporting. Now, error reporting is a system where we report an error, which is investigated to find out what went wrong. And we give that relevant information to the people who are involved. And the idea is that we prevent this error from happening again. So the error reporting systems are in place for both errors that are prevented. So it can be something that was detected early, so it didn't reach the patient, so it's a prevented error. Or it could have been an unprevented error and it just happened and we found out at a later stage that we have given the wrong dose or the wrong drug to the patient. So the system is there for both of these, because even an error that prevented can be investigated to find out how we do not make that error in the first place. It is actually a learning exercise and not something where we use to appropriate blame. So it doesn't matter whether I make the mistake or you make the mistake. The important thing is that we look at that mistake and we learn from them. So error reporting needs to come in a better way than what is happening. Now the problem is people don't report because they think that they will be penalized or punished for doing something, but that is not what error reporting is about. Error reporting is all about learning from a mistake and making sure that it doesn't happen thereafter. If there are any medication errors or drug reaction, mainly the adverse drug reactions that you see with medicines, you can inform the NMRA so that they can look at it in a broader perspective to see whether any other medicines that we have are causing more problems. Just to highlight that that mechanism is in place and you can use it. Cannot stress the importance of having the BNF in your phones, right? It's a lifesaver in many instances. You can always check. It takes very little time, but it can, of course, save the life of your patient. So what I did with you is to discuss with you how we can get the best out of medicines. That's a very brief presentation, just to give you an idea of what you need to be aware of and what you need to look at, and more importantly, how we can prevent medication errors. Right, so any questions? That's all from me. Any questions? Anything you want to ask? We have about 3 minutes. Anything you want to clarify? Any questions? Okay, so if you have no questions, that's all from me. All the best for your internship. Enjoy your training. And then make sure that you learn as you go on. Every single time you make a mistake, because that's how we improve ourselves. Good luck to all of you.
Chandani, next is Tushara's slot I'm using. Huh?
Oh, yeah, I'm okay. That's I think there's somebody from the ministry and the system who's handling it. I'm leaving the meeting now.
Okay.
Right. Thank you very much, madam, on lecture. Next up is a lecture by Professor Indra Kumar, approach to chest pain. Over to you, sir.
Yeah, thank you. Okay. Can you see this screen?
Yes, I can see it full screen, sir. Yeah.
Right, okay. So I just thought I will just share with you some important concepts in the management of acute chest pain. You can hear me? Yeah. Right.
Yes, sir.
Right, okay. So chest pain is by far the commonest symptom that will come to a medical ward, right? Okay, so it's a very important topic and can be a very serious illness. So it has a very vast differential diagnosis, but only handful are life-threatening diagnosis. So you cannot miss that handful of causes. That missing those may be very, very serious. So the diagnosis must be made early and accurately, right? So just draw your attention to this presentation of a patient who is 56-year-old man, comes to the ETU with crushing chest pain, 3 hours, and classically radiated to the neck and the arms, and nauseated, and examination, sweating, pressure high, ECG is abnormal. So I said abnormal. So let's just start from there. Right. As house officers, this is the list that you have to keep in mind, right? Onto your left, you see the serious causes. On your right, they may be common than the left side causes, but not so serious. So there are two types of causes. One is a potentially life-threatening causes. Other one is not so at all life-threatening, but it's a bother for the patient. So as house officers, the one on the left has to be seriously considered in every patient coming with acute chest pain. Because if you miss one of the things on the left, it may be a difference of life and death. The one on the right, if you miss the list, is no harm. It may be causing only a little bit of pain and suffering. That's all. So in the what are your aims of assessing a chest pain? Now, what is your real aim, right? The number one aim is to make an accurate and early diagnosis of a myocardial infarction. Is it a STEMI or non-STEMI or unstable? So you have to make a very, very early diagnosis. If you cannot make an early diagnosis, at least you have to exclude acute coronary syndrome. So that is second more thing, right? So one is you try to make a diagnosis of acute coronary syndrome. Other one, if it is not so, you need to exclude that. It's not easy, right? You have to exclude, right? So once you do that, then third objective is once you exclude the acute coronary syndrome, you have to make sure it is not one of those other life-threatening causes. So these are the three objectives that should be in your mind when you see a patient with acute coronary syndrome. Right? So those are three objectives. Don't forget those three objectives. Then how would you start off? Right. So we all have been taught in from the medical school days. You all have been taught by your teachers that there is a way of assessing, analyzing chest pain. Right. So I don't need to go into detail. Do I need to go into detail of Socrates? I'm sure all of you all know these Socrates. So you should have a very detailed assessment of a chest pain. Right. The mnemonic is Socrates. Right. So I don't need to go into detail because all of you all, I'm sure, you all know about it or not know about it. Can somebody tell us? Yeah. Yapa. From which faculty are you, Yapa? Hello. Dr. Yapa? YMSH Yapa. 24. Off na niyo. Katakan do off no. Hello? Can somebody talk? Number 24, YMSH Yapa. Vijayaratna. Chandima. Are you all there or are you all not there?
Yes, sir.
Who is that?
Sam Vijayaratna.
Right. So you're from which faculty?
From Rohuna.
So do you have to go into detail with the Socrates? You all know about it?
Yes, sir.
We
We
know
can
about
remember.
it. Huh?
Yes, sir.
Good. Excellent. So let's not talk about that. So all have to analyze the chest pain properly, right? This is the number one task, right? When the patient comes, right? So you go into the details of Socrates and associated symptoms. That's a very important associated symptoms, right? Once you've done the Socrates, associated. Are there autonomic symptoms? Are there other cardiac symptoms? Are there gastrointestinal symptoms? Are there any constitutional symptoms? For example, severe myocarditis, pericarditis can occur due to virus. Are there psychosomatic symptoms? Young girls coming with chest pain, crying, severe, pain, suffering, psychosomatic illness, panic attacks. So this kind of associated symptoms will help you to also to diagnose the cause of chest pain. Right. This condition called stable angina, right, which you hardly see in ward practice, because stable angina are stable. These patients don't come to hospital admissions. They come to the clinics to take medicine. They're stable, right? So why should they get admitted? They won't get admitted because of stable angina. So you don't see stable angina in hospital wards, right? So don't try to diagnose stable angina in a patient who is coming to the hospital because of chest pain. Because if it is so, stable angina should have become unstable, right? So I have seen some of the doctors are making diagnosis of stable angina in a patient who coming with an acute chest pain to the hospital. So stable angina should not be in your diagnosis list of an acute chest pain, right? But stable angina you should know to manage in the clinic. So I'm sure you know about stable angina. They are stable symptoms brought on by exertion, relieved by rest, or GTN, and they are stable and they should be managed as outpatients in the clinic, right? You don't have a problem in diagnosing stable angina, right? So the things that other than acute coronary syndrome, you have to be very careful. One not so common but important diagnosis that you cannot miss is an aortic dissection, right? So aortic dissection is characteristically presented with tearing central chest pain, tearing, right? Severe pain radiating through to the chest, to the back, right? It's a tearing nature, right? Tearing nature, very, very severe. And all acute chest pain, you have to make sure that this is not an aortic dissection. So there is a triad. 95%, if you apply this triad, it identifies you will not miss 95 of the patients. What is this triad? The symptoms, typical symptom, and the difference in the pulse or the blood pressure between the arms, and the X-ray, simple X-ray showing the mediastinal widening. If you see a patient with severe chest pain, and if this comes into the category of these three, then you have to seriously consider aortic dissection, because this is the typical clinical triad. So it's easy. You only need X-ray, right? So you can diagnose aortic dissection 95% of the time only with a chest X-ray and clinical sign. So it's a very easy diagnosis not to miss, right? We don't need sophisticated test. All of your house officers, please remember this clinical triad, right? You won't miss a dissection. That is the important differential diagnosis for acute chest pain. So of which the type A, type is the most commonest, right? And the most dangerous type, right? Of aortic dissection, right? So this is the X-ray. You cannot miss this mediastinal widening, right? This kind of X-ray, if you see, if the pulse volume is different in both arms, if the blood pressures are different in the both arms, then you are seriously thinking of aortic dissection and make the further referral. Then comes the other one, which is extremely uncommon, called esophageal rupture, where patient typically come with acute chest pain while eating. And while eating, patient gets a cough and severe vomiting and suddenly gets a chest pain. You suspect seriously. Again, to diagnose this, you don't need much test. You only need an X-ray. X-ray will show pneumomediastinum. So X-ray is very, very useful test, right? So all chest pain, try to see whether you need X-ray unless you have categorically diagnosed acute coronary syndrome. Then you might not need an X-ray, right? If you have not diagnosed acute coronary syndrome yet, or if you have excluded acute coronary syndrome in a patient, X-ray becomes very, very handy, right? Esophageal rupture, you will see pneumomediastinum. Important differential diagnosis. Then the other differential diagnosis, which can be serious, is pericarditis. Again, it is a clinical diagnosis. It is relieved by sitting up, worsened by lying flat, right? Kind of pleurotic type of chest pain. Again, you don't need much investigation. ECG and clinical symptoms. You might find a rub in examination, but simply by analyzing the chest pain, you can suspect pericarditis, which is characteristically showing this kind of history, right? This kind of history. Okay, and patient will have, commonly it's post-viral. So recent history of fever, chills, and so on. So again, this is an important differential diagnosis to make. Then far more common cause of chest pain is a GORD, very common in the wards, very common in the wards. Of course, you have to exclude acute coronary syndrome first, and then you think of these things, right? So is the burning chest pain coming after meals, bending, reflux symptoms coming to the throat, acid taste, right? You cannot miss again, it's a very typical symptom. So these are not so difficult cases, but important cases that you need to make a diagnosis in and by analyzing the chest pain symptom, right? Okay, and you get a rarer symptoms like esophageal spasm, rarer condition, right? Very difficult to differentiate from angina. So we don't expect that this for you to diagnose, but it has its symptomatology where you can suspect, right? Okay, it can be differentiated. So from angina can be difficult, right? And there may be associated difficulty in swallowing, maybe not there, right? So just remember there is a condition called esophageal spasm, which can cause differentiation from angina difficult, right? That's rare, very rare. Then comes whole heap of musculoskeletal causes, right? You will cause the commonest of which is costochondritis, where you find tenderness in the costochondral joints, right? Okay, tenderness in the costochondral joint. Then this in a younger patient or a middle-aged patient, anxiety, panic attack is very well known to cause severe chest pain, severe chest. They get a sensation of chest tightness, can't breathe, they cry, they shout, they struggle, right? You can see in the ward a young female getting admitted with severe chest pain, past history of anxiety, illness, and so on. So it's not very difficult to make a diagnosis, right? So basically, I have just ran through the causes of chest pain, and this one slide gives you a kind of a bird's eye view of analysis of chest pain. So comes with chest pain, you can divide just the chest pain into three broad categories. One is the typical one that we should never miss. I told you for this onset, the typical acute coronary syndrome, and then comes the other causes that, along with the acute chest pain, that are life-threatening causes other than the acute coronary syndrome, and then pleuritic type of chest pain, these causes, and the other causes like aortic dissections and so on and so forth, right? So if it is acute coronary syndrome, go in this line. If it is pleuritic type of chest pain, go in this line. If it is not acute coronary syndrome, not pleuritic type of chest pain, then go down this line. This is one just algorithm just to show you one way of investigating, right? So this is next to dissection. This is the other important part of chest pain that you should never miss, right? One is the aortic dissection. I told you the classical triad, clinical triad will be applied. This, of course, can be very difficult to diagnose, but history is very, very strong to point out. What's the history? Always, not always, usually this comes in patients who are likely to get DVT. So who are the patients who are likely to DVT? Either you get a referral from the orthopedic ward, either you get a referral from the surgical ward, for fracture, immobilized for some time, orthopedic surgery done 2-3 days ago, or oncology ward, right? Patient is being treated for cancer, bedridden patients, right? This kind of patients comes with acute onset chest pain, right? So these can be MI or pulmonary embolus, right? Okay. So this is a condition that have to be suspected based on the history. So previous history, what was the history that brought to the hospital? Was it a cancer treatment? Was it a recent surgery to the general hospital surgery ward or orthopedic ward, and so on, right? This kind of patients who will present with acute onset shortness of breath and difficulty in breathing and they have persistent hypoxia if you test by pulse oximetry. And this is a condition that should never be missed. And if you strongly suspect, you start enoxaparin treatment, awaiting investigation. You don't wait till you diagnose to start enoxaparin. If the clinical suspicions are strong, please remember that you start enoxaparin immediately pending confirmation by CT. CT coronary angiogram, CTPA, or sorry, CT not coronary angiogram, CT pulmonary angiogram, which is done on all the major hospitals. Until you do the CTPA, you need to start treatment based on clinical suspicion. Right. So we go to the common one that you like to see 90% of the time. So 90% of your serious cause of chest pain is acute coronary syndrome. 90% of your serious cause of chest pain, acute coronary syndrome. It will be about 10% whether it's pulmonary embolism, aortic dissection, esophageal rupture, pericarditis, myocarditis, or 5 to 10%, right? 90% it is acute coronary syndrome, right? Okay, so they can come in various ways. The ones you are taught in the university, typical symptoms are only present in quarter of the patient. So remember, if you apply the classical teaching, you will only diagnose 25%, because only 25% of the people come with classical symptoms. So other 75% will come with various atypical symptoms or silent symptoms or gastritis-like symptoms and so on. So please be aware that don't depend on classical symptoms to diagnose acute coronary syndrome, especially in women and elderly patients in diabetes. They don't come usually with classical symptoms, right? So that is my important lesson in diagnosing acute coronary syndrome. And please remember the definition of myocardial infarction. This will come over and over again, this issue, right? There are patients coming with chest pain, patients having abnormal ECGs, patients have positive troponin. My goodness, troponin can be positive even due to non-ischemic myocardial damage, right? So remember that positive troponin in a patient with chest pain is not diagnostic of myocardial infarction. That is the message that you got to start put into your head. Troponin should be positive, and plus patient must have one of these for you to diagnose, right? So this is the definition. There should be rise and fall of troponin, that is essential, right? Plus any one of these 5. Either patient should have symptoms of ischemia, that is typical chest pain. ECG can be normal, ECG can be abnormal, ECG can be perfectly diagnostic feature, but it doesn't matter. Whatever the ECG is, if the patient comes with symptoms of ischemia, even with a normal ECG, positive troponin is enough to diagnose. Secondly, if the patient does not have symptoms or no symptom at all, but if there are STT changes with positive troponin, you make a diagnosis, right? If the patient comes with a first ECG where there are no Q waves, and tomorrow ECG there's a Q wave, next ECG, still you make a diagnosis. ECG is normal, troponin is positive, the ECG is normal, symptoms are atypical, but you do an echo, you should see a regional wall motion abnormality, and you compare that with the previous echo that was not there, and it's a new regional wall abnormality, you make a diagnosis, right? So this is a very complex area. You will repeatedly be encountered. Troponin positive, troponin positive, troponin positive, troponin positive. You always start everybody on enoxaparin and so on. But to see carefully, if you analyze, the troponin positive will, in some patients are due to falsely high due to non-ischemic myocardial damage. Example in chronic kidney disease. Another example in severe sepsis, right? Patients can have rise of troponin, okay, with atypical ECG changes, right? But their troponin is rise due to myocardial damage, which are caused by myopericarditis as a result of uremia, uremic myopericarditis. So it's a complex issue. Only a consultant is capable of solving, but you should be aware of it, right? You should be aware of it. If you don't have typical symptoms, if you don't have typical ECG changes, if you don't have typical echo findings, please ask your consultant, should we start enoxaparin or not, right? That is something that you don't waste enoxaparin, right? Otherwise, you all can discuss and start enoxaparin and tell the consultant, or you ask your registrar and start and whatever, right? So remember this point. So you have to make a diagnosis of myocardial infarction. As much as making a diagnosis is very important, how you can avoid making a misdiagnosis, avoid missing an MI, right? So don't miss an MI, right? One way you can falsely diagnose myocardial infarction and treat with enoxaparin for a false positive troponin, right? The other way is even worse, is missing a myocardial infarction and saying that it is some other cause. That is worse mistake than that, right? Okay, so sometimes we tend to think that some other cause, chest pain, looks like a muscular pain, we don't order ECG. Don't do that. See, all chest pain patient order the ECG unless an obvious pneumonia or obvious diagnosis. Otherwise, always order ECG. Not ordering a ECG is a mistake number one, right? And second mistake is misreading or misinterpreting the ECG findings, right? So the third mistake is not ordering serial ECGs, right? You can order one ECG and say, nothing wrong and go. But if you order a second ECG, you might find changes. So when you are suspicious, always do a serial ECG. So these are the points that you should remember when you start working. How am I not going to miss? How do I avoid missing a dangerous diagnosis? So not ordering an ECG you can misinterpreting an ECG, you can miss an MI. Not ordering an X-ray, you can miss a lot of things like rupture of the mediastinum, you can miss aortic dissections. So X-ray, ECG, right? Very, very important tools when it comes to management of acute chest pain. Right? So this is how these slides tell you all about the ECGs that you need to take into account. Make sure your ECGs are done as soon as the patient comes. Don't delay, because early diagnosis is very important, right? And first ECG, I told you, is you may not be able to diagnose in a patient with chest pain of half the patients, 50% of the patient. So you'll have to repeat the ECG. So remember, if you may not be able to diagnose in the first ECG, please repeat it after 1 hour. And always ask the patient for a previous ECG if available, right? And do serial ECGs. Make note of ST segment, the most important component of the ECG. Not the Q wave, not the P wave, not the T wave, is the ST segment. So concentrate on the ST segment first. Is the in chest pain? How about the ST segment? It is elevated, depressed, or then go to the T wave. Okay, so these are the points that you should remember, right, when you are analyzing the ECG, right? Then, depending on the ECG, you can make a diagnosis of ST elevation MI, or ST non-ST elevation MI, whether it's a high-risk MI, it's a low-risk MI, and so on, right? Okay, so ECG is a vital tool in the analysis of chest pain. Then I told you, chest pain, another vital tool, pneumothorax, pneumomediastinum. Pneumothorax, another thing which I didn't mention, but it won't come to a medical board normally. That's why I did not mention much, but you might get a pneumothorax coming to a medical board as well. For admitting officer might not suspect, and then it might come to a medical ward. Then in that case, X-ray. So pneumomediastinum, pneumothorax, two causes can be diagnosed by simple X-ray, right? Even heart failure. even aortic dissection. So X-ray, ECG, X-ray, ECG. Always remember, you will be masters of those two investigations. 90% of the problems can be sorted out by X-ray, ECG. Then I told you about troponins, right? I got 5 minutes more. But troponins, I told you, one of the most difficult tests, but the important test, right? Don't go away with the idea that normal troponin excludes MI. Yes, normal troponin excludes MI if done at least 6 hours after the onset of chest pain. Not before that. You cannot, if you want to exclude before that, you need to go for high sensitivity troponin, HS troponin. That is available in some hospitals in major cities. High sensitivity. That if it is normal within 1 hour of admission, you can rule out MI. But not the normal troponin that is can be normal even up to 6 hours after MI. So remember this point. If you have facilities for high sensitivity, you can exclude MI if it is normal after 1 hour. Right? So why is troponin so notorious? Because it is can confuse you for MI in a lot of other conditions when there is no MI. Right? If a patient comes with chest pain due to pericarditis, CKD, it can be positive. If the patient gets pulmonary embolism, it can be positive. Right? If the patient has severe sepsis, it can be positive. So it's a very, very tricky investigation which has to be interpreted in the context of the patient's presentation. So context is very important. How the patient presented, what is the type of symptom, what is the ECG. On that basis only you are supposed to interpret a positive troponin, not just taking the troponin itself. Right. So there are no non-cardiac causes of positive troponin. There are cardiac causes as I told you, myocarditis, aortic dissections, arrhythmias. They all can cause positive troponin with normal, without causing myocardial infarction, right? Without causing myocardial infarction. Without causing myocardial infarction. So that's a very important point. So you can have a cardiac damage causing rise in troponin without suffering a myocardial infarction. If you give a shock, if you give a CPR, if you give a DC shock, that shock itself can cause myocardial damage and rise in troponin. So huge amount of information has to be known about troponin before you interpret troponin. So I think I have told you what I plan to tell you. So please remember acute chest pain, not to miss acute coronary syndrome. Try to diagnose acute coronary syndrome early. If it is not acute coronary syndrome, next step, try to exclude acute coronary syndrome early by high sensitivity troponin if you have. Otherwise, by serial ECGs, serious troponins, right? Third point, once you exclude acute coronary syndrome, make sure it's not another life-threatening cause of chest pain that I mentioned to you, dissection, embolism, and so on. Right? Okay. So that's the point I want to stress as a summary. So any question, 1 or 2 minutes, I can answer because they're almost time. Any quick questions? Understood or understood? So can I assume there are no question? So I will wish you all the best for a happy internship. Right? Thank you.
Thank you, sir, for that interesting lecture. So if you all have any questions, please type on the chat box.
Chat box.
So next up is another very interesting lecture by Vimalasiri Uluwatha, consultant physician at TH Karapitiya on leptospirosis. So over to you, sir.
Thank you, Roshan. Can you hear me? Roshan, can you hear me?
Can see. You can share the slides.
All right. Can you see my slides, Roshan?
Yes, sir. Need to make it full screen.
All right. Thank you. Good morning, everyone. I am Dr. Vimal Siruluwathige, one of the physicians from Teaching Hospital Karapitiya. And my topic is today leptospirosis for interns. As you all know, leptospirosis is a very common febrile illness. Wherever you work in Sri Lanka, you will come across this problem, and it's as common as dengue sometimes. And in some places, and depending on the duration, season of the year, you might see more cases of leptospirosis than dengue and other viral infections. So with that introduction, let me introduce this topic. Leptospirosis is the most widespread zoonosis in the world. It presents all over the continents except Antarctica. So you can see that it's a worldwide infection. And it infects more than 1 million people and is responsible for more than 60,000 deaths per year worldwide. So what about the Sri Lankan scenario? According to a WHO study done published in 2015, Sri Lanka has been identified as one of the hyper-endemic countries to have leptospirosis in the world. So it's a common cause of acute febrile illness in all over the country wherever you work, except little less only in one district, is Jaffna district. I think it's a little less or not found so far, except that all the other districts in the country has been found to have this common infection, especially so in wet zone of the country. And early diagnosis and initiation of specific treatment is essential to save lives. So you have a very big responsibility and duty to recognize this infection and start treatment. So this is the map of the world of leptospirosis. And as you can see, Sri Lanka is in red, indicating that it's one of the highest in density in the world. So why this renewed interest about leptospirosis world over? There's a world over renewed interest of leptospirosis lately. And there are a few reasons why this is becoming more and more common and more hot topic around the globe. So one of the important reason is that the frequent endemics occurring all over the world due to environmental factor, changes in climate and increase in pollution and overcrowding around the world, causing increased incidence of leptospirosis. And also, this disease thought to be changing, and it appears to be migrating from rural areas to urban areas. Earlier, this disease was thought to be predominantly a rural infection, but now we can see that there are many patients becoming, leptospirosis is migrating into urban communities as well. And also the categories of society where the high risk, we thought it was farmers and high risk other groups like people who are engaged in various agricultural activities and animal associated with animals like with surgeon. But now the situation has changed from that to involve many sectors of the community where you would not suspect leptospirosis normally. So it's changing and it's migrating disease involving and engulfing whole society. And thirdly, the clinical pattern of leptospirosis has changed. And it's clearly demonstrated in many countries in recent past. It has changed. This change has occurred on geographical basis. Actually, even the different parts of the same country may have different dominant clinical patterns. For example, pulmonary hemorrhage in leptospirosis is predominantly a disease of wet zone in Sri Lanka. In many other countries also, this condition, this dreaded complication of leptospirosis, which is pulmonary hemorrhage in leptospirosis, has been recognized in geographically different parts of the country country in the same different part of the region in the same country. So this has been documented, and Sri Lanka also this has been demonstrated. It's a mainly predominantly a disease of wet zone. So another causes for the leptospirosis becoming more and more common is now it's considered to be a more severe form of disease compared to the we saw the cases we saw earlier some time ago. Now the severity of the disease pattern has changed. So taking into all this consideration, there is a renewed interest of leptospirosis. Whatever the scenario when you consider in Sri Lanka, the number of deaths due to leptospirosis is significantly higher than the deaths due to dengue. This is not my own finding. This is actually a paper published by one of the leading scientists from our country, Professor Agampodi from Rajarata University. He published this paper in 2017, and he said that in 2017 there had been more than 200,000 cases of dengue, confirmed cases of dengue, which was the largest outbreak, and that led to 400 deaths during that epidemic of dengue. But in the same year, the estimated number of deaths due to leptospirosis is 730 deaths. So you can see the difference. Well, now, even though dengue is a very widespread and very very large outbreak compared to dengue, leptospirosis causing the mortality and morbidity is more, and the number of deaths are much more than that due to dengue. So most of these patients in leptospirosis died because of the multi-organ failure. Among the fatal cases, there have been many cases with pulmonary involvement, lung involvement. So the estimated case fatality rate of leptospirosis was more than 10 times of that of dengue, according to his conclusion. So what is your role as an intern in diagnosing and treating this condition in ward setup? First of all, you must know how to take a proper history, which in relation to diagnosing and arriving at a diagnosis of leptospirosis. And also, you can help to identify a suspected case, which I am going to describe later on what a suspected case of leptospirosis is. And one of the most important your job is to differentiate it from other common febrile illness like various other viral infection, and of course, more common and more deadly dengue. So my slides are not going. Yes. And also, it's your responsibility to order relevant investigation initially so that you can differentiate this condition from other febrile illnesses. And then again, your responsibility to monitor these patients to identify severe cases of leptospirosis. So identifying a severe case of leptospirosis is very important because the severe cases of leptospirosis causes higher mortality as compared to mild cases. So the other responsibility that you are supposed to be responsible, look out for dangerous complications of leptospirosis, so that you need to monitor these patients and identify complications quite early and alert your seniors. And also, as an intern, you are allowed to start initiate treatment quite early in this stage. If you're suspecting a case of leptospirosis, actually you are allowed to start antibiotic. This is one of the instances where you are allowed to start antibiotic on your own, taking decision. So treatment as early as possible is one of the your responsibilities after recognizing this condition. So you need not to wait until your seniors to start treatment. If you are suspecting, if you are confident enough to suspect a case of leptospirosis, yes, you can initiate treatment. And then the last but not least, the confirmation, because confirmations is only by doing serum studies done at MRI, which is usually done, the serum is collected after 7 or to 10 days of illness, not in the initial stage. But don't forget that to collect this very important sample of confirmation sample to be sent to MRI for confirmation. And one of the other most important responsibility is notification, so that in the future we can hope that we'll get a nice bunch of reliable data with regards to the leptospirosis around the country, so that it's your responsibility to notify these cases on once you diagnose and treat. So to start to elaborate a little bit more on this subject, I'll go in to discuss a case scenario. It's a 14-year-old boy, school student from Imadu, admitted to teaching hospital Karapitiya with fever, arthralgia, and myalgia of 3 days. And then on examination, revealed he was febrile and had a respiratory rate of 22, and his saturation was normal. He was with tachycardic, pulse rate of 100, and blood pressure was normal, and rest of the examination was unremarkable. And initial investigation showed his white cell count was 9,100 with neutropenia leukocytosis, hemoglobin was 10, and platelet count was 70,000, which is low. His creatinine was normal, and CRP was little high. So based on this history examination, we so the other thing, now how to do now when a patient comes like this, admitted to your ward like this could be quite possible that it could be a case of dengue or any other viral infection of leptospirosis. So how are we going to differentiate it from dengue, which is the other common deadly disease you need to identify quite early in the phase of illness? So history plays a very important role in the differentiating dengue from leptospirosis from dengue. So it's very important to explore history, to looking into the possibility of patient being exposed to a muddy water. Or you need not to always, I mean, it's quite irrational if you only confine yourself to asking about whether the patient is been working in paddy field, because it's more than that. There are so many people who get into exposed into contaminated water many other ways. In Sri Lanka, being a tropical country, you get a lot of these situation where you would get exposed to contaminated water, as you know. And contaminated water plays an important role, like in flood water, and when you wade into a flooded street or flooded water, especially in muddy area, so you are considered to be exposed to this high risk exposure. So even working in a wet soil, coming into contact with wet soil can cause this infection. It's not only water, even wet soil can harbor this infection. And also working in rat infested areas, like even in an in-house, you can get exposed to this infection if it is if that place is infested with rats. So other thing is, in the history and examination, the myalgia becomes a very important finding or the symptom, which will important to differentiate it initially from other illnesses. Myalgia mainly is lower back and thighs and calves, as compared to the myalgia, which is also common in dengue, which is usually a generalized myalgia, whereas in leptospirosis, mainly in the lower back and thighs. So headache is a very common feature in dengue, but it's not a dominant feature in leptospirosis. Apart from that, initial basic investigation would suggest that there will be an very early rise of serum creatinine, which can even happen in first or second day of quite early in the disease, and which is very characteristic of leptospirosis. And also rise in CRP is quite common, but it can happen really in dengue as well. So it will not definitely tell you that whether it's leptospirosis or dengue, but it is more commonly you will find rising of CRP is more commonly with more favors diagnosis of leptospirosis. Apart from that, urine sediments like hematuria and evidence of hematuria and proteinuria also favors the diagnosis of leptospirosis. So within 1 or 2 days of admission, So you can, if you can gather this information, you can confidently say that you are dealing with a case of, probably a case of leptospirosis. So coming back to our case scenario, now even though he was a 14-year-old school boy, with the available evidence like low platelet count and high CRP, we suspected leptospirosis. But we went ahead and explored his history, and there he actually came out with a story that he was briefly stepped into the paddy field where his father was working. So there was a brief but very definite exposure history positive for leptospirosis. With that, we came to conclusion that we are dealing with a suspected case of leptospirosis, but later on our conclusion confirmed, and with the availability of serum creatinine, which was going up, and CRP also rising. So our work in diagnosis became, it was a case of suspected case of leptospirosis. What do you mean by suspected case of leptospirosis? As you all know, now it is very important to have a working diagnosis of leptospirosis when the when your confirmatory tests are taking times to come. So what is the case of suspected leptospirosis? In any patient who is coming with acute febrile illness from an endemic area with a positive history of high risk exposure to contaminated water, together with two of the following symptoms or signs: myalgia, headache, arthalgia, conjunctival suffusion, meningism, shortness of breath, anuria or liguria, jaundice, evidence of bleeding, and evidence of shock. So all these indicate any two of these things together with a history of high risk exposure in an acute febrile illness patient, you can diagnose or you can name as a case of suspected case of leptospirosis. So why do you need to define this as a suspected case of leptospirosis? Why? Because as I told you before, leptospirosis is a clinical diagnosis initially, because its confirmation takes time, at least 7 to 10 days maximum would be the ideal time to send the confirmatory test, but you can't wait until such time, because early diagnosis is important to start treatment. Because as you earlier the initiation of antibiotic treatment will definitely reduce the complication of leptospirosis. So it's very important that you start diagnosing these patients and starting treatment, initiating treatment with antibiotics, so that you can prevent them heading into more complication in the later part of his illness. So it's one of the other important things I need to highlight again and again is the importance of exposure history. So it's essential, because it's an essential component of the clinical diagnosis, or initial diagnosis. So please explore the history with regards to a positive, to find out the positive exposure history. Do not just confine to traditional modes of exposures, and as I told you before. And apart from high-risk group, many other people also can get infection. For example, we came across an 8-year-old grade 8 student who came with severe leptospirosis. The only possible exposure he had was that he had cleaned his classroom with his classmates after the weekend, and they are probably that place would have been rat infested. Another case of temple cleaner who came with severe leptospirosis after cleaning the shrine room where it has been heavily infested with rats. And another case of software engineer who came with severe leptospirosis. He developed pulmonary edema, pulmonary hemorrhage as well. And only positive, he has been working in Colombo, but he has had a bathe while on a trip in a remote part of the country, and that was the only exposure, and he ended up having severe leptospirosis. So there are so many sporadic cases coming in various sectors and parts of the society, so be aware of that. Now, in summary, the febrile illness plus possible exposure history with compatible history, you can name them as a suspected case of leptospirosis. So what are the initial investigation in this type of patient you need to order? So full blood count is very important. CRP is again an important investigation that you need to order. UFR gives you some more information, supportive, as well as the indication of the severity of the illness as well. And also serum creatinine, which has to be done on the first day itself or the as early as possible during the illness. The rising of serum creatinine is quite important to differentiate it from other illness. So coming back to our case scenario, on 24 hours after the admission, his urine output reduced to 150 ml per 6 hours. And his blood pressure dropped from 110/70 to 90/60. And his saturation also dropped to 92%. And he became more tachypnea, but still his chest X-ray was normal. And 40 hours after the admission, his saturation further drops from 91 to 75. And his blood pressure needed noradrenaline to support at 100/60 level. And at the 48 hours of admission, that is on the 5th day of illness, he developed hemoptysis, and his chest X-ray showed bilateral changes, and the blood gas revealed that he was in arterial hypoxia. So this was the first chest X-ray which was done on admission when he became short of breath, which was appeared to be normal. And this was the second X-ray done on 48 hours after the admission, showing that bilateral hazy shadows, small nodular opacities, more than right more than left side, and which these shadows are described as alveolar shadows because it look like cotton wool shadows. So it is a very likely that this appearance is very likely to be due to pulmonary hemorrhage. So we diagnose this case as a case of leptospirosis complicated with pulmonary hemorrhage. So what is the traditional classification of leptospirosis? Usually, more than 90% of the cases of leptospirosis, as you all know, are mild form of cases, which are thought to be anecdotal. But the severe form of leptospirosis thought to be icteric, and when it is associated with other, this classical, right, jaundice, renal impairment, and bleeding diastasis is called Weir syndrome, thought to be the severe most form of leptospirosis in the early days. But now the thing has changed, and now we think that now the newer thinking pattern is that often the clinical features of leptospirosis depend on the organ that is involved. If it is predominant renal involvement, you will get a patient with evidence of renal impairment. And if the patient's predominant organ involved is liver, you will get evidence of liver involvement. And if the patient's main organ involvement is lung, you will get evidence of pulmonary involvement. So the newer findings are that suggest that no system or organ in the body is immune to leptospirosis. However, the mortality is very high when there is a pulmonary involvement, and which is thought to be more than 70% of mortality, associated with more than 70% of mortality. And also, the mortality is higher when there is a concomitant renal as well as cardiac involvement. Mortality become even reach more than 70%. So what you need to take is that the patient with severe leptospirosis may or may not be icteric. So don't wait until a patient becomes icteric to diagnose a case of leptospirosis. Initial suspicion and the background history will make you suspicious of this disease, and you can name them as suspected case of leptospirosis in relevant scenarios. So it's very important to differentiate mild form of leptospirosis from severe leptospirosis, because severe leptospirosis, which consists of 10% of the cases, associated with very high mortality. So how are you going to differentiate severe form of leptospirosis from mild cases? If you are dealing with a patient with reduced urine output, that is why it's important to monitor these patients regularly. It's your job to monitor these patients once they are admitted to the hospital. If the patient's urine output is becoming reduced, And if the patient's serial electrolytes showing evidence of hyperkalemia, and if the patient's blood pressure is dropping and showing early evidence of shock, so you are dealing with a severe case of leptospirosis. Please remember these basic parameters to monitor and recognize severe leptospirosis. And apart from that, if the patient is becoming tachypneic, breathing very fast and heavy, and also if the patient showing evidence of hypoxia, and if the patient is coughing out sputum with blood, so and chest X-ray showing infiltrates in the chest X-ray as additional features to suggest you are dealing with a pulmonary hemorrhage. So it's a very dreaded complication of leptospirosis. Recognized in these cases of severe leptospirosis saves lives. One of the important parameters as a house officer you need to monitor to identify severe cases. As you can see, pulse and blood pressure would be very important because you will recognize early shock. And shock is a very common finding in severe leptospirosis that has been very well documented. It's behave like just like pyogenic sepsis. Initially, severe leptospirosis leads to shock. Respiratory rate and saturation is important parameters together with evidence of hemoptysis, looking for hemoptysis and doing serial chest X-ray to find out whether the new changes are appearing, and which is suggestive of pulmonary hemorrhage. And also, if you monitor their urine output, and if you do serial UFRs and do serum creatinine and electrolyte, you can recognize acute kidney injury quite early. And also, if you do see ECGs and troponin, you would recognize, or you can identify myocarditis, which is one of the more very severe form of leptospirosis, which lead to higher mortality. So these are the basic parameters that any of you can monitor in your whatever the stage of your hospital facilities are. I think these are not difficult parameters to monitor. If you have little interest on these patients, and it's very important to recognize these patients quite early in their disease, to pick these complications quite early so that you can intervene and prevent them going into a severe form of complications further. So a little bit of pathophysiology regarding acute kidney injury, where it is mainly two types. The first type of acute kidney injury, which happens quite early in the disease, is due to acute tubular necrosis due to direct toxicity of leptospirosis. As you know, leptospirosis can be found adhered to the epithelial surface of the renal tubules, which can exert direct toxic effect to the renal tubules, which causes direct acute tubular necrosis, leading to renal impairment quite early in the disease. So by giving antibiotics, you can retard the process, and that's why it's important to starting antibiotic quite early in the disease so that you can reduce the number of organisms, infected organisms in the kidney, so that you can prevent them going into severe form of renal impairment. So in addition to that, there is another form of renal injury which occurs sometime later due to immune-mediated injury. It's called acute interstitial nephritis, which takes time to develop, but together with the acute tubular necrosis, the patient later on can go into persistent or persistent renal impairment. And also dehydration is quite common in these patients, which can predispose acute kidney injury, and rhabdomyolysis also can occur rarely in this patient, which also contribute to acute kidney injury. Right, little bit of pathophysiology regarding myocarditis, and presence of leptomyocarditis is evident usually by ECG changes, which is very common. Actually, there are a range of things that ECG shows as evidence of pulmonary myocarditis, of leptomyocarditis, AV conduction defects, ventricular depolarization abnormalities, and commonest arrhythmia is atrial fibrillation. And if you have facility to do echocardiogram in the acute stage, it will show regional wall motion abnormalities and LV dysfunction, evidence of myocarditis. And also, if you do cardiac enzyme, often with the ECG changes, together with the ECG changes, you could see, you can demonstrate that elevation of cardiac enzyme confirming the myocardial injury. So little bit on pathophysiology of pulmonary hemorrhage. This is a normal alveolus, a sketch of cartoon of normal alveolus. And this is more of a same thing in a more histological type of diagram, where you can see that most important part of this alveolar is the alveolar capillary membrane, where the capillary epithelium is lying very approximately to the type 1 respiratory cell, which is in a green color as a tapering thing. So this together with this type 1 respiratory cell membrane and capillary pulmonary capillary epithelium forms the alveolar capillary membrane, which is the most important part of the lung, which enables gas exchange. What happens during leptospirosis pulmonary hemorrhage is that there is a linear deposition of immunoglobulins and complements on the alveolar surface of the epithelium. It's something like that, and which causes a direct damage to alveolar capillary membrane and results in bleeding into alveoli. So it's called alveolar hemorrhage. So it's entirely immune-mediated injury. So pulmonary hemorrhage can be very severe. One of the patients who presented to us with typical history of leptospirosis, suspected leptospirosis, and he became short of breath. And when we did his X-ray, this is what we found. Hardly any normal lung tissue, lung field, and it's bilateral severe pulmonary hemorrhage. And there's another patient who came with suspected history of leptospirosis, and he started coughing out blood, and he went into respiratory ICU ward. And we had to intubate him as an emergency procedure to save his life. And this is what we saw once he was intubated. You can see that blood is coming through the ET tube even into the ambu bag. This is the third patient, one of the patients who was not lucky enough to survive and succumb to his condition. And later on, we did the post-mortem, and this is what we found in his lung when it cut open. You can see that it was the severe hemorrhage has occurred into the lung. So it can be a very severe form of leptospirosis with associated very high mortality. So what is the management of this condition? Leptospirosis. As I told you before, dehydration is quite common in this condition, and use normal saline, but remember not to overload, especially if you are thinking of suspect pulmonary hemorrhage. Don't overload, just get the opinion of the senior, how much to give. And one of the most important aspects that you can contribute in this management of these patients are the monitoring of these patients, essential parameters of monitoring: pulse, blood pressure, urine output, and saturation, etc., to find out whether the patient going into develop a severe form of leptospirosis or severe complications. And also, it's very important to start antibiotics quite early in the disease. So if you are dealing with a case of mild leptospirosis, you can start oral antibiotic, doxycycline 100 mg twice a day, and azithromycin or azithromycin. And if you think that you are dealing with a severe case of leptospirosis, they need IV antibiotic, intravenous antibiotic, IV C-penicillin or ceftriaxone 1 gram BD would be ideal. So patient may need inotropic support if the blood pressure is not stable, and even after adequate hydration. But one of the important things to remember is that if you are suspecting you are dealing with a severe case of leptospirosis, please inform your seniors and get their opinion regarding further management. The management of severe leptospirosis is essential to continue close monitoring, as I told you before, because monitoring plays a very important part in early recognition of complications and preventing them going into further problems, developing into further problems. And so it's very important that to continue monitoring these patients' stages. And if the patient is having severe evidence of severe acute kidney injury, hemodialysis would be very useful, and you have to arrange that. If the facilities are not available, you may have to inform your seniors and transfer the patient to a place where this facility is available. And if the clinical evidence suggests that you're dealing with a pulmonary hemorrhage, IV methylprednisolone is quite useful. It has been shown to be beneficial in pulmonary hemorrhage of leptospirosis. And also plasma exchange. This is what we have shown in teaching osteotherapy. A team of us did a small study and found that the therapeutic plasma exchange is shown to be beneficial in management of pulmonary hemorrhage in leptospirosis. Now it is being widely used all over all parts of the country, and it has saved many lives around the country. So plasma exchange is an option which is available in the major hospital. So if you're suspecting pulmonary hemorrhage quite early in the illness, it's better to transfer these patients to the hospitals where this facility is available. IV immunoglobulin is another option that can be used in the treatment of pulmonary hemorrhage. Apart from that, your duties are to arrange blood transfusion and platelet transfusions whenever your patient, depending on the patient requirement, you may need blood transfusion and platelet transfusion. Apart from that, remember not to forget that the confirmation test after 7 days of illness, you can send a serum sample of serum to MRI to confirm your diagnosis. So last but not least, the notification is a very important step in your management of these patients, so that you can, we can hope that we get more reliable data with regards to leptospirosis in the country in the future. So this therapeutic plasma exchange is a simple procedure with the use of simple machine and plasma. This is the same patient I told you before, the 14-year-old schoolboy who came to Parapiti Hospital and is being diagnosed as pulmonary hemorrhage, and therapeutic plasma exchange is in progress. And this is the first X-ray we started with, showing bilateral hazy shadows, and this is after a few cycles of therapeutic plasma exchange, which is making a good clearance of chest X-ray, and his condition improved quite dramatically, and he made an uneventful recovery a few days after this therapy. So in summary, leptospirosis is a very common cause of acute febrile illness in Sri Lanka. The exposure history is quite important in the early diagnosis of illness, because early diagnosis is quite important in the management. So important to identify severe cases of leptospirosis from milder cases, because severe cases of leptospirosis are associated with high mortality. And it's very important that continued close monitoring of these patients to recognize severe cases, and also to early identification of complications of leptospirosis, such as acute kidney injury, pulmonary hemorrhage, and myocarditis. So it's very important to recognize these cases and escalate the care to a higher level depending on the patient requirement, depending on the complication that the patients have developed. And also, it's your responsibility to start antibiotic quite early in the disease. As I told you before, you are allowed to start antibiotic in this patient quite early in disease, unlike any other condition where you are a bit discouraged to start antibiotic whenever you come across patient with a fever. But here, if you are suspecting, if you are reliably diagnosed, can suspect a case of leptospirosis, you are allowed to start antibiotic early in the course of disease. And remember that plasma exchange is an effective mode of treatment in the treatment of pulmonary hemorrhage. Thank you. And yes, I can answer any questions if you have any questions.
Yes. Thank you very much, sir, for that very important lecture. If you all have any questions, please type on the chat box. We are a little behind the time. So next up is Dengue and the Essentials by Dr. KVC Jara, consultant physician. Sir, can you hear?
Yes, now There is one question.
Yeah.
Sir, can you please identify briefly, use my glasses. Can you please briefly explain the prophylaxis doses of doxycycline and how we should, yes, okay. How we take it. Now, the recommended prophylaxis for leptospirosis doxycycline, which is to be taken 2 capsules per week as prophylaxis, and you can advise when you come across a risk behavior or risk patient with risk of exposure to leptospirosis, take this capsule, 2 capsules per week. So that is quite effective. Actually, we have seen so many patients who are being, especially farmers who takes this thing regularly before starting their field activities. Actually, they are quite, this is quite safe and effective, and which prevents getting doxycycline, infection. Now, one very important thing to tell you is that sometimes even post-exposure, if you accidentally fall into a stream of water, or if you get exposed to flood water accidentally, even after getting exposure within 24 hours, if you take doxycycline recommended dose, actually that will prevent you getting infected. So that's an important piece of information as far as we are concerned, because we are not often, and we think that we are not in a high risk group, but still there's a chance that we might get this infection. So the second question, even if there was no skin breach, can someone get lepto after exposure? Probably yes, through the mucosa you can get, even without skin breach. Yes, some might get infected with through the skin mucosa. Third question is there an association between leptospirosis and hemolytic uremic syndrome in both plasma chain has place? I can't exactly tell you with evidence base, but there may be, but I am not sure about this two condition, but because the clinical picture is very much similar, because of that you cannot differentiate one from the other, one reason. And so it's, I can't tell you exactly with good evidence, because there is no adequate evidence available.
Right. Thank you, sir. We'll start the short of time, sir.
All right. Thank you.
Thank you very much.
Thank you very much.
So we go to the next lecture by Janaka, sir. Over to you, sir.
Yeah.
So if you all have questions, please type on during the lecture so we can take it up as soon as we finish the lecture. So over to you, sir. Sorry about that.
I just can't get the. Can you?
We can see you. So just make it full screen, sir. That's all.
Yeah, there's somewhere here, but.
Okay.
That. Hello? Can you hear me?
Yes, sir. You can start full screen. Yes.
Right. Okay. Right. Sorry about the delay. Now, this is a very short lecture, and I'm just trying to teach you a few basics about dengue management, what we expect from a house officer. Now, we know that many patients with dengue virus are asymptomatic, and they can be having just a simple viral fever, dengue fever, or DHF, or expanded dengue syndrome. I'm not going to go into the differentiation. So it's viral fever, can be asymptomatic or symptomatic. If it is asymptomatic, we don't have to admit the patient to the hospital. Symptomatic viral fever, again, you manage this as viral fever with just paracetamol. DF, again, there can be some people with dengue fever having a little bit of bleeding from the gums and things like that, but nothing to worry. DHF is where there is leaking, and that is the worry. And that DHF can expand to have unusual manifestations like myocarditis and other things which are troublesome, but I'm not going to discuss on this situation, this lecture. But DHF with shock and DHF without shock is what we want to manage, especially to prevent a patient with DHF from without shock going into shock. Now, this is again something that you know for a long time. From usually between the day 3 and 6. This is the period where the patient can leak and can bleed and have shock. But we have seen sometimes even on day 2, people go into develop leaking, right? And sometimes till the end of day 7, they are still not fully recovered. So you can't go by the exact time period, but it is usually after the day 3 that we have to be very careful. Now, do you need to do dengue antigen? It's not available in the government sector. I don't think we have to, we really need to do dengue antigen test. But if they come with the dengue antigen test done on first 3 days, if it is positive, okay, that's good. We know it is dengue. Even if it is negative, you can't exclude dengue. So you don't have to really worry about the antigen test because we manage the patient on patient's clinical parameters, not on the lab reports. So the phase that we are worried is the critical phase. So what is critical phase? That is a phase where the patient is leaking plasma from the blood vessels. So that usually occurs towards the end of the febrile phase. Initially, the dengue patients have high fever, body aches, then they develop leaking. Now, this is important when somebody comes to you with high fever and body aches. We don't allow in the wards what happens in the outside. People give things like diclofenac, ibuprofen to relieve the fever and body aches, mefenamic acid and things like that. We all know that is dangerous in dengue. And some people do a full blood count, and if the platelet count is normal, they give diclofenac. That is again dangerous because initial full blood count can be normal. Initial dengue antigen can be normal. So you can't exclude. So any fever, don't give diclofenac, mefenamic acid, ibuprofen, or steroids without a diagnosis, because that is going to be dangerous, right? So that is a lesson. Even if you have a diagnosis, if you have fever, even now we have a patient in the hospital who came to the hospital, underwent a surgery, had fever day after surgery, but now it has turned out to be dengue, right? So don't give NSAIDs just because somebody is having fever to relieve the fever, even in the hospital or outside the hospital. That is a lesson I have to tell you. What is this plasma leaking? It is due to the increased permeability. And it is usually a transit. It happens very short period. Usually we say it's 24 to 48 hours. It may be slightly longer, but it is not clinically significant. Now, the people with dengue fever may be leaking from the early stages, maybe very small amount, but it is not significant. Significantly, clinically detectable significant leakage is usually for 48 hours, right? And what is interesting in this is, this leaking is mainly into the peritoneal and pleural spaces. Yeah, right? Pericardial effusions also be here, but it's very small. But they don't get like if you see a nephrotic syndrome patient or cirrhotic patient, they also leak. But then you get ankle edema, then you get facial swelling. But in dengue, you don't see facial swelling or ankle edema. The edema, the fluid leakage is into the abdomen or to the pleura or to the tissues. But you don't see ankle edema as such, right? So if you see a patient with dengue fever with ankle edema or patient with dengue fever with periorbital swelling, then that is fluid overload. It's not pure dengue leakage. That is fluid overload. So what happens when there's fluid leakage? When the water goes out, plasma remain inside the blood vessel. Red cells remain inside the blood vessels. So plasma, some of the plasma goes out, albumin goes out. So mainly the red cells and the white cells are remaining in the blood vessel. Red cell are the main majority of the volume. So you get the concentration of the blood volume, the blood goes up. You see the hematocrit, that is the cell concentration, goes up when the plasma is going out. And theoretically, we say there should be about 20% rise in hematocrit to say that there's a significant plasma leakage. So that is a clinically significant plasma leakage will cause about 20% rise in hematocrit. And other evidence are low albumin and low plasma cholesterol, because plasma cholesterol and albumin goes out into the system. Then the next slide. Right. Now, if you take like this, you can see now this yellow color is plasma, red color is the red cells. When you centrifuge in the blood, you see about 40% of the blood volume is made up of cells. When there's leaking, plasma volume drops. Then if you centrifuge that, relatively the red cell volume goes up. So it's a relative thing, but then the red cell, the P hematocrit goes up, maybe 60%, from 40 to 60. So it can go up. And if there's a bleed, what happens? Without leakage, if there's a bleed, the blood volume goes down and the plasma volume relatively increases. It's not actually increase, it relatively increases. Then you see a drop in hematocrit. So this is the lesson. If the plasma is leaking, hematocrit should go up. If blood is leaking, hematocrit will drop. So what are the situations where the hematocrit goes up? Either you give blood. If you give blood, hematocrit will go up. Or if the plasma leaks, hematocrit will go up. What happens in dehydration? Okay, in dehydration also, there is slight increase in hematocrit. It is slight. I'll come to that later. But if somebody leaks plasma, then the hematocrit should go up. But if the same person bleed at the same time, leaking and bleeding, the hematocrit can remain without a change, or the change can be minimal than the actual thing that is happening inside the body. Right? At the same time, if somebody with leaking are being hydrated in the ward, say if somebody is leaking plasma and we are giving saline, for example, if somebody is leaking, say 75 ml per hour, and we are giving 100 ml per hour plus saline, what will happen? Then the excess 25 will pass as urine, and hematocrit will remain same. It will not change because we are masking the leak by giving plasma. So hematocrit alone is in a patient, if the patient is in the hospital, hematocrit alone does not say whether the patient is leaking, because you may not see a rise in hematocrit if you continue to give fluid. So that is something you have to remember. With the leaking, hematocrit can remain stable due to your fluid resuscitation, right? So some people in dengue management try to do this. Some people try to give fluid to prevent a rise in hematocrit, which is wrong. So you have to remember that is wrong. Patients can leak. That is okay. It is okay to leak during the leaking phase. Our aim is not to manage the hematocrit. We are not managing the hematocrit. Keep this in mind. We are not managing the hematocrit. We are managing the patient. Our aim is to maintain the minimum urine output, adequate blood pressure and heart rate, not the plasma volume, not the hematocrit. If somebody tries to manage the hematocrit by giving fluid, patient will be leaking and we will be giving more and more fluid. Then at the end, the patient will have a lot of ascites, a lot of pleural effusion, and patient will be dyspneic, difficult to breathe. And finally they can bleed also, right? So aim is not to manage the hematocrit. So during the leaking phase, hematocrit can go up and we should allow that. We shouldn't be worried about the rising hematocrit. If the hematocrit is rising too much and too rapidly, okay, then you can intervene. But if the urine output is maintained, if the pulse pressure is maintained, then I am not really worried about a rise of hematocrit. Maybe a 10%, 15% of rise of hematocrit is accepted. But if somebody hydrates too much, what will happen? If somebody hydrates more than the patient is leaking, then actually hematocrit can drop. It is not bleeding. How do you know? Because the pressure is normal, urine output is high. Pressure is normal, urine output is high, and we are overhydrating. Then the hematocrit will be low. Right. So the things you have to know in dengue management is what is happening to the hematocrit, what is the blood pressure and the pulse pressure, what is heart rate, that is, and the fluid. What is the fluid that we are giving? That is all what that you have to know to manage the patient. I'll come to it later. Now we'll take some examples. This is a very short lecture, right? A 25-year-old man on admission, fever for 5 days and complaining faintishness. GCS is okay. Blood pressure 115/70, heart rate is high, 114. Respiratory rate is also slightly high. On admission, we don't know the urine output. What are you going to do? You don't have the full blood as a HO. You won't have a full blood count. You won't have a urine output as soon as the patient comes in to the ward. But what do you know? This is a patient with fever for 5 days. That's all. It may be UTI, it may be dengue, it may be anything, right? But what should you do? See whether there's any patient coming to the fever, just check for liver tenderness. Check for CRFT to see whether the patient is in shock. It can be dengue shock, it can be any shock, right? Then do a PCV till you get the full blood count. Because these days, especially during the dengue epidemic, they don't come with dengue reports. They don't come with full blood count to the hospital, right? It takes few hours for a full blood count and these things to come, lab reports to come. So if the patient is coming in a shock, when the reports come, it will be too late, right? Any patient coming to the hospital, think, is this dengue? Is this leptospirosis? Is this something else? Whatever it is, check the blood pressure, check it carefully, see whether the patient is in shock. Look for liver tenderness. Maybe they are in leptospirosis, maybe they are in dengue, but check for that and do a hematocrit. So if the hematocrit is 58, then most likely it is a dengue shock, right? So do that. If the patient is stable, then you have time to get the full blood count and look for ultrasound scan, all the other things, right? Right. Another patient that we received some time back when I was in the periphery, a 36-year-old lady transferred from a peripheral unit with history of fever 5 days. Then she had a menstrual bleeding for 1 day. On admission, platelet count was 85,000, PC was 40, hemoglobin was 11. That is to the peripheral unit. They have given saline and dextrose, I don't know why, but they have given dextrose, which is completely wrong. But this happened 2-3 years ago, right? It's wrong, but they have given it. I don't know whether it was not available. I don't know, right? So on admission to the ward, PV bleeding was there. Blood pressure was 90/70. Heart rate is 100. Respiratory rate is 26. And the hematocrit is 38. So what do you think from this? I don't know whether I can communicate with you, but what do you think? Now this patient has a blood pressure of 90/70, pulse pressure of 20. We know pulse pressure less than 30 is shock. Less than 20 is shock definitely, right? 20 to 30 is early shock. Now this patient is in shock by definition. Heart rate is 100. Now, and inward PC is 38. Now a shock patient with a PCV of 38, what do you think? It's probably bleeding, right? So this is what has happened overnight or early morning, I can't remember. They have started the patient on saline, 100 cc power. Urine output is catheterized, PC was 38, urine output was 10. Then they have given a dextrose, dextran, 250 ml of dextran. Then urine output improved slightly. Blood pressure also improved slightly, but still remaining oligouric and tachycardic. Now, what should you do now? Now, you know that this patient is having tachycardia, low blood pressure, low hematocrit, and we know this patient has low platelet also. So this is a dengue patient who is leaking. You should give blood. This patient should have been given blood at the first admission to the base hospital. Initial thing should have been blood, because on admission, hematocrit was 38, and patient was in shock. So that is, now there's a thing called expected rise in hematocrit. Now, expected rise in hematocrit is this. Now, if you see now this, if the patient is in shock, this should have been the hematocrit. Now, at least 20% rise. Do you know the baseline hematocrit was 40. So now the patient is in shock. So at least the current PCV should be at least 48 or more. It should be more than 20%, at least more than 20%. But actually the patient is having what? Patient is having a PCV of 38 instead of 48. So this is not 40 going to 38. This is 48 coming to 38. So this patient is bleeding. Somebody can think it was 40 on admission. They have given 2-3 liters of saline and dextrose. Now it is 38. That way somebody can think of it, but it's not, because the patient is leaking. If a leaking patient has dropped PCV, not even 1, even if it has gone, say, even if the PCV was 44 here, even if it was 44, even if this was 44, in a shock patient with the baseline of hematocrit of 40, still there has been some bleeding. You should give blood. Okay. Another patient. On admission, fever 5 days, faintish. Blood pressure 100/70, 30, right? Early shock. Heart rate 104, respiratory rate 20. Urine output, we don't know on admission. What is your steps? Again, you will look for liver tenderness. It's there. CRF is less than 1. So patient is in shock. PCV is 58, right? So my advice is that any patient suspected of coming to ward with fever, and if the patient is not stable, do inward PCV immediately. Don't wait for blood reports to say it is dengue, right? PCV is 15. What is your management now? You should give normal saline, bolus, then you have to give dextran in this situation, right? Because hematocrit has gone up to 58, right? So if this patient, now this patient has a PCV of 58, I forget. I mean, I just wanted to do something, but we'll forget about that slide. Show some bleeding after that. Now, what I want to say is, if the 58 drops to 48 after 1 pint of dextran and saline, then that is probably bleeding after the high leak. Right? Then there's this story is again a true story, right? It's a true story. A 17-year-old boy had fever for 5 days, and he was fever free for 1 day. He's 17 years. He's a player. Then they had the school cricket match. Then he went, and this happened in dry zone. So he went out, played the cricket match whole day. He was feeling faintish and reduced urine output. Then he came in the evening to the channeling center to consult on the physician. It's not me, don't, right? Even if I was there, I don't think it could have been different, but he came to see a consultant. Consultant suspected dengue. He sent a full blood count and asked the patient to get admitted. The blood pressure has been 90/70, heart rate, so dengue, sepsis, blood taken and admitted, asked to admit. So patient came from the private hospital to the government hospital immediately in half an hour. Right, on admission to the high hospital, there was no melena. Blood pressure has been 100/80, heart rate 90, respiratory rate not recorded, As usual, they don't record the respiratory rate in the hospital, which is wrong. Again, there was no idea about the urine output, but the child said he has been playing in the ground all day in the sun. So he has passed hardly any urine, right? The house officer thought, okay, he is dehydrated, which is okay. It's a rational thinking. Patient is dehydrated. So he was waiting for the lab reports and started normal saline 100 cc per hour. Now, what you have to remember is his blood pressure is 100 by 80. Now, this is the lesson. By having dehydration alone, a young patient, healthy male or a healthy female, will not have a pulse pressure of 20. Right? Don't take dehydration as a diagnosis in most. But the difference between dehydration and leaking, what is the difference? Leaking, the plasma capillary wall is not working well. Plasma is going out. So body can't compensate. In dehydration, the body can compensate. The plasma, they can have vasoconstriction. They can have reduce urine output due to renal vasoconstriction. But renin aldosterone is working. Plasma blood vessel is not leaking. So the body will maintain the blood pressure. It will maintain the perfusion to the tissues. So there won't be evidence of shock in a healthy patient just because of dehydration of 1 or 2 days, right? Mainly if the patient has been dehydrated from morning to evening, they don't drop the blood pressure as such like this. Right? Don't take dehydration as a cause. Okay, if it is an 80-year-old patient or a patient who's on diuretics, an elderly patient or cirrhotic patient on diuretics, okay, then they can have very low blood pressure due to dehydration and due to diuretics. But young people, healthy people, dehydration alone will not cause this amount of reduction in pulse pressure. Right? So the house officer started saline 100 cc per hour and dengue monitoring, that is 3-hourly monitoring. At 7 p.m., blood pressure is same. Heart rate is 94. Respiratory rate, urine output is low. And platelet count is 34,000. Hematocrit is 40. Hemoglobin 11.5. Now what? When you look at this, what did the house officer thought? Okay, he said it's dengue fever, dehydrated. Give some more fluid. Right? 7 p.m. they gave a 250 bolus. And urine output improved a little bit. Right? Then, but it's not coming up, not improving. Still at 20, they are hydrating. Right? Then here, 8, 9, still not picking up. Now it's coming up slowly. They gave a dextran at 10 p.m. 250 bolus. Right? Urine output improved a little bit, but heart rate is going up. The SHO saw the patient after the private practice around 9:30, 10. And then he thought of possible tachycardia. Anyway, better to get some blood. Ask for blood. Right? They asked for blood. Then around 10 p.m., still low, patient developed melena. Right? So this, sorry about 7 and 8 here. And the timing here is wrong. The patient developed melena in the night and hematemesis in about 2 hours. When the blood arrived, the patient was having hematemesis. And the child died same day night before 12 o'clock. This is a true story. So what was the mistake? What was the mistake? Mistake was, this is a patient, this is a true story. Child played the cricket match in the morning, came to walking to the hospital and died at 12 p.m. The problem was what? Child had a PCV of 40, hemoglobin of 11.5. House officer didn't thought of bleeding when the hemoglobin is 11.5, right? But no urine output, pulse pressure was 20. So this is a leaking child. Leaking child. Early shock. Ideal hematocrit. He's a healthy child. Maybe his baseline is about 45. With the leaking, it should have been maybe 55 or 60. But it was 40 on admission. Hemoglobin was 11. Hemoglobin should have been 18 with that leaking. But it was 11. Because it is 11, the house officer didn't thought of giving blood. Not until this at the end. That was too late. This is the true story. I share this story with everybody I talk about dengue. So lesson is what? If the patient is having unstable, maybe young people, they compensate very well. They don't show their weakness. Even if the HB is low, right? It can be shock. Then 35-year-old man, bilateral fluorescence, sorry. This fluid overload, I have taken more time than expected, sorry. Admitted fever day 7, heart rate is high, bilateral fluid effusion, body swelling, urine output reduced. What are your steps? PC is 30, CRF is normal. So you don't give fluid. If when the fluid was overloaded, you just you just wait and see, depending on the urine output. You don't give fluid, you monitor the patient. Sorry that I have taken. So this is the last slide. What do I need from a house officer during a ward round? I need to know whether it's DEF or DHF. And how many days of fever, whether it's day 1, day 2, day 3, day 5. What is the last platelet count and is it going up or down? What is the trend of WBC? Is WBC going up or down? Blood pressure, pulse pressure, and the heart rate. Hematocrit, the baseline and the current hematocrit. Is there liver tenderness? Is there evidence of leaking in the ultrasound? And what is the last urine output? And how many hours have passed in the leaking phase? And the current rate of fluid, how much fluid, and how much fluid have been used from the quota and how much is remaining. These 10 questions are what I need from a house officer during the ward round. Thank you.
Thank you very much, sir, for that very important lecture on the case scenarios. If anyone having questions, please type on chat box. We're a little bit behind the time. Thank you once again. So we are going to the next lecture by Professor Heyrath on the essentials of COVID management. Over to you, sir.
Roshan, can you make me as one of the hosts? Can you make me the host, Roshan? Can you hear me?
1 second, sir. Now you can share, sir.
Right. So I'm going to do that. Can you see the screen, Roshan?
Yes, can see, sir. Need to make it full screen. That's all.
Right. Okay, I'll do that. So thank you, Roshan. So good afternoon to to all of you. So the lecture that I'm going to do today is on COVID-19, the essential. Particularly, I would discuss the management of COVID-19. Right. So these are the areas that I'm going to cover during my lecture: introduction, pathophysiology, clinical symptoms and staging, and the management of patient at home and in ward. and oxygen delivery at the ward, and notification. Right. So let me start with a bit of introduction to COVID-19. What is COVID-19? COVID-19 stands for Coronavirus Disease 2019. As you all know, it was first detected in December 2019 in Wuhan province, Wuhan in China. It's an RNA virus. It belongs to a family of coronavirus. Coronavirus got this name because it has this peculiar appearance, which is like a crown-like appearance. Therefore, it is named as coronavirus. The specific virus which causes COVID-19 is called severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. In fact, there is a similar one way back in 2002, which fortunately did not spread to the other part of the world, which was called SARS-CoV-1. And therefore, since we have this one, so this particular virus is called SARS-CoV-2. So COVID-19 is the disease, and the virus which causes COVID-19 is called SARS-CoV-2. So don't get mixed up. Right. So the virus is something not constant. It can mutate all the time. So as a result of mutation over last say 2-3 years, the COVID-19 has become quite different to what it was earlier. These are called variants, and because of variants, it has acquired new properties. So the transmissibility is quite different to the previous variants, and the disease severity as well as the efficacy of vaccination also can be changed. For example, Omicron, which is the highest prevalent variant at present all over the world, has a higher transmissibility, and also it has the ability to evade the immunity created by the previous vaccination as well as previous natural infection. So it has many variants, of which Delta 1 is one of the important variant. Maybe around a year back when I was giving this lecture, the Delta was very severe at that time, causing significant morbidity and mortality. And also we had significantly higher number of deaths as a result of Delta. Now, of course, what we got is the Omicron variant, as you all know. That is the predominant variant type of SARS-CoV-2 virus present at present. This is first reported in South Africa, and it has become the dominant variant around the world now. And it differs from the previous variant of SARS-CoV-2. It has acquired the highest number of mutation, 15 mutation in the spike proteins, and therefore it has higher transmissibility, as I mentioned earlier. However, the disease which produced Omicron are compared less severe, causing less death as well as morbidity. And Omicron has also changed over the period, and at present what we have is predominantly due to BA4 and BA5. In Sri Lanka also probably same, and in USA around 90, almost 100% are due to BA4 and BA5 variant of Omicron. Let us discuss about the pathophysiology. It's a predominantly virus. This virus predominantly enters through the respiratory system, respiratory epithelium. It has this spike-like protein which goes and binds with the angiotensin converting enzyme 2 receptors, which are there in the respiratory epithelium, predominantly in the respiratory tract as well as alveoli. And once it binds with the receptors, it can enter into the cells where it replicate and producing thousands and thousands of viruses inside these host cells, and these viruses then release back into the interstitium and to the circulation and causing more and more infestation of the host cells. So it's become a cascade, and in the process of doing that, it activates in some patients, of course, it activates macrophages, which ultimately lead to activation of pro-inflammatory cascade, and which is called cytokine storm. As a result of excessive production of cytokine and the effect of cytokine, the patient can get severe acute lung injury causing ARDS, and some patients die as a result of severe lung injury. Not only it affects the lungs, it can affect the other organs, it can affect the liver, it can affect the kidney and also heart. So it is even though it predominantly affects the lungs, it can cause multi-organ dysfunctions. As I said earlier, the most patients with COVID-19 have mild disease, and only small percentage of the patient would develop critical illness. So therefore, it is important for us to recognize those people who would develop critical illness and manage them appropriately. If you look at the viral replications and the different stages of the disease, during first 5 to 6 days, predominantly they have symptoms, mainly because of the viral replication. And the symptoms are due to viral replication. And after day 6, day 7, symptoms are due to inflammation. And some of these patients can develop severe illness in day 5, day 6, day 7, due to the inflammation produced by the cytokine storm. Symptoms, the common symptoms are fever, cough, sore throat, runny nose, anosmia, and body aches. And these symptoms are predominantly due to viral replication. And you can see these symptoms in any patient with viral infection. So these are not very specific to COVID-19. It's really difficult to recognize COVID-19 based on the symptoms alone. However, if a patient tell you that the patient has these symptoms along predominantly upper respiratory symptoms, and if there are few family members also having the same symptom at the same time, so most likely you are dealing with a patient COVID-19. But most important symptom that I want you to concentrate is dyspnea, which generally occurs on day 6 or day 7 after the onset of symptoms. So the patient start fever on day 1, then on day 5, day 6, day 7. During that period, patient can develop dyspnea. You need to understand that dyspnea is mainly due to the inflammation, the activation inflammatory cascade causing cytokine storm. Based on the severity of the patient's illness, it can be categorized into 5 categories: asymptomatic, where the patient has no symptoms; mild symptoms, mild disease, the patient has symptoms such as fever and cough, and anosmia and chest tightness and so on, but the patient has but the patient has no evidence of dyspnea. So that is mild disease. Patient has other symptoms, but respiratory symptoms are not very common, not predominant. So moderate disease, when the patient has evidence of COVID pneumonia as indicated by clinically or radiological evidence of pneumonia with saturation more than 94% and having some degree of tachypnea, respiratory rate more than 20, respiratory rate in the range of 10 to 30. That is moderate disease. So which indicate that the patient has pneumonia, but this is not very severe. So this is due to inflammation. The severe disease is when the patient has severe pneumonia as indicated by hypoxia, saturation less than 94%, respiratory rate is more than 30, and the lung infiltrate more than 50%. So this is quite dangerous when the patient has severe disease. Critical ill patient has evidence of respiratory failure, and those patients need ICU or HDU care at that stage. So basically, patients who have an asymptomatic mild disease can manage at home. Moderate severe disease should be hospitalized and can be managed in medical wards or COVID ward, and those who are having critical illness should be managed in the ICU setting. So this particular diagram, this picture nicely depicts the different the severity of the illness based on the viral replication, based on the inflammation, based on the potential therapies. Now, for example, when the patient has asymptomatic disease or mildly symptomatic disease, it is predominantly due to viral replication, not due to any inflammation, not due to cytokine storm. But when the patient has moderate disease, which could be due to early cytokine storm or early inflammation, but when the patient has severe illness or critical illness, generally it is due to overwhelming inflammation of the lungs and other organs. So it makes sense to treat those patients who have viral replication with antiviral therapy, but antiviral therapy is less effective when the patient goes into inflammatory phase So when the patient is in inflammatory phase, they should be treated with anti-inflammatory therapy. With that, we will move to the management. We'll move to the management. Most patients can be managed at home as outpatient. You don't need to do anything. Basically, you have to advise them. You have to reassure them, and probably they need to check. They need to check their health. So those who have less severe disease or asymptomatic disease, so having mild disease, can be managed at home. And those who are particularly those who are vaccinated, as they are less likely to develop severe disease, and also those who are not having any risk factors to not having risk factors to develop severe disease, such as those who are CKD, obesity, diabetes, malignancy, steroid therapy, immunosuppressive therapy, COPD, heart failure. Those are the patients who are likely to get severe disease. So if the patient has none of these risk factors, probably you can manage those patients at home. And also younger patients can also be safely managed at home. So those are the patients who can manage at home. But of course, so generally, what you need to do is to give symptomatic treatment, reassure the patient, ask them to take some paracetamol, maybe antihistamines. And of course, countries like America, some of these patients are treated with antiviral therapy. But of course, in Sri Lanka, since it's not available, we don't give antiviral therapy for any of these patients. But in some countries, developed countries particularly, some of these patients are treated with antiviral therapy to avoid these patients going into severe phase. Let's start with the case scenario 1, just to highlight what we discussed so far. A 46-year-old previously healthy, fully vaccinated man present with cough, sore throat, fever for 4 days duration. RAT was positive and was admitted to medical ward on casual day. On admission, he is stable on visual triage, pulse 86, blood pressure okay, respiratory rate is slightly high, 18, saturation normal, lungs clear. What is the correct management of this patient? So these are the options given. Keep the patient in a COVID ward, start oxygen therapy, start COVID-specific therapy, discharge home with home isolation, start dexamethasone. So out of these, the correct treatment option is discharge home with home isolation, because other treatment options are not indicated for this patient, as this patient is a patient who is less likely to develop risk or high risk complication COVID-19. This patient is a young patient. This patient is fully vaccinated. This patient has absolutely no risk factors to show that he would develop progressive or severe disease, and his clinical parameters are in keeping with mild disease. So therefore, this patient can be safely managed at home. So therefore, this patient can be discharged then and there, and ask the patient to go for home isolation. So if you decide that the patient needs hospital admission, how are you going to manage this patient? So those patients, as I said earlier, moderate illness or above need to be hospitalized for inward management. So if the patient has evidence of COVID pneumonia with saturation less than 92%, if the patient respiratory rate more than 20%, if there is lung infiltrated more than 50%, those patients would require hospital admission, as the patient is in high risk category. And patient with COVID-19 having other illnesses, for example, patient with COVID-19 having acute myocardial infarction, also need to be managed in a medical ward or COVID ward, as the patient, as the coexisting medical illness need further care. And if the patient is a high-risk person having multiple risk factors, such as say heart failure and diabetes mellitus and CKD, and having advanced age, those patients are likely to develop severe disease. Therefore, those patients should be managed in an inward care setting, so that you can monitor the patient appropriately and initiate the therapy appropriately. So those are the indications for inward management of COVID-19 patients. And what are you going to do as a house officer? So first and foremost, you need to protect yourself. Therefore, self-protection is very important. You have to wear a mask and you have to wear appropriate PPE, personal protective equipment. And then, of course, you have to initiate triage, and you have to take detailed history regarding the symptoms onset, when exactly the patient develops symptoms. That is important, because we know that the patient would develop severe disease on day 6, day 7. So therefore, the exact onset of these symptoms is very, very important. And diagnostic day, when was the RAT done, when was the PCR done, and past medical history, whether the patient got any comorbidities, what is the vaccination status, and what about the social history. Then, of course, you have to do examination, blood pressure, pulse rate, respiratory rate, saturation, and you have to auscultate the lung. And then, if the patient is not hypoxic, if the patient not having any features of dyspnea, then you need to do what is called you need to look for what is called inducible hypoxia. For that, of course, in other words, you see whether even though the patient is not hypoxic at rest, whether you can induce hypoxia with exertion. So this is called modified exertional desaturation test. So you perform only if the patient saturation more than 94%, and if the patient is not dyspneic. If the patient is dyspneic or if the patient has hypoxia, don't perform NMEDT, because we know that the patient is already hypoxic. You don't need to do this. So if the patient is otherwise all right, not having any evidence of respiratory distress or not having any evidence of hypoxia, you need to see whether you can induce hypoxia by performing what is called modified exertional desaturation test. What do? You ask the patient to sit somewhere and for 1 minute, and then of course you check the baseline saturation, and then you ask the patient to stand up and sit, stand and sit 8 to 10 times, and then check the saturation and see whether there is a saturation drop. And if the patient has some degree of lung infiltrate with COVID pneumonia, you can elicit hypoxia. You may be able to elicit hypoxia. So if you're able to elicit hypoxia, those patients need to be managed in the hospital. So what are the other thing that you have to do? You have to manage the patient symptomatically. You have to hydrate the patient, give some cough syrup if the patient is having cough, and you can give paracetamol, but don't give NSAIDs. Very, very important. Don't give NSAIDs, because NSAIDs can make the situation worse. So don't give NSAIDs. Then oxygen therapy for hypoxic patient. Anybody who has saturation less than 94%, or anybody having respiratory distress should be given oxygen via appropriate device, which we would discuss later on. And prevention and evaluation for venous thrombolysis is important. Anybody who is hospitalized due to COVID-19 should be given enoxaparin. All patients should be given enoxaparin prophylaxis dose. And then, of course, you can continue most of the patient usual drugs. You can continue aspirin, you can continue ACE inhibitors, you can continue statin. You should not stop any of these medication unless there's a specific indication. For example, hypotension. If a patient is hypotensive, then you have to stop ACE inhibitors. And prevention of disease is important, because patient may be managed in a medical ward, and we don't have separate COVID ward in most places. So most patients with COVID-19 are managed in medical ward. So you have to make sure that you would not spread the disease. So you have to avoid nebulization, because nebulization can generate aerosols, and with these aerosols, more and more people around the COVID-19 patient can get infected. So don't nebulize any patient with COVID-19. Instead, you can give puffers, MDA puffers, which are commercially available. You can give MDA puffers, which are as effective as nebulization. Then you have to consider COVID-19 specific therapies. So what are the COVID-19 specific therapies? So COVID-19 specific therapies, the type of the COVID-19 specific therapies would based on the oxygen therapy. If the patient is low flow oxygen, probably you would consider only the dexamethasone. If the patient is high flow oxygen or needing high flow oxygen, at that situation you would consider dexamethasone plus tocilizumab or baricitinib. If the patient mechanical ventilation in the ICU setting, generally you would give dexamethasone plus tocilizumab or baricitinib. So depend the patient clinical situation. So essentially dexamethasone and tocilizumab and baricitinib are the treatment strategies that we used. In Sri Lanka, of course, we use dexamethasone plus tocilizumab primarily. Dexamethasone for less severe patient, and dexamethasone plus tocilizumab for high severe or severe patient requiring non-invasive ventilation or the ICU care. And then, of course, you have to discharge the patient appropriately. The patient would you should not discharge the patient on your own. It should be done by a senior person like consultant. There are no specific discharge criteria as such now. It's dependent on the clinical sense and the safety of the patient. The notification is something that you have to do. So this is the notification form that you have to fill, and each and every time when a patient with COVID-19 die. Generally, patients, if the death occur 7 days or more after the diagnostic test or RAT or the PCR, then of course patient dead body can be treated as for non-COVID, because the less likely that the patient is infectious anymore. So again, if I repeat that, if the patient died 7 days after the positive test results, like RAT or the PCR, 7 days after the positive test results, is very unlikely that the patient is infectious anymore. Therefore, the patient body can be handed over to the relatives. With that, we will move to the case number 2, case scenario. A 56-year-old man with diabetes mellitus transferred from ICC as his oxygen demand is increasing on day 3 of admission to ICC. He had mild upper respiratory symptoms for day 4 prior to the admission to ICC. That means altogether he is in day 7 of the illness, which is very important. We know that generally the patient would develop inflammatory phase at day 5, day 6, day 7 during that period. That is important to know that the patient would develop inflammatory phase during that period. So the patient is exactly in that period, and the reason for trans is that the patient is requiring higher amount of oxygen. Therefore, the ICC cannot manage this patient. On admission to our hospital, the patient is hypoxic with a saturation 92%, and he was on 6 liters oxygen via venturi mask, and he's tachyptic, and he has bilateral cause crepitation, suggesting that the patient got pneumonia. And how do you manage this patient? So this patient cannot be discharged. This patient should not be sent back to ICC. This patient should be admitted as this patient got severe COVID pneumonia. While on oxygen therapy, this patient got severe COVID pneumonia. So as a first therapy, as this patient's hypoxia while on venturi mask, we have to escalate oxygen therapy. So we have to escalate oxygen therapy, and how we are going to do is the next important thing that I'm going to talk to you all. So oxygen, when it comes to the oxygen therapy, so there are different ways that the oxygen can be administered. For example, nasal cannula, face mask, venturi device, non-rebreathing face mask, high flow nasal oxygen, or non-invasive ventilation such as CPAP or BiPAP. So if I just show some of the pictures to highlight different oxygen delivery method, nasal cannula is what is shown in your left-hand side. Nasal cannula is a very simple one. If the patient is mildly dyspneic, you can manage that sort of patient can be managed with nasal cannula, and face mask also more or less same. And venturi device is given with venturi device, you can give high amount of oxygen. There are different percentage of oxygen that you can deliver through venturi device, venturi particles. And if the patient not responding to venturi devices, probably you can try non-rebreathing face mask, and what is shown in your right-hand side. This is called non-breathing face mask. And if the patient not respond to that also, you can consider high flow nasal oxygen, which is somewhat similar to nasal cannula. But of course, here the patient is given high flow of oxygen, which are humidified, so that the colored alveoli, which are there in the lungs, can be reopened with this higher flow of oxygen. So which can create some amount of PEEP, and also with high flow, you can give higher percentage of oxygen. In fact, high flow nasal oxygen is used for many patients with COVID-19 during, say, past 1 or 2 years. And if the patient is not responding to high flow nasal oxygen, at that point, you can consider non-invasive ventilation, either CPAP or BiPAP. Particularly BiPAP is when the patient has carbon dioxide retention. CPAP is when the patient has type 1 respiratory failure. If all fail, then of course you have to ventilate, you have to intubate the patient and start ventilating. So a few important messages regarding oxygen therapy. You have to select the device according to the patient's saturation and work of breathing, and try to achieve saturation 90 to 96%. But if the patient has COPD, your target of oxygen saturation is 80 to 92%. And a patient should be monitored regularly, and appropriate investigation should be done. And you need to do arterial blood gas analysis at least twice a day, just to see whether the patient's hypoxia is getting improved. And once you start the oxygen therapy, the patient should be monitored regularly, and you have to come back to the patient hourly basis to see how the patient is doing. And so you have to discuss with the senior colleague, maybe a senior registrar or the registrar or your consultant, if the patient is not improving and the oxygen requirement is going up. So in addition to oxygen therapy, for this patient, as this patient got severe COVID pneumonia, you have to consider specific therapy, which I discussed earlier, and then of course supportive care and as an adjunctive therapy, awake proning should be done if the patient is awake. What is awake proning and what is the objective? When the patient is in supine position for a fairly long period, the dorsal aspect of the lungs, the alveoli which are there in the dorsal aspect of the lung get collapsed as a result of inflammatory substance. So those collapsed alveoli will not be involved with ventilation because those alveoli collapse. So if you can change the position, you can recruit those collapsed alveoli back to the ventilation. So that is the main purpose of proning. And how do you do it? How do you do it? You ask the patient prone for 30 minutes and then ask the patient to be in right lateral position for another 30 minutes and sitting for another 30 minutes and left lateral position for another 30 minutes. Likewise, patient can go on to different positions at different 30 minutes time interval. So this is beneficial because that would improve the oxygenation also. So this can be done if the patient is awake, and this should be done. And you have to do some of the investigations depending on the patient's clinical situation, full blood count, CRP, LFT, RF, renal function test, ECG, blood culture, and chest X-ray. Those are routine tests that we do, but not these. All these tests are not indicated for all patients. But if the patient has severe illness, these patients are indicated. For some patients, we do CRP, procalcitonin, ferritin, D-dimer, LDH, and troponin, and high-resolution CT scan, depending on the clinical situation. But you should not order any of these investigations without the supervision or without the opinion of your seniors. This is what you get in chest X-ray. You can have basically anything in chest X-ray, any appearance in chest X-ray due to COVID-19, but subpleural space and basal spaces are predominantly affected in COVID-19, as you see in this chest X-rays. But of course, it can produce lobar pneumonia, it can cause multilobar infiltration, it can cause any appearance. Right, with that, I have come to the end of my presentation. So as a summary, I want you to know that most patients with COVID-19 has less severe disease and can be managed at home. And some patients need hospital admission due to their severity or due to the coexisting medical illness. And those patients have been managed appropriately with appropriate monitoring. You need to understand some patients, particularly those patients with those patients who have advanced age, and also those who are unvaccinated, and also in multiple risk factors can progress severe COVID-19. Therefore, those patients should be admitted to the hospital and should be monitored appropriately and should be initiated on appropriate therapy at the earliest. Recognizing the patient who can progress severe disease is important and to initiate the treatment, as I said earlier. However, so scientific evidence are still evolving. Therefore, we need to use the scientific evidence or the appropriate treatment options based on our clinical judgment. And also, I need to highlight that the multidisciplinary approach is very important in managing COVID-19 patients successfully. Right, with that, I have come to the end of my presentation. Right, if you have any questions, I can answer now. Roshan, are you there?
Sir, yeah.
Right, okay.
Right. So we'll take these 5 minutes to answer some questions if you are having. So you can ask some questions on the chat box. Professor would like to answer them.
Somebody has asked whether early stage prednisolone can cause mortality. Yes, that is true. So the patient, so I mean, if you just use your clinical sense, or if you just look at the pathophysiology, as I said earlier, the initial phase is predominantly due to viral replication, not due to inflammation. So in fact, you need to give prednisolone to reduce the inflammation. But if you give prednisolone at initial stage where there is no inflammation, but there is viral multiplication, by giving prednisolone, you can potentially enhance the viral multiplication. Therefore, the patient, those patients who are not having hypoxia, those who are not having hypoxia mean those who are not having significant lung injury as a result of inflammation. So those who are not having hypoxia should not be given prednisolone because they predominantly have viral replication only. They don't have any inflammation. So inflammation is evident when the patient has hypoxia. We know that hypoxia is due to lung injury as a result of cytokine storm or as a result of inflammation. If you give prednisolone at this stage, we can prevent or we can reduce the overwhelming inflammation. So therefore, as a matter of fact, the patient without hypoxia should not be treated with steroids. So this was proven in clinical trials as well. And in the clinical trials, those who are treated, those who are not having hypoxia are treated with prednisolone and found a significant higher mortality. So the mortality benefit is there only for those who are hypoxic only. So other patients should not be given steroids. And there somebody has asked the place of vitamin D in corona. In fact, there is, I mean, of course, as I said earlier, evidence are evolving, and there are some studies showing that vitamin D therapy may have some beneficial effect. But of course, these studies are, I mean, the evidence are not very strong. Therefore, it has not come to the guideline. So the recommendation, of course, not to use any of these substances or any of these agents at the moment because there is no strong evidence. I think best thing, of course, to take the natural course rather than doing a lot of unnecessary stuff, because unnecessary stuff can even cause more problems. So therefore, we don't have enough evidence to say that vitamin D is very effective in COVID-19, even though there are some evidence say that vitamin D is effective. So it has not come to the guidelines. So therefore, it should not be used. So there is another question, plasma exchange in hypoxic patient. Yes, that is a good question. There is place of plasma exchange. Not exactly, yeah, of course, plasma exchange. That is not, that is as one of the adjunctive therapy, but again, evidence not as a primary therapy, but for some patients who are not responding, and probably you can use exchange therapy, but of course, evidence are not very strong. It is generally a class 2A or class 2B indication. Basically, when there are no other options, you might consider it as one of the options. Right.
I think that's all the questions.
Yeah.
Right. Thank you very much, sir. That was Professor Hewat on a profound lecture on COVID management. Thank you once again, sir.
Thank you, Roshan.
Right. So we'll break for lunch. So it's we'll start at 12:45. Right. Okay, we'll come back after lunch. Next up is a lecture on headache by Dr. Tushara Mathias, senior lecturer at CSTH Kalubovila. Madam. Madam, you can start.
Give me 1 minute.
Oh, yes, sure.
Okay. So welcome back, everybody. So this is the first session in the afternoon. So what I'll do over the next half an hour is to briefly touch upon the acute headaches that you might encounter during your internship. So starting off about headache, all of us have one point in our time, in our life, have experienced headache, and we have a lot of differential diagnosis for this headache. So when you encounter a patient with a headache, what we really need to figure out is this a sinister headache, or is this like a primary headache, which might not be so sinister, which we can deal with some analgesic and supportive treatment. So these red flags or sinister features of a headache is what you're supposed to recognize when you take the history and do the examination. So when somebody comes with a headache, if they say that the headache is very sudden in onset, like it reaches the maximum severity in a few minutes, right, then you're worried because you're thinking of something like a subarachnoid hemorrhage. Or else somebody who has been experiencing headache anyway, like say suppose a patient with migraine or cluster headache, says that their daily headache pattern is changing. So it's not the usual headache. They do have headaches usually, but nowadays it's not like what it used to be. So if they say there's a change in the character, then again you're worried. Third feature is like if you get up in the morning with a headache because you're thinking that this can be a cause that is causing high intracranial pressure. The fourth reason is also aggravation by straining, that also means the same thing. That means there is high intracranial pressure, which is causing the problem. Then the next one is fever. Fever is important because fever with a headache can be the presenting feature of a central nervous system infection. And that is one thing that we don't want interns to miss. And the other thing that can manifest with fever is giant cell arteritis. The next feature is a new headache in a person over the age of 50 years. So if you have somebody who has a headache, new onset headache over the age of 50 years, then you're thinking, can this be giant cell arteritis? So that's why you're worried. So unless you treat this patient with giant cell arteritis as soon as possible, they will have devastating consequences. And the last sign is if you examine them, you find that there is papilledema, or there is meningism, or there are focal neurological signs, then again you're worried. So moving on to the more common one, that is a migraine. Acute migraine attacks are quite common in hospital patients. They come to hospital because their headache or the migraine attack is worse than what it was. So as you all know, migraine can be two types. One is with aura, the other one is without aura. Though we talk about the aura a lot, usually the one without the aura is much commoner than with aura. So when we talk about migraine, you should be able to identify with the history that the patient presents with. So these migraine attacks are episodic. And usually they are not very short-lasting headache, they are a bit long-lasting. They usually minimum last for about 4 hours and sometimes up to about 72 hours. And mostly a unilateral pulsatile headache, which the patient will be able to describe to you. And commonly, you find that this headache is associated with nausea and vomiting. And some patients have this photophobia and phonophobia. So because they have photophobia and phonophobia, they just want to be let alone by themselves in a dark room. And they hate it when somebody talks to them. So they just want to be left on their own. So that is the characteristic presentation of migraine. So because migraine can come with the aura, this aura is usually more commonly visual, where they describe these lines, then certain flickering dots and things like that. But the migraine with aura is not as common as migraine without aura. So this is about migraine without aura. I'll give the lecture. So coming on to these are the diagnostic criteria for migraine. So once you make a clinical diagnosis of migraine, you need to treat that acute attack. So how you can treat the acute attack, what we commonly do in the hospital is we give a NSAID with an antiemetic. So you can give your diclofenac sodium with a metoclopramide or domperidone. That is the usual standard treatment. If triptans are available in the hospital, triptans sometimes are available in hospital, sometimes not available in the state hospital. The commonest triptan that is available in the state hospital is sumatriptan tablets. So if they are available in the hospital, you can give a sumatriptan tablet. Paracetamol can be used, but paracetamol will not relieve the headache as much as an NSAID will do. So you can also use the combination of NSAID with triptan if one modality doesn't solve the problem. So talking a little about the NSAID that you will be using, because now that you all have graduated from medical school, you all will be prescribing drugs to patients in the ward. So we commonly use either diclofenac or naproxen or ibuprofen in the hospital setup. So you can give these drugs if they don't have any allergy to NSAIDs. You can use this drug together with an antiemetic. So both these drugs are available in the state sector. So you can use the NSAID with an antiemetic. Out of the triptans, we have two triptans available in Sri Lanka. We have sumatriptan and solmitriptan tablets. Solmitriptan is not available in the state hospital, but sumatriptan 50 mg tablets are available. The problem with the triptans is triptans has to be taken at the onset of the headache, but some patients, they complain of nausea or chest tightness. And this is sometimes unbearable to the patient. So because of that, they might not be willing to take the tablet. But you cannot predict it, so you can give the triptan if there are no contraindications and see how the patient responds. Because patients who do respond to triptan, they have very good response. So NSAIDs and triptans are equal treatment modalities. You can use either of the one, or sometimes you can use them in combinations also. But before you use a triptan, the problem is with triptan, you have to be careful because there are certain contraindications. So if they have severe ischemic heart disease, if they have uncontrolled hypertension, any vaso-occlusive disease in severity, then it becomes a problem to use these triptans. So otherwise, triptans are good drugs to be used, and most of the tertiary care hospitals carry sumatriptan throughout the year. So migraine, once you treat the acute attack, the problem doesn't stop there. Usually, if they have significant headache that affects their quality of life, that they are unable to carry out their day-to-day activities, you have to start them on a prophylactic treatment. Otherwise, we are only dealing with half the problem. So the prophylactic treatment, what we use commonly is propranolol. We can also use flunarizine, and we can also use, there are a lot of people using topiramate now. So each of these drugs have their own side effects. The problem with propranolol is some people don't like to use propranolol because of erectile dysfunction and things like that, younger patients. Calcium channel blockers, the problem is it can cause certain psychiatric manifestations again in younger patients. And calcium channel blockers in general cause constipation. The problem with tricyclic antidepressants is they are sedative, so people don't like that sedative effect. So if they can take it at night and if they don't mind the sedative effect, tricyclics can be used. The problem with topiramate is topiramate very rarely can cause angle closure glaucoma. So you have to be careful not to use topiramate like for every patient. You have to carefully select your patients and use one of these modalities for preventive therapy. So you don't give all of them, you give one of these preventive therapies for a patient if they require prophylaxis. So that's about migraine. Moving on to tension type headache, we all have had it at one point of time. So tension type headache is usually bilateral, unlike the migraine, which is mainly unilateral. And it is like a band-like headache, which occurs in the frontal region mainly. And if you ask the patient, there is some amount of recent stress, either mental or physical stress, that is accounting for this headache. And these patients can be safely discharged if those sinister features that I mentioned is not there in these patients. So if these people come to hospital, if you can safely exclude that these red flags are not there, you can send these patients home with paracetamol therapy. Then we come on to the third type of migraine, that is this trigeminal autonomic cephalalgias. Out of these trigeminal autonomic cephalalgias, the commonest type that we see is the cluster headache. So I'll talk a little bit about the cluster headache. Unlike migraine, cluster headache is more common in males. And I told you the migraine patient wants to be let alone on their own in a dark room without anybody speaking to them. Whereas the cluster headache patients, they are very, very fidgety. They want to move about. They can't be in one place. So it's contrary to migraine. So cluster headache is also a unilateral headache, more common in males, younger patients, but they can't be still in one place. They are very, very fidgety. They want to move about because of the headache. And what is characteristic about this cluster headache is it's called cluster because these headaches occur in clusters. So they get one attack and then they get a cluster of attacks. That's why it's called cluster headache. And the duration is usually very much shorter than a migraine attack. So when this cluster headache comes, the usual acute treatment modality when they are in hospital is you can give high flow oxygen via an unrebreather mask. Or else, even for this condition, your triptans will work. Just like in migraine, for cluster headaches also, you have to give them preventive therapy. So the preventive therapy for cluster headache is verapamil. Again, another calcium channel blocker. So that is the usual preventive therapy for cluster headache. So migraine and cluster are the two primary headaches which are commonly seen in the medical world. So if somebody's cluster headache is not responding to standard treatment, it is good for you to do a neuroimaging because sometimes there might be a secondary cause. Always in headaches, you think it's migraine, but you're treating them adequately. And if the headache is not going away, whether it's migraine or cluster, it is good for you to lower your threshold and do a imaging if there are sinister features or if the pain is not responding to standard treatment. The third type of headache that I would like to talk to you about is giant cell arteritis. This is very important, whether you're posted in Colombo or whether you're posted in your peripheries. If somebody above the age of 50 years comes with a new onset headache, you have to think about giant cell arteritis because for somebody to have a first time severe headache after 50 years is very unlikely. So you have to think about, is this cluster headache? Is this giant cell arteritis? So unless you think about giant cell arteritis, you are not going to investigate nor treat. The important thing about giant cell arteritis, if you don't treat them adequately on time, as soon as possible, they can end up in blindness. So you know that giant cell arteritis and polymyalgia rheumatica are the same spectrum of diseases. So alongside giant cell arteritis, you can also have these constitutional symptoms and also this girdle pains and things like that because it's like a PMR, polymyalgia rheumatica like pains. So as soon as you suspect giant cell arteritis, you have a simple, inexpensive investigation that you can do, that is an erythrocyte sedimentation rate or a ESR. So you do the ESR, you find that it is above 50, then you think that it is supportive of giant cell arteritis. And once you think it is giant cell arteritis, you do a ESR, it's high. The next thing is you can do a Doppler scan of the temporal arteries and go ahead with a temporal artery biopsy. But even if you go ahead with a temporal artery biopsy, sometimes the temporal artery biopsy might be negative. The reason being the artery is not uniformly affected all throughout the artery. So we do it, but sometimes it might come as negative. But on clinical suspicion, you can actually start treating this patient. So alongside the temporal artery Doppler and temporal artery biopsy and the ESR, the alkaline phosphatase also tends to be high in giant cell arteritis, and you can have anemia, anormochromic normocytic anemia. And once you suspect giant cell arteritis, even in the peripheries, you can immediately start on prednisolone tablets, 1 mg per kg per day, and then sort out the investigations thereafter. Because if you don't, the patient might end up being blind. So if somebody with a new onset headache comes after the age of 50 years, and there are suggestive features like PMR, GCA-like features, then you have to do a ESR, thereafter proceed in the investigation line to start on treatment with prednisolone. That's an important point of the lecture today. So apart from that, you have to always think about a brain tumor. I said that there are certain sinister features which I put down in my first slide. So if these sinister features are there, you have to think about the space occupying lesion in the brain. So recently, about a week back, I had a lady, she was 60 years, previously very well. She was healthy. She only complained of a headache, which was completely new onset. She has never had headaches before. She was a well-functioning lady. She had headaches before. And it turned out, so we did the basic investigations and then I took a history. There was nothing to suggest of another primary cause. And when we did the CT, we found a large glioblastoma. So if there are sinister features, or if you can't pin it down to anything else, whether it's tension headache or migraine or cluster or tension, anything else, it is good for you to lower your threshold and do a CT or an MRI, neuroimaging, to see whether there is a space occupying lesion. But usually, alongside this headache, they can have some personality changes, they can have this increased intracranial pressure features. There might be something when you take the history or examination. Another cause of headache in the acute setting is angle closure glaucoma. If you suspect angle closure glaucoma, you need to refer the patient as soon as possible to the eye unit, because they will start on treatment to reduce the eye pressure. So how they present is they come with a headache. Alongside the headache, they come with eye pain. And they have a lot of symptoms, visual symptoms, blurring of the eye, halos, scotomas, and they also have nausea and vomiting. So when you examine this patient with angle closure glaucoma, you find that they have a red eye. That's a characteristic feature with a fixed mid-dilated pupil. And as soon as you see this, you have to urgently refer the patient to eye clinic, because they will, or the on-call eye unit, because they will start on drugs to reduce the eye pressure. So that is something that can present to a medical ward, because medical casualties taking all the medical acute presentations. So angle closure glaucoma, you have to suspect in a patient who comes with a headache alongside eye pain and visual symptoms. So as I told you before, headache can also be a presenting feature of meningitis and encephalitis. So these patients usually come with fever. If it is meningitis, you might just have fever, photophobia, and vomiting. If it's encephalitis, you might find that there are certain focal neurological signs or change in the sensorium and things like that. The other important cause of acute headache is subarachnoid hemorrhage. I bet all of you all would have seen at least one patient with subarachnoid hemorrhage. So the characteristic presentation is they describe the headache as a very acute headache. It's called generally a thunderclap headache, because this headache reaches its maximum severity over a very short period. Very rapidly, the maximum severity is achieved. Having said that, the only cause of thunderclap headache is not subarachnoid hemorrhage. Subarachnoid hemorrhage can cause thunderclap headache, but if somebody describes to you a thunderclap headache, the only cause is not subarachnoid hemorrhage, because there are other causes such as reversible cerebral vasoconstriction syndrome and things like that, which also might present with thunderclap headache. But subarachnoid hemorrhage is one entity that you have to think about if somebody comes with subarachnoid hemorrhage, with thunderclap headache. If you suspect somebody to have a subarachnoid hemorrhage based on the history of a thunderclap headache, the first and foremost investigation that we do is a CT scan. The CT scan, the earlier you do, the sensitivity is higher. And you might see the characteristic appearance of the blood in the cisterns and things like that. So once you see that, you don't have to do LP always, but if you decide to do an LP because it is not seen in the CT and you still have strong suspicion for a subarachnoid hemorrhage, we usually suggest to do the CT 12 hours after the onset of symptoms, because then only we can see xanthochromia in the cerebrospinal fluid. So xanthochromia you can see usually better after 12 hours. So we suggest to postpone the LP lumbar puncture by about 12 hours. So this is how a xanthochromic CSF will look like. So we first do the non-contrast CT scan. If that doesn't reveal anything, we can go ahead with the LP if the suspicion for a subarachnoid hemorrhage is higher. And then you might find that there is xanthochromia in the CSF. Apart from these two investigations, which can be done even in a peripheral unit, if you're in a slightly better hospital with facilities, you can always do a CT angiography. CT angiography in subarachnoid hemorrhage will find that there are intracranial aneurysms. And MRI, if the facility is available, you can do it as a second line investigation, because that might show things more sensitively, especially if the time has passed. Because I told you CT, earlier you do, the better. LP 12 hours after. So if the patient comes to you even after that, When your suspicion for SAH is still high, then you can go ahead with the MRI. So once you diagnose a subarachnoid hemorrhage, you have to stabilize the patient, make sure the patient is all right. Then you have to control the blood pressure because you have to make sure that it doesn't bleed any further. So because of that, you need to control the blood pressure. And if there are any clotting abnormalities, we correct those. We make sure there's enough hydration. We give laxatives if the patient has a cough. We treat all that because we don't want the intracranial pressure to go up. And for the vasospastic effect, we give nimodipine 60 milligrams 4 hourly, and we monitor the patient very carefully. But these are all supportive treatment. If you find aneurysm after you do the CT angiogram, if you find that there is an aneurysm, you can either do clipping or you can do coiling. Generally, they say that coiling has better outcomes in the long term. So these two modalities you might not be able to do in hospitals all around the country, but once you suspect, what you can do is you can do the supportive initial management, and thereafter refer the patient to a unit where there is neurosurgical support, so that they will take care of the definitive management thereafter. So that's about in the lecture. Do you all have any questions? Anything which is not clear? Roshan, if they don't have questions, you can ask Dr. Namal to start.
Right. Thank you very much, madam. I think we are going for the next lecture in a few minutes' time. Is by Professor Namal Vijay Singh on management of chest pain. Right. Basic ECG interpretation for interns by Professor Namal Vijay Singh. Over to you, sir.
Roshan, can you hear me?
Yes, I can hear and see you, sir. Right.
I hope you can see me.
I mean, the presentation, yes.
Okay, thank you. Give me 2 minutes. Within
Sure,
2 minutes,
sir.
I'll start.
Yes.
Good afternoon, everyone. I hope you all can hear me and also see me now. And you all can see my slides too. So, like every time, my task is to discuss with you about some basic ECG interpretation for interns. Now, the whole idea of this course is to give the basic knowledge or the most important knowledge required to function as house officers. I mean, at the moment, you all have passed with final MBBS exam from your respective faculties, but this is a refresher course just before starting the internship. So likewise, identifying some important ECG abnormalities is fundamental to your skills and capabilities when you do your internship. So my objective of this talk is to introduce some basic ECGs for you to identify. Now, out of these also, there are some I will point out time to time. There may be about 8 or 10 ECGs that you must know as a doctor. Because, for example, ventricular fibrillation or asystole and ST elevation, things like that are very basic but very important for life-threatening conditions, and those ECGs you need to identify. Now, before we talk about ECG abnormalities, I just want to briefly tell you about the ECG complex, because we need to know the various waves and the intervals of the basic ECG complex. You all know the P wave, which indicates the depolarization of the atria, and then the QRX complex, that is the depolarization of the ventricles, and also the T wave, that indicates the repolarization of the ventricles. And some people tend to believe that the repolarization of the atria is hidden in the QRS complex, which we don't believe, because then you should be able to see that in a complete AV block. But actually, the repolarization of atria, there's no wave, it's too small to form a wave. And also important intervals, like the PR interval, starting from the beginning of the P wave to the beginning of the Q wave, is actually the PQ interval, but we normally call it as PR interval. Then the width of the QRS complex and the QT interval and the corrected QT interval, they are the important intervals to know. Then when we do a 12-lead ECG, we talk about 6 limb leads and 6 chest leads. Actually, we attach only 10 leads. They are the 6 chest leads and the 4 limb leads. But using these leads, we generate 12 different waveforms. The limb leads, you can combine together, like you can see in the picture. They are called bipolar limb leads. When you combine the 2 upper limbs, you generate L1, and then L2 with the right upper limb and the left foot, and then L3 is the left upper limb and the left foot, and likewise then you can use the augmented leads. They are unipolar leads. They are AVR, AVL, and AVF. The right foot lead is usually the earth. So those are the 10 leads generating 12 waveforms. As a junior doctor, it is a must for you to learn how to do an ECG. Now this will be taught for physiology. There's a physiology practical in every medical faculty where students are taught how to do ECGs. And also during their clinical training, especially during the professorial training, we advise them to do ECGs. Because when you are posted to various hospitals as house officers, especially in the nights, there may not be people to do ECGs for you during emergencies. So you should be able, no one can say, I don't know how to do it. If you don't know, learn at least from now. Before you start your internship, go to a ward, go to a place where they do ECGs, do few ECGs with them and learn how to do. Learn how to attach and learn how to play with the ECG machine and generate a ECG. Now, before reading any ECG, it is important to pay attention to various things. Now, if a patient comes to me, you don't have to specifically question, and but you should see whether this patient ECG belongs to this particular patient. But oftentimes, especially to the clinics and to the private channel practices, they bring files and they have the ECGs of their wives, and because for the patient it is like just filing them together. So in the wards, sometimes they by mistake they can file the ECG with the wrong patient. Therefore, important to identify the correct patient who belongs to that ECG. So patient identification important, and just cross-checking the death ticket number or the name of the patient is important. And also lead positioning. I'm not going to go into details of the lead positioning. And often we find, at least I find 1 or 2 a month, that people have taken ECGs with wrongly attached leads, because especially the ECGs are taken in the private sector from small private clinics. And the people who do the ECGs have not got proper training, and also maybe because they are busy, sometimes the leads are wrongly attached, and you all should know how to identify these. If you suspect wrong lead attachment, do another ECG and compare. And also paper speed and amplification, I will tell you how to identify. And also there may be a lot of artifacts in ECGs. You should be able to identify them and interpret appropriately. Now this is a classic example of paper speed. The usual speed of the we use is 25 millimeters per second. So in a second, in your ECG, there will be, the speed is 25 millimeters, that is 5 large squares per second. But sometimes you can slow the machine. This can happen as a mistake, or some very experienced electrocardiographers, they can purposefully slow it down to see the waveforms. The issue is, often we train our eyes to identify arrhythmias. Now, if you look at the one on the left-hand side of the screen. It is an atrial flutter. I can see that it is an atrial flutter with 2 to 1 block. But if the paper speed is, because I have trained my eyes to identify it. The other panel on the right side, if you look at the upper rhythm, it is, as soon as you see, you know that it is atrial fibrillation because of the irregular nature. But if you look at the same rhythms in the bottom, they have increased the paper speed. Now speed is 10 last squares per second, like 50 millimeters per second, and you don't see that classic wave pattern. Therefore, you have to be careful. I have seen enough, and sometimes people come running thinking that it's a very slow heart rate. And actually, the paper speed is 50 and the heart rate twice what we normally measure. Now, this is to identify the simple like signal amplification. If you look at the right hand corner of the ECG, right hand side of the screen, corner of the ECG, there's a small box like thing, and that is exactly 2 large squares tall. What it indicates is the voltage of the ECG. The normal voltage is 10 millimeters, 10 millivolts, that indicates 10 millimeters. But this also, now in this ECG, if you look at the V4, you can see that the wave, the R wave is going out of the paper like, right? The ECG area, it is going even beyond that. Therefore, if you want to get that wave within the paper, you can reduce the voltage. But if you do that, we need to know. So the person who reads the ECG should know that the voltage has been reduced. And as a result, you see all the waves half the size of the normal size. Therefore, you have to pay attention to the paper speed as well as to the signal amplification or the voltage. Now, what do you all think about this ECG? Now, this is a real patient who was transferred to us when I was doing my overseas training for ICD implantation. But actually speaking, this is an artifact. If you look at the whole ECG, there are 4 rows. If you look at the bottom row, you can see normal ECG pattern. Now, it can't be like that, like think that this ECG is just printed from the machine. And if you look at from top to bottom, there are 4 rows. All the ECGs in the same line are same complex. That is how it is printed. Now, one disadvantage of this A4 size ECGs with the tape-like ECG that we normally do is that in the tape-like ECG, we see about 50-60 ECG complexes. Here we see only about 10 to 15 ECG complexes. In the rows, all are same. But how can you have an arrhythmia in the upper 3 rows and a normal rhythm in the lower row when the same the complex is printed? What actually has happened is that this patient have moved and may have like brushed the teeth. Now this is, you can see that this is not a, this ECG was taken maybe while he is being monitored. So what normally happens is, if you see a rhythm or some abnormality, using the same monitor, we can take a 12-lead ECG in a CCU. Don't know whether this patient has gone to the washroom in the morning and started brushing teeth. You can get exactly same pattern, like an arrhythmia. I mean, otherwise this looked like even ventricular fibrillation to me. And often what happens is then we go looking for the patient and rushing to see that whether he has collapsed, and the patient is nicely brushing teeth. So this is an artifact. There are several artifacts. So if you want to master reading ECGs, you have to be you have to have a good knowledge on identifying artifacts, and also you should not miss the paper speeds and the lead attachments and the amplification as well. So these are the first few things you need to do before you actually read the ECG. You have to identify the patient, you have to keep an eye on the paper speed and the amplification as well as artifacts. Now, first thing you need to do is rate determination. For that, RR interval is important. Now, if in this ECG, you know where the starting point on top of the R wave, and then you start calculating large squares. Now, provided the rhythm is regular, you can apply this method. If there is one large square between two R waves, the heart rate is 300, which don't normally happen because the patient will arrest. But if there are two large squares, you know that the heart rate is 150. Anything between 1 and 2, you know the heart rate is more than 150, maybe 200 to 180, somewhere there. 3 large squares is 100, 4 large squares is 75, 5 large squares is 60. But it means is you have to divide the number of large squares from 300. 300 divided by the number of large squares, you get the heart rate. So the normal ECGs have normal sinus rhythms. Sinus rhythm is the P wave is always followed by a QRS complex with a fixed PR segment. There should be a normal looking P wave followed by a QRS complex, and the PR interval is constant and the PR segment is constant. When we want to look at the rhythm, we normally do either L2 or V1 because we like to see the P wave in relationship with the QRS complex, because then only we can identify what the rhythm is like, whether it's a sinus rhythm or whether it is some other abnormality, especially AV conduction. To identify the rhythm, we need to see. The most important thing to see is to see the P wave very clearly. So we normally do either L2 or V1 to look at the P wave. That's why you normally do either either L2 or V1 as the rhythm stripped. Now this ECG is a common ECG normally seen in the adolescents or young adults. Can see even in among adults occasionally. There is sinus arrhythmia. When you examine the pulses, you find the pulses are irregular. But when you do ECG, you find something like that. They are in sinus rhythm, but at times the heart rate is slower than the other times. So this is the heart rate variation due to respiration. So the first part of the ECG, patient was having inspiration. The first part of the ECG, patient was having expiration and the heart rate is slower. And the middle of the ECG shows a faster heart rate because of the inspiration. So if you have a proper long rhythm strip, you can even tell the respiratory rate of this patient. This is sinus bradycardia. Heart rate less than 60 is called sinus bradycardia. But they are in sinus rhythm. Rhythm is normal, only the heart rate is slower. So there are so many causes, both extrinsic and intrinsic causes. You should know like hypothermia, hypothyroidism, cholestatic jaundice can develop sinus bradycardia, raised intracranial pressure, and medications, that is the commonest cause, like beta blockers, verapamil, diltiazem, and digoxin, and neurocardiogenic syncope, and the carotid sinus syndrome. And also various cardiac issues, also like sick sinus syndrome, ischemia of the SA node can lead to sinus bradycardia. So when the sinus node is defect, we normally call it as sick sinus syndrome. Now this is sinus tachycardia, the opposite of sinus bradycardia. There the patient is in sinus rhythm, normal QRS complexes, everything is normal except the heart rate. Heart rate is more than 100. In here, you can see the QRS complex is between 2 to 3. That is between 100 to 150. I would guess that the heart rate is about 120 in this patient. Again, there are causes, there are acute causes like anxiety, pain, fever, everything can cause tachycardia, infections, acute LVF, pulmonary embolism, hypovolemia, and chronic causes like the pregnancy, anemia, hyperthyroidism, catecholamine excess, all can cause sinus tachycardia. Now we'll one by one. Now all this time we discuss 3 rhythms or 3 ECGs. They all are normal ECGs, except for the fact that the heart rate may be either increase or decrease. Sinus arrhythmia is a normal ECG. There's a variation of the heart rates during respiration, expiration and inspiration, and also sinus bradycardia, normal sinus rhythm, everything is normal except the heart rate, and sinus tachycardia. Likewise, heart rate is increased, but everything else is normal. Now, ventricular hypertrophy, we normally find it in certain specific leads, V1 and V5, V6, and also in the lateral leads. In the lateral leads, you can see that the QRS complex is little wider than it should be. It's not very wide, but it's little wider. And also, they are either very tall or deep. So there we apply several criteria. Now, one criteria is if V5 or V6 R wave is more than 35 millimeters. So 27 millimeters. So 27 small squares. That is one criteria to diagnose LVH. And if you calculate the S wave in V1 with either R wave in either V5 or V6, and the addition is more than 35 millimeters. So S wave plus R wave is more than 35 millimeters or 35 small squares, you call it as left ventricular hypertrophy. And AVL also, if it is more than 12 millimeters R wave, you take it as electrical criteria fulfilled. However, to diagnose LVH, you also need to have, I don't have a pointer to show you. I don't know whether you can see my pointer here. This T-wave inversion. Now see with tall R waves in V5, V6, L1 and AVL, you see a T-wave inversion that is called left ventricular strain pattern. That is due to left ventricular strain. If you combine the electrical criteria with the left ventricular strain pattern, your specificity or your accuracy of diagnosing LVH is much higher, because if you are a thin person, very young person, because your electrical activity of the heart is very high, and because you are thin, that activity transmits through the lead is very much, you can have tall waves. That is why young children have very tall waves in their ECGs. So here the important point is you have to have electrical criteria. I told you what they are. V5, V6 more than 27 millimeters. or S wave in V1 plus R wave in V5 or V6 should be more than 35 millimeters. Or else if you take AVL alone, it has to be more than 12 millimeters. And with that, if you also have a left ventricular strain pattern, you can diagnose LVH. Now this is a ECG of left ventricular hypertrophy. As you can see the you can see tall R waves in V5 and V6, and also deep S waves in V1 and V2, and you know that you can see that they are taller. And I don't think it is taller than 27, almost 27 there. But if you calculate V1 and V5 or V6, or V2 and V5 or V6, it is more than 35. So it's fulfilling criteria and fulfilling AVL more than 12, and also there is strain pattern. Opposite to that is left ventricular hypertrophy. Now here you see a tall R wave in V1. With that you can see some right ventricular strain pattern also as a teen version. Now we all know that in normal ECG there is no R wave in V1 because the main wave is a deep S wave. If you see a positive R wave in V1, we have to suspect certain conditions, and right ventricular hypertrophy is one of them. So what this patient have is slightly widened QRS complex, positive R wave in V1, and also teen version. That is right ventricular strain pattern. Remember these criteria, and then it's easy for you to diagnose. Now this is a ECG with right ventricular hypertrophy. You can see the right ventricular strain pattern as indicated by the T wave inversions in V1, V2, V3, V4 and V5. And also you can see a tall R wave in, this is actually reciprocal of a S wave. You can see that as a reciprocal or a mirror image of S wave. You can see it as a tall R wave in V1 and V2. Moving from there, next we will discuss complete left bundle branch block and right bundle branch block. Now this is very wide QRS complexes, and maybe bifid, that is the wave is, the top notch is divided into two, as you can see in the V5 and V6 and L1 of this patient. And when you see that, you call it complete left bundle branch block. And once you develop it, it remains forever. So if you see a left bundle branch block, you need to find out whether it's an old left bundle branch block or acute left bundle branch block. Acute left bundle branch block is considered as acute myocardial infarction. Similarly, there is a ECG of left bundle branch block. You can see the wide QRS complexes, mainly R waves, in the R waves of V5, V6, L1 and AVL. But right ventricle or right ventricular right bundle branch block, again you can see a tall and bifid R wave in V1. Now if you go to the left bundle branch block, you could see that in V1 there is only a S wave. There is no positive R wave. But here you can see a positive R wave, bifid and wide in the right bundle branch block. Now this is a ECG of a right bundle branch block. You can see positive R wave. Now this is a another cause for positive R waves in V1 and V2. We discussed one, that was right ventricular hypertrophy. This is another one, complete right bundle branch block. Now, we discussed four more ECGs. They are the left ventricular hypertrophy and right ventricular hypertrophy, and also left bundle branch block and right bundle branch block. We need, because they are very common ECG abnormalities, you have to have a knowledge to identify them. Then let's move on to cardiac arrhythmias. Cardiac arrhythmias can be divided as bradyarrhythmias when there's an arrhythmia and the heart rate is less than 60, and also tachyarrhythmias when there's an arrhythmia and the heart rate is more than 100. Arrhythmias may not cause any symptom, but and may be asymptomatic, but they also can develop a sudden cardiac death. So they can present with very wide variety of symptoms, ranging from completely asymptomatic status to syncope, heart failure, chest pain, dizziness, palpitations, lightheadedness, loss of consciousness, and sudden cardiac death. Now, this is how an arrhythmia can develop. As you can see at the beginning of the ECG, there is ST elevation, so the patient may be suffering from ST elevation MI and suddenly has developed this arrhythmia. Now, as I said at the beginning, it is very important for you all to identify the rhythms of cardiac arrest. There's no forgiveness for not identifying these ones, because you may be the first person to detect a cardiac arrest in the ward when you're the house officer, and you may be the first person to jump and start CPR. So there are two shockable rhythms where you can, or the choice is to give a shock as soon as possible to revert back to normal rhythm. So they are the ventricular fibrillation and pulseless ventricular tachycardia. In addition to that, they can also develop asystole and pulseless electrical activity where a shock is not indicated, but you need to identify the underlying cause for the cardiac arrest and correct it. Now, this is sinus node dysfunction. What normally happens is they are having a normal rhythm, but suddenly the SA node stops firing. So there is a long pause. If you calculate, see how many large squares are there. There are about 20, more than 20 large squares from in this pause. So that means it's about a 4-second pause. It's about a 4-second pause. So during this 4 seconds, blood supply ceases to the brain. And this is the time they normally develop a syncope. And they faint and have a loss of consciousness. And as a result, the patient can fall and break a bone, or can develop a fracture, like a fractured neck of femur or somewhere. So sometimes we identify these patients when they come with fractures or other injuries. So this is when the sinus node is dysfunction. Other bradyarrhythmia is AV blocks. These are the abnormalities we normally call as heart blocks. I don't like the word heart block because the patients get scared. Patient gets scared. Therefore, the better and the safer the terminology is AV block or atrioventricular block. And that can be divided into first degree AV block, second degree AV block, and third degree AV block. First degree AV block is all the impulses generating at the atria are going to the ventricles through the AV node, but with a delay. So all the impulses are going, but slowly, with a delay. And as a result, the PR interval is prolonged. The normal or usual PR interval is 0.12 milliseconds, 0.12 seconds or 120 milliseconds to 210 milliseconds, so 0.21 seconds. Then second degree AV block is only some of the impulses originating at the atria level go past AV node to the ventricles. Only some. And the third degree AV block is there's absolutely no connection between the atria and the ventricles in terms of electrical activity. So in the SA node, the impulses are generated, they go along the atrial syncytia, but they don't go across the AV node into the ventricles. And instead, the ventricular myocardium, somewhere they start generating impulses. And they are the ones that help to depolarize and contract the ventricles. So this is a very serious condition, important condition, where you have to treat promptly and usually with a pacemaker. If it's a reversible cause, you put a temporary pacemaker and wait until the precipitant is eliminated. Or else, if this is likely to be long term, you implant a permanent pacemaker. Now, this is a ECG of a second degree AV block. As you can see, every other P wave is followed by a QRS complex. And then next P wave, there's no QRS complex, but again it is followed afterwards. So this is called a second degree AV block. Now here, the P waves occur on their own and QRS complexes occur on their own. There's absolutely no connection. So that is a complete AV block. You need a pacemaker implantation in this patient. So management of bradyarrhythmia, so bradycardia. Now when we ask our junior doctors about, like, what would you prefer to manage, whether it's a arrhythmia or a myocardial infarction, many of them say myocardial infarction because the treatment is streamlined and it's in the guidelines, and you know exactly what to do, like loading doses and morphine and thrombolysis, everything you know, and there's one way of managing it. But arrhythmias vary. You need to identify the arrhythmia as well, and sometimes you don't get an ECG done at the time of the symptoms, and that ECG they bought is also normal. So a lot of difficulties to diagnose, and the management vary from arrhythmia to arrhythmia. Therefore, you have to diagnose it properly and know to manage different arrhythmias. Now, but as junior doctors, these are the important points that you need to know. If you identify bradyarrhythmia, either sick sinus syndrome or AV block, first thing to do is to withdraw rate control drugs. They may be still on rate control drugs like the beta blockers and the calcium channel blockers like diltiazem and verapamil and amiodarone, digoxin, and so on. And we need to correct electrolyte abnormalities. Better do sodium and potassium. Potassium can cause bradycardia, and also if you have facilities, do calcium and magnesium. For any bradyarrhythmias, atropine may help. So you can give about 3 milligrams of atropine intravenously, and some people we start isoprenaline infusions. But the definite solution is, if it's a reversible cause like Caneru poisoning, you can put a temporary pacemaker and wait until the cause for the AV block is removed or eliminated. Or else you have to consider them for permanent pacemaker implantation. Someone has said time is almost over, but actually I have 1 hour. Initially it was from 1:30 to 2:30. Is that right, Roshan? So is Roshan is there? Anyway, someone has put that in the chat box, as I said. Just check. Let me know if you want me to finish. So then we'll move on to tachyarrhythmias. Tachyarrhythmias may be, the tachyarrhythmias can be supraventricular tachyarrhythmias and ventricular tachyarrhythmias. They can also be divided like narrow complex tachyarrhythmias and wide complex tachyarrhythmias. The narrow complex or supraventricular tachyarrhythmias again can be divided as atrial tachyarrhythmias and nodal tachyarrhythmias. So atrial tachyarrhythmia, the common ones, there are several, but common ones are atrial fibrillation, atrial flutter, and atrial tachycardia. Right? They all arise from the atrial myocardium, and the common ones are atrial fibrillation. As you can see here, is instead of P waves, you can find a small fibrillatory waves, and the rate is irregular. You can see 2 ECGs of atrial fibrillation here. Very common arrhythmia to learn. The management of atrial fibrillation, I'm not going to discuss a lot because this is out of this topic, but there are 2 strategies. You can go for rate control strategy or rhythm control strategy. Rate control with various drugs like beta blockers and digoxin and verapamil. Rhythm control with antiarrhythmic drugs like amiodarone or flecainide. But whichever the way you choose, there is a risk of thromboembolism, so you should consider warfarin. And therefore that there is this CHED score, there are CHED-WES score. You all should know about it and calculate for the patient when you become a house officer. If you can calculate that and tell your consultant the CHED-2 score is this much or the CHED-WES score is this much, therefore warfarin is indicated or not, then the consultant will be very happy. Right? So if the score is 0, there's no need of anticoagulation. If it's 1, you should give aspirin. If it's 2 or more, warfarin is indicated. Nowadays there are newer anticoagulants also like rivaroxaban and apixaban. If the patient can afford, we can consider them as well. So these are the rate control strategies. As I said, you can use medicines or else you can do AV node ablation. The rhythm control strategies, again, you can use medicines like amiodarone, sotalol, or flecainide, or else you can do catheter ablation of atrial fibrillation. AF ablation we call it. What they normally do is they put burns around the pulmonary veins origins, and we call it as pulmonary vein isolation. That will help eliminating atrial fibrillation. And these are the anticoagulants you can use. Aspirin is an antiplatelet medication. Sometimes we give aspirin or clopidogrel. Warfarin, when we give, we have to maintain INR between 2 and 3. And newer anticoagulant or newer oral anticoagulants, apixaban, rivaroxaban, and dabigatran. The apixaban and rivaroxaban are available in Sri Lanka. We can use them. Atrial flutter is also somewhat similar to atrial fibrillation, but in atrial fibrillation, the atrial rate is about 380 to 400 beats per minute. In atrial flutter, it is about 280 to 300. Give me a second. Roshan, yeah. 1 hour. So apparently it's not 1 hour. The one they sent to me had from 1:30 to 2:30. So always we did for 1 hour. But anyway, I'll try to finish in 5 minutes. So this is another atrial flutter. Another important ECG for you all to know is atrioventricular tachycardia. This is also called supraventricular tachycardia. You can see the heart rate is very fast here, about 200. You can see that among the young people. This is not atrial tachycardia, the tachycardia originating around the AV node. And there are two types of atrial tachycardia. We don't want you to identify the different types, AVRT and AVNRT. It is only important for the cardiac electrophysiologist to ablate. Even to give medicines, it's not important to differentiate. Now, WPW syndrome is also around. It is also a type of tachycardia that can originate around the node. So I categorize them with the nodal tachycardias. How you identify is there is absent PR interval. You can see that soon after the P wave is over, the QRS complex starts. And that slope is called the delta wave. That is because of the repolarization. It's early depolarization of the ventricle because of the aberrant pathway. Ventricular tachycardias are also important. Now this is another ECG that you should not miss. Wide complex tachycardia, they can present with pulseless ventricular tachycardia. That's a cardiac arrest. You start CPR. They can present with severe symptoms with cardiogenic shock, or sometimes they can present as a hemodynamically stable patients also. These are multifocal atrial tachycardia, also called Tosardi pointis. I am not going to take time because I want to finish within 5 minutes. Otherwise, I was going to explain all this to you all. And this is another important rhythm. We can see after thrombolysis is called idioventricular rhythm. The rhythm starts from the ventricular myocardium. So we should not suppress it, because if we suppress it, patient might go into asystole. So if you see this, just leave it alone. Of course, ventricular fibrillation is a must to know. These are the core ECGs: ventricular tachycardia, ventricular fibrillation, ST elevation. These you must know as house officers, right? Now, the person who did it didn't know. Otherwise, he wouldn't have taken the 12 lead ECG while on ventricular fibrillation rather than. Now, we'll go to ischemic heart disease. That's the other thing that we need to know. Non-STEMIs or unstable angina develop ST depression, as you can see here. ST depression and ST elevations in the anterior leads, you can call it a STEMI, and the next ECG is after thrombolysis. You can see like more than 1 centimeter ST elevation in the leads. Then anterior STEMI, extensive anterior STEMI, when it starts from V1 to V6 and LV and AVL, the whole left ventricular myocardium is involved. Maybe left bundle branch block. So I'm sorry, maybe obstruction at the level of left main coronary artery or at the beginning of the LAD. This is again anterior ST elevation MI. I'm showing different ECGs for you all to identify. This is inferior STEMI. ST elevations are seen in L2, L3 and AVF, or the inferior leads. Sometimes very difficult. It's only 1 millimeter or 2 millimeter ST elevations are seen. But also don't miss the reciprocal changes in AVL. You can see whenever there is a STEMI, there has to be some reciprocal changes as well. Sometimes reciprocal changes are more prominent than the ST elevations, and you try to treat them as non-STEMIs. And lastly, the electrolyte imbalances. Out of the electrolytes, you can see ECG changes in hypokalemia and hyperkalemia, hypocalcemia and hypercalcemia, and also hypomagnesemia and hypermagnesemia. Those are the 3 electrolytes that can change, and depending on the severeness of the electrolyte abnormality, the ECGs change. Now, most important thing to not to miss is the hyperkalemia. Now, this is a ECG of hyperkalemia. You might suddenly see this ECG, and don't miss hyperkalemia, especially in patients, heart failure patients who are on spironolactone and other potassium-sparing medications, and also patients with chronic kidney disease. They can come like this, and if you don't pick it at this stage and treat adequately, patient might go into asystole. Thank you very much. I'm sorry I had to rush the last few ECGs because I had to finish earlier, at least 15 minutes earlier than the scheduled time. But I mean, I wish you all the best, and start liking ECGs, start collecting ECGs, and when you learn this little by little, you will be a master one day. Thank you very much.
Right, thank you, sir. You can take on the few minutes if you want to.
Now that I have finished, I can't go back. But if anyone has a question, I can answer.
Yes, we can take that time to answer questions.
If you can't, if you couldn't understand something that because I had to rush, I can go back and explain. Anyone?
Yes.
Yeah. Okay, but I don't think there are questions. I wish you all the best again. Thank you very much.
Thank you very much, sir. That's Professor Nama Vijay Singh, Professor in Medicine in Kotalawala Academy. Right. Next up is we go to the last lecture for today. That's by Pearls of Maternal Health by Dr. Indika Boteju, consultant physician at Chilau. Over to you, sir.
I'm at Castle Street Hospital for Women.
I'm sorry, Castle Street.
Yes. And can you make me the host, Roshan?
Made you co-host, sir.
All right. Okay. Shall I share my screen?
Yes, sir. Yes.
Can you see the screen, Roshan?
Yes, I can see. You can start.
Yeah. Is it working now?
Yep, it's moving, sir.
Moving, no? Yeah, okay. Hi, good afternoon to you all. We welcome you all for the program, and we actually congratulate for your new career. And now at the last, as the last unit, we will discuss about pearls in maternal medicine and care in maternal medicine. Anyway, you will be one day mother or father, so anyway, it's very useful to know these facts for your life even, right? For your family and friends also, right? Right, so we will discuss about hyperemesis gravidarum and then hyperglycemia in pregnancy, then moving into hypertension in pregnancy and liver disease in pregnancy, and a little bit about cardiac disease in pregnancy and dengue in pregnancy and the COVID-19 at last. So regarding hyperemesis gravidarum, during pregnancy we have to, there are two terms with regard to nausea and vomiting. That is, one thing is nausea and vomiting of pregnancy, which occurs in the first trimester, right? That is a usual thing, a physiological phenomenon, and it is defined as onset in the first trimester without other reason for nausea and vomiting of pregnancy. And then there's hyperemesis gravidarum, which is defined as having nausea and vomiting in pregnancy with the triad of having more than 5% pre-pregnancy weight loss, or having evidence of dehydration and having with electrolyte imbalance. So when those three are there, we categorize these mothers as having hyperemesis gravidarum, right? And other differential diagnosis for nausea and vomiting has to be entertained during this period in mothers. Usually they can have UTI, pyelonephritis, cholecystitis, and even severe gastroesophageal reflux disease causing nausea and vomiting. So we any other sepsis, even dengue. So we have to make sure that these patients are purely having either nausea and vomiting of pregnancy or hyperemesis gravidarum, right? So otherwise we will miss the important other diagnosis. My slides are not moving. Yeah. So we assess these patients nausea and vomiting using pregnancy unique quantification of MEC score. And if the score is less than 7, we say it is mild nausea and vomiting of pregnancy. If the score is 7 to 13, it is moderate. And if the score is more than 13, it is severe nausea and vomiting in pregnancy. Now, please note that to admit these patients with nausea and vomiting, the PUQE score has to be a severe, that is score should be more than 13. Or else the patient should have features of hyperemesis gravidarum, and then we have to admit these patients to investigate other causes as well. For these patients, first line treatment is prochlorperazine, which is Stemetil, or promethazine, Penagan. And the second line, as the second line, you can use metoclopramide, domperidone, or ondansetron. As the third line, if the patient is not responding to those medications, then you can use hydrocortisone or prednisolone under consultant's guidance only. Make sure to correct hydration and to correct electrolyte imbalance and monitor their blood sugar levels. They can have hypoglycemia time to time. And please make sure to monitor urine output to prevent, we have to prevent acute kidney injury as well, and monitor the vital functions while they are in the ward. We can give IV or oral thiamine to all women admitted with prolonged vomiting to prevent Wernicke's encephalopathy. So what are the things we should not do? So don't give any iron containing preparations during this period, which will increase more nausea and vomiting. And please don't give diazepam in the first trimester for these patients. Sometimes mothers are asking for sedation, so don't sedate them with diazepam. And please don't use phenothiazines and metoclopramide if there is a previous history of drug-induced extrapyramidal symptoms or kilographic crisis. Without thiamine, please don't start dextrose drips for these patients. And previously, some schools, they were using hypnotic therapies for nausea and vomiting and hyperemesis gravidarum during pregnancy. But nowadays, guidelines do not recommend using hypnotic therapies for this problem. Then what are the things we should do? We have discussed previously, and then we will discuss about hyperglycemia in pregnancy. So what are the things we should know in hyperglycemia in pregnancy? There are three types mainly, that is gestational diabetes mellitus, and type 1 diabetes and type 2 diabetes. So the type 1 diabetes and type 2 diabetes women can get pregnant and they go into pregnancy. That is pre-existing diabetes in pregnancy. And GDM is gestational diabetes, which is occurring after the first 3 months. of pregnancy, first trimester after 12 weeks. So pregnancy is a diabetogenic state, and most of the placental hormones, they are diabetogenic, and the mother will have problems or difficulty in carbohydrate metabolism. And please note that the pre-existing diabetes is a risk factor for preeclampsia. Preeclampsia is a disastrous condition for pregnancy, and it can cause even maternal deaths. So if the patient is having pre-existing diabetes, she is more likely to have preeclampsia. So we have to be careful. All women who do not have any history of pre-existing diabetes, they have to undergo a 75-gram oral glucose tolerance test at 12 weeks of period of gestation, that is 12 or after 12 weeks, as a screening test. We are monitoring their blood sugar levels using blood sugar series, which is called BSS. Right, in blood sugar series, we take their fasting blood sugar and then blood sugar 2 hours, 2 hour value after 2 hours of main meals, that is post breakfast, post lunch, and post dinner. We take their blood sugar values and we have targets of managing them. So we will discuss those while we go on. And blood sugar control targets are different in these mothers compared to non-pregnant women. So the targets are usually low compared to the normal woman. And metformin is the only oral hypoglycemic recommended in pregnancy. So except metformin, please don't use any other oral hypoglycemic medications during pregnancy, or if the patient is, if a woman is willing to become pregnant. We can start metformin or insulin as the first line therapy, but the guidelines usually support starting insulin in gestational diabetes mellitus. But if the blood sugar values are marginally elevated, and if the patient is refusing to have insulin, always you can try first metformin, and if we can't control them adequately with metformin, then you can start on insulin as well. So these are the blood sugar values which I was talking about. So the fasting blood sugar, usually we take 126 for normal population, but in pregnancy we take it as 95. So our target value is 95, keeping the blood sugar values less than 95 fasting blood sugar value of a mother if the mother is pregnant. And after meals, PPBS value less than 120 after 2 hours of breakfast, and after 2 hours of lunch, after 2 hours of dinner. But if the patient is, if the mother is having pregnancy complications like polyhydramnios or fetal macrosomias, then we will keep their postprandial blood sugar less than 100, after breakfast less than 100, after lunch less than 100, and after dinner less than 100. So keep that in mind. So once you do the OGTT test, if the mother's blood sugar is more than 126 and the first hour OGTT value is more than 180 and the 2 hour value also more than 180, that means she is having severe degree of carbohydrate metabolism problem. So then we will have to start insulin straight away in these patients with diet control and medical nutrition therapy. If the patient's blood sugar is 100 to 125 with OGTT value, 2 hour value varying between 140 to 179, then we can try metformin first, depending on the patient's choice. But if the patient is willing to start insulin, you can start small dose of insulin. We will discuss how we start insulin later on. And if the patient's fasting blood sugar is between 92 to 99, and if the 2 hour OGTT value is varying between 120 to 139, now you can see now the 2 hour OGTT value is normal, but the fasting is only 92 to 99. Still, we take it as gestational diabetes mellitus, and poor carbohydrate handling of the mother. So we can start on non-pharmacological management alone with diet and exercise. Mainly exercises means maybe walking for about 1 hour after each meal. So we can start that without metformin or insulin for those mothers. Right now, in hyperglycemia in pregnancy, how do we decide on insulin? So the insulin, usual method of giving insulin is recommended in guidelines to give basal bolus regime, which is we give pre-meal, that is before meals, short-acting insulin 3 times per day before each main meal, and then we give basal insulin at night, long-acting insulin before going to bed. Usually we give isopen insulin at 10 p.m. and then we give soluble insulin 3 times per day before each main meal. So that is basal bolus regime which is recommended. But however, some patients with existing diabetes type 1 or type 2, they are on premix insulin. But we try to convert them to basal bolus regime because it will give a good blood sugar control. However, sometimes the mothers, they are willing to continue their old previous regime. So we allow them to go with that. But if the control is getting poor and not under control, then we will ask them to start on basal bolus regime. Yeah. So hyperglycemia in pregnancy, what you should do. If the patient is having pre-existing diabetes, almost always we have to start aspirin 150 milligram at night for patients with pre-existing diabetes from 12 weeks of period of gestation. This is to prevent preeclampsia in these mothers. And we have to start lifestyle modifications and medical nutrition therapy, which is proper diet control, as well as usually we ask them to have a brisk walking 1 hour after each of their main meals. Then patients having type 1 and type 2 diabetes, patients need to screen for other diabetes related complications, especially there can be diabetic retinopathy, where we have to screen them for the diabetic retinopathy in these patients. In pregnancy, it can become more complicated. And we have to ask them to maintain a good blood sugar control throughout and during delivery. So we have to monitor these patients closely for proper blood sugar control and give insulin as required. And especially for patients having gestational diabetes mellitus, we can stop or even we can reduce medications who are having pre-existing diabetes after delivery. So after delivery, usually the mother's insulin requirement goes down. So if they are not on high doses of insulin, we can stop insulin and monitor this patient and see. My slide is not moving here. Yeah. And during this period, what you should not do is don't give any oral hypoglycemic drugs except metformin in pre-pregnancy, because they should get pregnant while they are on either metformin or insulin. Other drugs are teratogenic. And do not use HbA1c for blood sugar monitoring after 12 weeks of period of gestation, because they have hemodilution and their hemoglobin level is low, and the HbA1c level could be falsely low in these patients after 12 weeks. So do not allow blood sugar targets to fall below 80 because to prevent fetal hypoglycemia, because fetal also should have sugar for its survival. And please do not continue doing blood sugar series after delivery, which will be not necessary after delivery. The patient is like a normal woman with diabetes. So just a fasting blood sugar and postprandial blood sugar after lunch would be enough. Not the whole BSS is required in these patients. And do not start oral hypoglycemics except metformin during breastfeeding period. So in breastfeeding period also, if the blood sugar is not under control only with metformin, we have no other choice. We have to start on insulin, but no other oral hypoglycemics can be used during breastfeeding period. Right, now we will discuss about hypertension in pregnancy. So there are several types of hypertension. If a mother is having hypertension, it can be chronic hypertension where the mother must have had high blood pressure before conception, and she is progressing to pregnancy with the chronic hypertension. Then there can be pregnancy-induced hypertension where the mother's blood pressure may be detected after 20 weeks of period of gestation and without albuminuria. And the preeclampsia is the most severe and dangerous form of hypertension during pregnancy, which causes albuminuria and hypertension as well after 20 weeks of period of gestation. And some patients who are having chronic hypertension who get pregnant and later on their pregnancy, it may be in second trimester or third trimester, they can have preeclampsia superimposing on chronic hypertension, where they develop preeclampsia while the patient is on controlled hypertension. And then preeclampsia can give rise to eclampsia, which is literally means fits due to preeclampsia. So the blood pressure targets for diagnosing of hypertension during pregnancy is 140/90. If the mother's blood pressure more than 140/90, either systole or diastole, in 2 occasions we diagnose it as hypertension in pregnancy, and then we will decide on which category it's fall into, whether it is chronic hypertension or PIH or preeclampsia, depending on the presence of albuminuria and the duration of the pregnancy. And for control, our control targets are less than 130/85 that is the upper limit, and the lower limit is 110/70. So we have to keep the systolic blood pressure between 110 to 130, and the diastolic blood pressure between 70 to 85. So antihypertensive drugs used in pregnancy, not all drugs we can use, only dihydropyridine calcium channel blockers, which is nifedipine and amlodipine, we can use, and labetalol we can use, commonly we are using, and methyl dopa can be used, and hydralazine and GTN. And other AC inhibitors, angiotensin receptor blockers, they are contraindicated in pregnancy, and other beta blockers better to avoid. And prazosin, if we can't control them with these medications, depending on the mother's life and the severity of the hypertension, you can use. For these mothers also, we have to start aspirin 75 mg daily for chronic hypertension from 12 weeks of period of gestation. That is, if the patient is having chronic hypertension and going into pregnancy, so there's a high chance that she can develop preeclampsia superimposing on chronic hypertension. To prevent such happening, we start aspirin 75 mg at night after 12 weeks of period of gestation. Slide is not moving. Okay. Right now, we have to start once you diagnose hypertension in pregnancy in a pregnant patient, a pregnant woman or mother. So you have to start treatment with the senior advice only. Don't try to start medication on your own, because we have to think about the required medication and the route and other things, whether the patient is having features of pre-eclamptic toxemia as well. So what are the features of pre-eclamptic toxemia? The patient can have headache, blurring of vision, double vision, or sometimes numbness, hemiplegia even, if the patient becomes getting ICH. And then there can be nausea, vomiting, and right hypochondrial pain, drowsiness, and sometimes chest pain, shortness of breath, bloated out sometimes, and some patients rarely they can have reduced urine output also. So though if the patient is having those pre-eclamptic features with albuminuria and high blood pressure, it is an emergency situation, a medical emergency in a pregnant mother. So if the patient has PET symptoms with elevated blood pressure, we have to start IV therapy and get the blood pressure to the target level, which we discussed earlier. Then if the blood pressure is more than 180 by 110, even without PET symptoms, better to start IV therapy and get the blood pressure to the target level. And if the blood pressure is in between 140/90 to 179 by 110 without PET symptoms, we can start oral therapy and see the response, and we can continue the oral therapy if the blood pressure is getting under control with our desired target. My slide is not moving, Roshan. Yeah. So now, what are the drugs, intravenous drugs used in hypertension in pregnancy? Mainly we use IV labetalol and IV hydralazine if we happen to start IV medication on these patients. So IV labetalol we can use 20 to 50 milligram bolus given in 2 minutes, and we can repeat it in every 10 minutes. Up to 4 times we can give a maximum of 200 milligrams. If we can't manage with that, even we can go for a IV labetalol maintenance infusion, 20 milligram to start with 20 milligram per hour, and we can go up to 160 milligram per hour every 30 minutes. We can increase the rate until it is up to 160 milligram per hour. So maximum effect would occur in 5 minutes time after giving labetalol. The main adverse effects are bradycardia, hypotension, and preteral bradycardia and bronchospasm in the mother. So if the patient is having history of bronchospasm or asthma or acute bronchospasm, labetalol cannot be used. It is contraindicated. So in those patients, the drug of choice is hydralazine, where we can give 5 to 10 milligram bolus initially over 2 minutes. And if the blood pressure is not coming down, we can use another dose to a maximum of 20 milligram. And if it is not controlled with bolus doses, then you can start a IV maintenance infusion, 2 to 3 milligram per hour. And mainly it contains a few side effects, including flushing, headache, nausea, and there can be drastic hypotension and tachycardia and SLE-like syndromes. And if the patient is having PET symptoms, pre-eclamptic toxemic symptoms, you can start IV magnesium sulfate bolus 4 gram followed by 1 gram per hour infusion, right? And then we have to look for other secondary causes of hypertension. Could be kidney disease, could be renal artery stenosis, could be pheochromocytoma. So make sure that we look for secondary causes also, these mothers, because this is kind of a young hypertension. If a patient develops hypertension in pregnancy, especially in chronic hypertension, and need close monitoring in the presence of severe hypertension and PET symptoms for these patients. And we have to decide on whether to deliver or not, depending on their severity and presence of albuminuria, as well as involvement of other organs with PET symptoms. Then what you should not do is that we should not give AC inhibitors or angiotensin receptor blockers or diuretics for chronic hypertension in pregnancy, because if a mother with chronic hypertension, if a woman with chronic hypertension is expecting for a baby or pregnancy, then we have to take out all the AC inhibitors, ARBs, diuretics out of them, because they are teratogenic. And do not start beta blockers other than labetalol during pregnancy, unless there's indicated for unless other beta blockers are indicated, like sometimes we use bisoprolol for heart failure. So depending on mother's life, so then of course we can use, otherwise please stick to labetalol when you use beta blockers on this patient. And do not use diazepam to treat eclamptic fits. It is not indicated and can cause harm. Always use IV magnesium sulfate for eclamptic fits. Do not use angiotensin receptor blockers, thiazides and thiazide-like diuretics during breastfeeding as well. During breastfeeding, AC inhibitors are allowed, and it is recommended, and it is in guidelines. So you can safely use add AC inhibitors to the list we have discussed before, and you can replace labetalol with other beta blockers during breastfeeding, like carvedilol or atenolol. Okay, now we will discuss about liver disease in pregnancy. This is not uncommon. We find mothers with intrahepatic cholestasis in pregnancy. They start with itching of palms and soles, and generally having itching, generalized itching later on, and starts after about 20 weeks of pregnancy. When these mothers actually intrahepatic cholestasis does not affect the mother's life much, but it can cause intrauterine deaths for the fetus. So that is the problem in these patients. And these patients liver functions SGOT-PT can go up later on, and the serum bile acids will be high. And if it is going up and up, we have to identify these patients, and we have to treat these patients, and we have to time the delivery at the right time. Then there can be acute fatty liver of pregnancy, diagnosed using Swansea criteria, and where those patients bilirubin level will be high, and all of a sudden after second trimester or at the early third trimester or late third trimester, they will complaining of a nausea, vomiting with jaundice. So please be please note that we have to do liver functions for these patients, serum bilirubin, SGOT-PT at least, and then you will detect the problem. Because most of the times we delay these mothers by acute fatty liver pregnancy very late. Then you have HELP syndrome, diagnosed using Tennessee or Mississippi HELP diagnosis criteria, and please read these criteria when you go home. And there can be chronic hepatitis B and C infectious patients who are getting pregnant. Then we have seen patients with acute hepatitis also coming with pregnancy, and there can be autoimmune liver disease patients becoming pregnant, or else they develop autoimmune liver diseases while they are pregnant with elevated liver enzymes, and then they can have autoimmune profile indicating autoimmune liver diseases. We have had several mothers with cirrhosis, some mothers with portal hypertension, and some mothers with without portal hypertension. So it is not uncommon. I would say it's rare. Then what are the things we should do for the mothers with liver disease in pregnancy? So early delivery at or before 37 weeks is recommended in intrahepatic cholestasis in pregnancy. And acute fatty liver in pregnancy and HELP syndrome, for those patients, we recommend delivery as soon as possible to prevent maternal deaths and to save the mother's life, irrespective of the baby's life. So we have to stabilize the patient first in acute fatty liver and pregnancy and HELP syndrome, and then do the delivery. Then for the delivery, if we are going to do lower segmental cesarean section, the platelet count should be more than 50,000. Make sure to transfuse and keep the platelet ready. And for epidural analgesia and anesthesia, we require about platelet count more than 80,000. And please watch for hypoglycemia in these patients, because the liver disease is well known to cause hypoglycemia and cause harm to fetus as well as to the mother. So what are the things we should not do for mothers having liver disease in pregnancy? So do not give any hepatotoxic drugs. Go through the drug chart and see whether we are giving any hepatotoxic drugs. Remove them. Maybe paracetamol, regular doses. So be mindful. And do not give IM injections if platelet count is low or the INR is high, because they can have unnecessary hematomas with IM injections. And do not overhydrate with normal saline. Anyway, their fluid level would be high in the liver disease. Hydration would be, should be to the adequate level only, not more than that. So normal saline would contain more sodium, which will increase retention of water in these patients. So do not give normal saline unless otherwise indicated. Do not give excess salt, and please don't allow them to get constipated also, because it can lead to liver failure and hepatic encephalopathy. Now, cardiac diseases in pregnancy, there are few conditions where we cannot allow mothers to get pregnant if her heart is not going to sustain, withstand with pregnancy. So there are few conditions of those. So if you or if you know your patients or your friends or your family or someone is having, a woman is having these conditions, please don't allow them to get pregnant. Give some contraceptive method unless the cardiac condition is corrected or properly addressed. So what are those conditions for contraindications cardiac for pregnancy in cardiac diseases? So if the patient is having pulmonary artery hypertension, there is one contraindication. And then if the patient is having severe systemic ventricular dysfunction with ejection fraction less than 30%, and history of previous peripartum cardiomyopathy with left ventricular impairment, and if the patient is having severe mitral stenosis or aortic stenosis or right ventricle with reduced right ventricle, systemic right ventricle with reduced ventricular function, and if the patient's aorta is dilated, if it is more than 45 millimeters with Marfan's, more than 50 millimeters in bicuspid aortic valve, and if more than 15 retrograde fallets. And if the patient is having features of vascular Ehlers-Danlos loss, and then severe recoarctation, or if the patient has had previous cardiac surgery with complications, please get them to assess by the cardiologist and to see whether the pregnancy can be progressed in her before they get pregnant. In addition, patients with congenital heart disease, prosthetic heart valves, acquired heart disease, and peripartum cardiomyopathy, they can come pregnant again. And so those patients go through the history very carefully, ask for chest pain, shortness of breath, palpitations, sweating, lethargy, weakness, and there can be non-specific symptoms. So go through the history very carefully and detect whether if there's any cardiac involvement. Please have a low threshold to do 2D echocardiogram and to do a cardiac referral for these patients before they progress into severe complications. Now, dengue in pregnancy. I know that you were taught about dengue, but there are unique features in pregnancy who are having dengue infection also. Now, suppose if a patient just after delivery develop fever, so most of the time you would think that this is infection, because just after delivery your patient's white cell count will be high and the CRP will be high, and there's fever, and there will be a few pus cells in the urine also. So it's maybe UTI kind of a picture. But mind you that this is a normal phenomenon, right? So what the fever could be due to dengue, because sometimes these mothers they are in the ward setup for about 2-3 days, and our hospital setup is kind of a thing that they will provide all the mosquitoes, dengue mosquitoes, to the ward. So we have had several mothers like this. So don't miss to do a dengue antigen, even if the patient's clinical picture resembles a septic bacterial infection, right? And be careful about hematocrit in these mothers if the patient is in early pregnancy or late pregnancy. Before delivery, they have hemodilution. So their hematocrit is around 27, 28, 29, that area, right? Because of the hemodilution. So if that patient, if a patient is having basal hematocrit level of 28, develops hematocrit of 34, her hematocrit is increased more than 20%. So you might think that 34% hematocrit is unlikely with the leaking phase of dengue. So we have to see the trend of her hematocrit from the baseline from the beginning. But unfortunately, sometimes the baseline hematocrit we do not have, because pregnancy is a normal phenomenon, and when they come into delivery, we don't do a full blood count in each and every mother. And timing of leaking in dengue hemorrhagic fever during pregnancy is also a bit tricky, because with the gravid uterus, we find it difficult to do the scans and find leaking phase and fluid in the pleural cavity as well as hepatorenal pouch. Then in dengue hemorrhagic fever, actually during leaking phase, we tend to delay the delivery. So we try to, as much as possible, not to do the delivery during the leaking phase. But unfortunately, there can be compelling indications, like during hemorrhagic leaking phase, they develop preeclampsia. So for preeclampsia, we have to deliver the baby as soon as possible. But in dengue hemorrhagic leaking phase, we should delay. So what to do? So those conditions are there. So we have to balance them very carefully and do either the delivery or manage the leaking phase. Then there's ovarian hyperstimulation syndrome, you might know, where you can have pleural effusions and ascites and fluid leaking stage due to immune reaction. This is actually in the following assisted fertility care, and which can resemble dengue leaking as well. And dengue leaking, patient having dengue also can resemble ovarian hyperstimulation syndrome, because both conditions have a leaking picture, intravascular extravasation of fluids. So be careful about ovarian hyperstimulation syndrome and dengue looks like overlap. Then a little bit about COVID-19 in pregnancy. The normal woman has the same infection risk as a pregnant woman, and about 2/3 of pregnant women have no symptoms at all when they get COVID, and most of the patients who are symptomatic also they show less symptoms compared to non-pregnant women. However, the pregnant women is at high risk of developing complications with COVID-19. And the risk of being on ventilator and ICU care is high. However, now with the proper immunization, we find it very less number of patients going into severe complications, so which is very good. And in Castle Street, we keep all these mothers with COVID-19. They are having just mild symptoms, not even moderate symptoms. So these mild patients with mild COVID-19 symptoms, we keep those mothers in the ward, isolated, and we keep at least for 5 days. And then we monitor their saturation, and we give symptomatic treatment. And most of them, we can discharge after 5 days if the especially if the CRP and other blood immunization are also normal. But be mindful that you have, before discharge, we have to see the electrolytes, CRP, and full blood count as well. So that brings my talk to the end. So we wish you all the best for your new career. And over to you, Roshan. Roshan. Yeah, there's a question asked when to stop aspirin after starting at 12 weeks. Usually they say you can continue up to 36 weeks and stop after 36 weeks. But after that, after 36 weeks, there's no evidence to support. But usually we continue up to the term and then stop it. Any other problems? Any other questions, please? Yeah, there's another question asked during dengue. If the patient is hypertensive, do we give magnesium sulfate if develop eclampsia? Yes. So even in dengue, during dengue, even in fever or febrile phase, if the patient is having eclampsia due to preeclampsia, then we can give IV magnesium sulfate. There's no contraindication. Any other problems? We have about 10 minutes, I think. In APLS diagnosed patients, when should start aspirin? Yeah, so if the patient is having APLS, usually we start Leptospirosis. Aspirin is usually, if it is just compelling indication for other reasons. If the patient is having hypertension, we will have a multidisciplinary team meeting and then decide on starting on aspirin to prevent preeclampsia because the patient is already on enoxaparin. To these APLS patients, once they are pregnant, usually they have a history of miscarriage, multiple miscarriages usually. So we start on enoxaparin to prevent the, to keep the placental blood flow intact. So because of that, aspirin is used when there's any cardiac or severe hypertensive urgency kind of a thing. Otherwise, we continue with enoxaparin on these patients. Yes, there's another question. Do we use methyl dopa for chronic hypertension because it causes postpartum depression? Yes. Now, earlier, actually, recommendation was if the patient is having chronic hypertension. Now, suppose if the patient is on ARB or AC inhibitor, then if the patient is willing for a pregnancy, then we change to methyl dopa and let her become pregnant. So that was the early teaching and earlier practice. Now what we do is we change the ARB or AC inhibitor to a non-dihydropyridine calcium channel blocker. Could be nifedipine or amlodipine, and then we allow her to become pregnant, right? And while on calcium channel blocker, if the patient is still the blood pressure is high, then we practice to start on methyl dopa if the patient is not having for chronic hypertension, not having features of preeclampsia or pregnancy induced hypertension, that is before 20 weeks and without albuminuria, right? So those patients, we can add methyl dopa to the calcium channel blocker, right? And if that is also not under control, then we can go and add labetalol. And if the patient is developing preeclampsia with proteinuria and hypertension, uncontrolled hypertension after 20 weeks, then drug of choice is labetalol to add on to the nifedipine. But methyl dopa still we can use up to the delivery time, and just after delivery we have to stop methyl dopa because they can develop postpartum depression with methyl dopa. So that is the way we manage, and that is the recommendation given at the moment by the guidelines. Okay, then I will stop share. So Roshan will come and talk to you. So all the best and good luck for your future careers. And I think you will have a best ever, intern training here in Sri Lanka. So we have worked in foreign countries, but they are not getting, much exposure as we get in here in internship. So all the best, right? Okay.
Okay, thank you, sir.